Government of India. We also had two extremely interesting sessions and well-received sessions along with Honorary Brigadier Dr. Arvind Lal and Dr. Alok Roy. And the day ended with a chat on mental health concerns post the pandemic. We would also like to share with you that we had about 800 plus delegates from 35 countries on a virtual platform yesterday. And many people also viewed the conference on our YouTube link. Today, we have another interesting lineup of sessions for you all, starting with health delivery, balancing COVID and non-COVID, followed by the future hospital, and a fireside chat on health insurance of India. Then post-lunch, we have sessions on COVID vaccination, digital health technologies, where we will be joined by Dr. R.S. Sharma, the CEO of NHA. And we will end the day with most awaited session, a chat on politics. Politics at COVID experience so far. I now call upon Mr. Gautam Khanna, co-chair for FICCI Health Services Committee and CEO of PT Hinduja Hospital, MRC. He's also a managing committee member of a degree college in Mumbai. Mr. Khanna is an experienced business leader and has a rich experience of more than 51 years of successfully managing diverse businesses and creating sustainable shareholder value in domestic and internationally challenging environments. Mr. Khanna has been working very closely with FICCI for many years, earlier with the Medical Devices Forum, and now with the Health Services Committee. He has convened the thought leadership session on healthcare delivery, balancing COVID and non-COVID care. I request Mr. Khanna to take over, please. Thank you.
Thank you, Shilpa, and good morning to everybody. And, this is an important topic of discussion today, and I'm very happy to have very eminent panelists with me. Last year when COVID hit us, what it exposed to the world is the inadequacy of the healthcare infrastructure across the world and of course in India. And that also exposed that at a point when people were worried about COVID, what happened to the patients who needed treatment for non-COVID diseases. And there was a mismatch and there was a fine balance which many hospitals had to undergo, how to take care of their non-COVID patients. And it was very challenging because the infrastructure in many hospitals were created separately for COVID, but in some hospitals, the full hospital was converted for COVID. So there was no place for non-COVID. And also with the lockdown, with just the fear factor amongst the patients in the society, there is, and all kinds of concerns about traveling, it was a big concern for the hospitals. And apart from hospital not being able to give patient care, it also resulted in a major financial loss to the hospitals during the COVID time. So, and also what we saw, a good thing is that the technology upgradation happened rapidly. And what we've been trying for many, many years got done within a few months. And examples of teleconsultation and remote monitoring and sensor-based monitoring and so on. And we will hear more about it from the panel. So I think this is a learning which we all had in the last year or so, 1.5 years. And hopefully this has made us ready for any other pandemic where we have to balance COVID or equivalent infectious disease with a non-COVID treatment. So I would now like to introduce my panel, and it's a very esteemed panel. So what we will do is I'm going to ask a few questions to the panelists and hear their thoughts on what they have done and what they propose doing it. And then we will open it up for questions from the audience. So let me first welcome, as I see on my screen, is Dr. Ravi Trehan. So Dr. Ravi Trehan is the Medical Director, Admission and Transfer Center and Physician Referral Office, Consultant Orthopedic Surgeon from Sheikh Shahabud Medical City, Abu Dhabi, and Associate Professor Orthopedics, Gulf Medical University, Ajman, UAE. Dr. Trehan is a UK-trained orthopedic consultant with 25 years of experience, specializing in arthroscopy, arthroplasty, and trauma surgery. He has completed several fellowships in the UK, Germany, and Austria. He's authored or co-authored numerous international publications, and recently he has been involved in publishing on COVID. He has collaborated with international authors and one of those 3 publications has been awarded Guinness World Record for the most authors on a single peer-reviewed academic paper. Dr. Trehan is a keen educator and completed postgraduate qualification in medical education from prestigious Cambridge University. Currently, he is an adjunct associate professor at Khalifa University, Abu Dhabi, and Gulf Medical University, Ajman. He's an examiner for the Royal College of England and has extensive experience as an advanced trauma life support instructor. A strong advocate of continuous professional development, Dr. Trehan gained a master's degree in international healthcare management and leadership at the Manchester Business School. Currently, he's the medical director of Admission and Transfer Center at Sheikh Shahabud Medical City in partnership with Mayo Clinic USA, and it's a flagship hospital of Abu Dhabi Health Services in UAE. Dr. Trehan, welcome. Next, I'm happy to introduce Dr. Vikram Shah. Dr. Vikram Shah is the CMD of Shalby Hospitals. He is an Indian orthopedic surgeon by profession. He established Shalby Hospitals in 1994, which is an Indian organization established in Ahmedabad as a joint replacement center. Shalby runs a chain of hospitals in Ahmedabad, Surat, Indore, Vapi, Jabalpur, Jaipur, and Mohali. After completion of his MBBS and MS orthopedics in Ahmedabad, he has worked and trained at Ormskirk Hospital and Wrightington Hospital, UK for 2.5 years, and later worked in the USA. On his return to India, he began surgical practice by establishing Shalby Hospital and Research Center in Ahmedabad in 1994. He has developed the OS needle, orthopedic surgeon's needle, which can pass through both bone and soft tissues easily so that an orthopedic surgeon can finish repairing bone and soft tissues quickly. It is claimed that his invention has greatly reduced the surgical time in orthopedic surgeries. By the year 2000, out of 17 to 20,000 surgeries carried in India every year, 16 to 17% were conducted by Dr. Shah. He has achieved a world record by performing 3,000 knee surgeries in a single center in the year 2008. In 2012, Dr. Shah developed the zero technique for TKR, which he claims has further reduced the operating time to 7 to 10 minutes. Dr. Shah, welcome to the panel. It's my pleasure to invite my friend, Dr. Dharmender Nagar, Managing Director of Paras Hospitals. Dr. Nagar is a doctor, hospital administrator, and an entrepreneur. And he has established super specialty hospitals based on affordability, accessibility, and quality at locations that have no access or scarce availability of specialized healthcare. And we can see behind him, around 8 cities are mentioned. Dr. Nagar has been awarded the Entrepreneur of the Year Award in 2015 at the India Health and Wellness Summit 2015, and Dynamic Healthcare Entrepreneur of the Award in 2015 by Six Sigma Healthcare Awards at the World Entrepreneur Summit. He has an MBBS from Mysore Medical College, MPhil from BITS Pilani, MS from Imperial College, and an executive MBA in healthcare delivery from Harvard Business School. Welcome, Dr. Nagar.
Thank you.
Yeah. My pleasure to invite Mr. Krishnan Akleshwaran. He's the Group CFO of Apollo Hospitals, India. And as you know, Apollo Hospitals is the largest hospital group in the country. Mr. Krishnan serves as a Group CFO, where he's responsible for strategy, financial control, accounting, reporting, corporate finance, capital raising, costing, MIS, and investor relations. He's also a board member at Apollo Health and Lifestyle and Apollo White Dental. Mr. Krishnan has handled diverse areas in finance, ranging from financial and strategic planning, budgeting, controlling, accounting, MIS, auditing, taxation, costing, pricing, M&A, investor relations. Prior to this, he has worked with First Source, Leo Burnett India, and Mahindra Limited. Mr. Krishnan, we are looking forward to a CFO's perspective on what happened. How did you balance last year? So with that introduction of my esteemed panelist, I would straight away like to ask some questions. And I'm going to start with you, Dr. Shah, a question, and maybe Dr. Nagar, you can also answer the same question. So the question is that what were the steps which your hospitals took to address the concern of non-COVID patients during the pandemic? We heard about the COVID patient, and how did you ensure that your premises were safe to visit for the non-COVID patient? Dr. Shah, if you would, please. Dr. Shah, can you hear us? I think Dr. Nagar, can we go with you? I think
Of course.
Signals.
So, I think the steps we took actually proved failure towards the end of the COVID. We all thought that we'll start segregating our patients. We segregated our ER. We created different entrances. We created different floors for different category of patients, COVID, non-COVID. But eventually, I think we all got submerged in the tsunami of COVID. And I think the whole hospitals got converted to COVID. So I don't think we were able to really have a very excellent mechanism of segregating COVID versus non-COVID patients. Essentially started like that, but converted into COVID completely towards the end of the 3 weeks. Second, third week, we were inundated. And I think we just decided that it's better to kind of serve the patients who are in dire need. People were dying. So I don't think there was even an option for us to figure out to keep the COVID and non-COVID business going.
I have a question for you before I go to Dr. Shah. Is that you have your regular patients in and around your hospitals, and your hospitals are very large and serve a large community. And so, what happens to them? What happened to them?
Honestly, except the true emergencies like cardiac and stuff like that, everybody else probably suffered. They kept at home. Nobody came out. Some of the mitigation strategies were to go digital, i.e., we were doing teleconsultations, but I don't think that was truly taking care of the patients. So a lot of planned procedures, a lot of stuff in oncology, a lot of stuff in orthopedics got kind of further moved into, they kept at home. Essentially, they didn't turn up. And neither were we capable of at that time. Honestly speaking, if you ask me that, could we have done both the things simultaneously? We tried, we started, but I don't think we were very, very successful after the second week.
Understand. Dr. Shah, I don't know whether you heard my question. You got logged off at that time. You're on mute now. So let me just repeat the question for you. Is that in the pandemic, what steps were you able to take to address the concerns of non-COVID patients? And how did you ensure your premises were safe to visit for the non-COVID patient? You have to unmute yourself, Dr.
Yeah, I would like to divide these in two parts. One is the part of lockdown, the wave number one. Wave number one was a lockdown and hospitals were virtually empty. So there was no cold work, no other work, and number of patients of COVID also were very less, and they started coming in later part of the first wave. So hospitals were almost closed, and they were working at 10 to 15% of occupancy. As far as the fear factor was so much that number of patients died of heart attack at home, and they were not ready to come to hospital, and they were being given different type of ukalas and different type of steam therapies because of chest pain that corona has come. People used to keep windows also closed. So that was a first wave. Second wave, the way it came, all hospitals were instantly full and there were no beds. So there was no question of doing other work at all. And as far as, planned surgeries like joint replacement and all those planned surgeries, people were not even thinking about it. Having said this, two places where one is cardiac and the second is onco, where some of the patients were turning up to get their things sorted out and their radiation therapy. So we were able to create certain type of discretion, different entries, different exits, but still that amount of that kind of work was not even 5%. I would say during second wave, it was all hospitals of ours were nearly full of COVID patients.
So Dr. Shah, I have a follow-up question to this. That if they were full and you probably had common radiology facilities, common ultrasound, X-rays, and so on. And so some of them would be having to deal with COVID patients and non-COVID patients. So did you have any challenges in managing common equipments, common people, anything?
See, we on most of our hospitals, we have two X-ray machines. So X-ray machines were separated out. We were not requiring MRI for COVID patients. We were requiring CT scan. So CT scan was reserved for only COVID patients. So something like that, we actually planned internally and then were working accordingly. And only emergency patient of other than COVID were being taken, and not cold work was being promoted or done.
So thank you, Dr. Shah. I'm going to come to Mr. Krishnan. So Mr. Krishnan, you heard Dr. Nagar and Dr. Shah. So in Dr. Nagar's case and Dr. Shah's case, most of the hospital was full of COVID patients. And you being the CFO, you know that in many places you had to keep hospitals open for non-COVID also because there were some patients requiring non-COVID treatment. How, as a CFO or as a group, what was your strategy? What was your advice on balancing it? Because it was a huge financial drain on the hospitals. So any views on that?
Good point. I think, obviously there were also, there was a lot of costs involved across the hospital for one. But, as a team, we had come together. There was already a discussion which we had at the leadership level and decided that this is something that we will have to face as an industry and as a unit or as a hospital, to say that, cost is going to take a backstage. That was a decision which was already consciously taken. The cost is not going to be a focus area now, especially for us to, whatever is required to ensure. See, it was very anxious times. There was anxiety all around, right? There was anxiety at the government level. There was anxiety at the public level. There was anxiety at the workforce level. So clearly, during these anxious times, we decided that, we are going to be incurring some costs which are higher than normal. It's okay. We are not going to be worried about that. And I guess, finance took a back role. It was not on the front footing at all. I can tell you during those 6-8 months, and even during the second stage, I can tell you finance was really not as important as much as the frontline warriors and the doctors and the nursing staff, because they were facing the brunt day in and day out. And while we decided that non-COVID and COVID are going to be separate streams, and we did what had to be done towards that, the important thing was to ensure that it was visibly different and visibly there was a visible difference on the ground, because as we all know, it's word of the mouth which spreads very fast and very quick in this industry. And also brochures, we were really giving out brochures. We were trying to help people understand how disinfection protocols happen and how a COVID ward is separated from a non-COVID ward, etc. So that is something that we effectively did. We knew that things like oncology had to continue, which did continue for vast majority of the COVID time. Again, baby deliveries, right? Thankfully, at Apollo, in a couple of locations, we have separate hospitals taking care of mother and child and children. And we saw a huge demand for that, because people were really not wanting to go to some of the other nursing homes, etc., because they were worried genuinely about the quality of some of those so I think there has been a shift for quality, which was visible, and people did understand that, with time, that, people like all of us had really put together efforts and protocols to keep COVID and non-COVID separate. So we did what we could, but we all know that, we still could address only 40% or 30% of non-COVID cases. And I guess now it's a different time. I guess people have now come to terms with COVID and non-COVID, and I guess people have understood that COVID is, more an endemic than a pandemic. So I guess, today it's a different thing altogether.
Thank you, Mr. Krishnan. And I have to challenge you on a statement which you made, that finance took a backseat. I think, we know that across the country, the people handling finance were the most important, because you had to have cash to pay salaries, to buy equipments, to just run the hospital. So I know your team did an excellent job. Thank you for that. So I'm going to come to Dr. Trehan. So Dr. Trehan, you heard the perspective from the three major players in India on what they have done. So may I ask you to first tell a little bit about the Abu Dhabi Health Services and what has been this experience and initiatives which you took? Over to you, Dr. Sriya.
Thank you. Thank you very much, Mr. Khanna. I really want to thank you for inviting me to share Abu Dhabi experience and also to learn from the experience from our colleagues in India. It is indeed an honor to be here with this elite panel. Before I start, I want to take 30 seconds actually that I want to appreciate and congratulate every healthcare worker back home in India for doing this exemplary job and a service to humanity. Everyone from the ward boy, we have seen that everybody has been working very hard. Cleaners, nurses, pharmacists, paramedic staff, all the doctors and healthcare managers and the finance like Mr. Akhleshwar have played a very vital role during the first and second waves. And this is an opportunity to pay tribute to the brave hearts and conscientious health workers who have lost their lives while saving others' lives, actually. And once again, I want to congratulate the FICCI Health and your team for this initiative to dedicate the entire conference only on the COVID, which is absolutely vital to learn lessons so that we can move forward with in a better prepared position. Coming to the Abu Dhabi Healthcare Services, Abu Dhabi is the capital of UAE again, and then the Abu Dhabi has a population of about 3 million, with 80% of that is expat, only 20% the local population. Abu Dhabi Healthcare Services, or we call it SAHA here, is responsible for all public hospitals and clinics in the Abu Dhabi. We are the largest healthcare provider in UAE with about 13 hospitals, 46 clinics, and almost 2,700 inpatient beds available to us. We have more than 17,000 staff, of which about 3,500 are doctors. And my hospital where I work right now, Sheikh Shakbout Medical City, SSMC, is the crown jewel of the SAHA or Abu Dhabi Healthcare Services now. We opened only in January 2020, so we shifted one of the hospital into the new building with the new partner. So Mayo Clinic USA was brought in, so it's a joint venture with the Abu Dhabi Healthcare Services and the Mayo Hospital. And from January we started, and end of February we landed up with this pandemic. So it wasn't easy to start with because there were lots of other challenges which we were facing at that time. And all of a sudden, the pandemic was there. So we were not that prepared, but what happened, the national leadership, actually, the Crown Prince himself, had actually sensed this coming. So what they did, they closed a large hospital of SAHA and converted that into an infectious disease hospital. In fact, turning all the rooms there into a negative pressure rooms, sensing something is coming. So fortunately, the entire hospital staff was distributed to the other hospitals. So we had lots of ICU anesthetists and other doctors coming and helping us as a secondment to our hospital. We also managed actually from Mayo Clinic USA as well, because as you know, the USA was hit, but little later than this part of the world. So at that time, Mayo Clinic actually, they had sent a team of 100 physicians and nurses in an operation called Operation Hope to work with us at SSMC in Abu Dhabi. So again, it was a very good initiative, and lots of people we got extra to help us with the COVID and non-COVID situation. In the first part, actually in the first wave, you can see that one of the tower behind me is the third tower. We actually segregated it as a COVID tower, and our floors, quite a few floors, were dedicated only to COVID, but remaining hospital was still working as for the non-COVID patients. And as Mr. Akhilesh said, that the oncology services, many essential services, we just continued. But it was very difficult, as the other panelists said, that the fear factor was so high, patients were not coming in. So it took a lot of effort for us to encourage those serious patients to come. And basically, this balancing the COVID and non-COVID wasn't great, as Dr. Nagar has also said in the first wave, but we did learn our lessons and we were much better prepared for the second wave. And that is how we worked actually. And then we changed, the SAHA changed our hospital as a non-COVID facility actually. So we were completely a non-COVID hospital during the second wave, providing the non-COVID emergency services and even the little elective services to population of the Abu Dhabi.
Thank you, Dr. Chan. Thank you for that perspective. So I am going to come to Dr. Shah again. Dr. Shah, a question. You talked about, the hospitals being full of COVID and non-COVID patients were not coming. But, the biggest challenge at that time was to ensure the morale and the safety of our employees, the healthcare workers. So can I request you to give us some views on what did you do to ensure the safety of the healthcare workers providing care? And I'm going to come to Dr. Nagar with the same question. So Dr. Shah, over to you.
Yeah, well, what had happened, when we started treating COVID patients, the staff were running away and there were a lot of problems to keep the staff back in the hospital. So we had to run a lot of educative program for them that it's not only a responsibility, but it is safe also if we are wearing all required things, if we are taking care of ourselves. And we were keeping them in-house so that, their family is not affected. So, we took out certain rooms and a lot of nursing staff and a lot of doctors were staying within the hospital premises only. That is one thing we did. Second thing, we heavily incentivize them so that they feel that they are being taken care of. The third thing is we came across quite a few papers in initial part of COVID that, and also we saw that in our hospitals that 80% of the patients, 84% to be precise, and we made a paper out of it and we sent it to government of Gujarat also, that 84% of patients were vitamin D deficient, particularly who were requiring hospitalization. So what we did that we were giving good amount of vitamin C, vitamin D and vitamin B complex to all our staff. And we saw to it that their vitamin D comes to normal before they enter the ward. Because vitamin D is very important immune modulator, and patients having very low vitamin D behave differently and their immune system behave differently towards COVID, and they produce immunoglobulins against alveoli. And because of that, what happened that we got our few staff sick, but none require hospitalization. And I'm happily announcing today that we have not lost a single staff during first or second wave of COVID in all our 11 hospitals. So we took care of them and they also took care of patients, but we did not lose a single staff, even not a single staff required ventilator treatment. Few got sick and they were given leave, that's it. That is how we work with them.
Wonderful to hear that. Dr. Nagar, what is your experience on this?
Gautam, I think there's a huge dynamic shift between the first wave and the second wave. Mm-hmm. I think in the first wave, literally everybody was scared, be it staff, doctors. Fortunately, in the first wave, we didn't see too many patients. So that was balanced out. In the second wave, we had completely the opposite feeling. Doctors were right at the forefront, staff was right at the forefront in spite of being inundated. And I will attribute to 2-3 factors. India was lucky that we started our vaccination program in Jan-Feb. And I think all our staff had got vaccinated by March. That psychological shift of getting vaccinated, I think made a huge difference. That confidence that was in the staff was tremendous post-vaccination. Obviously, the experience of the first wave and better preparedness in terms of PPE, not necessarily in terms of the inundation of patients and ventilator shortages and medicine shortages, but still, I felt that the spectrum of staff, be it housekeeping staff to nursing to the doctors, there was huge paradigm shift between first wave and the second wave. And I think vaccination, and today is a great day. We must acknowledge this country's amazing efforts, 100 crore people getting vaccinated. I think this country deserves an applause from the world of what we've achieved.
True, I agree.
What you mentioned. And I'd like to just add to what you and Dr. Shah just mentioned. I give you a little bit perspective from the Mumbai side. Mumbai was really very badly affected in the first wave. And with the trains not being available, lockdown. And so it was very difficult for the staff to come. And in Mumbai, the place, the space is very restricted. So difficult for us to accommodate them in the hospital and so on. But, lots of these things were done. I mean, we had hired schools, we converted our temporary building into residential accommodation. We created isolation centers. And, one of the things which I think really helped, I'm sure all of you have done, many hospitals have done that, was this continuous education and reminding the healthcare workers the reason why they are in healthcare. The reason they are in healthcare is to provide service to the humanity, not to, for any other reason. So that is the primary focus, just to remind them that. And of course, to have, like Dr. Shah said, what you said, to have visible support system, like Dr. Trehan said, it is visible that what you are doing for the safety, like Krishnan mentioned in Apollo, it's visible that non-COVID patients are being segregated, COVID is segregated, what are the precautions we're taking. So I think a lot of it was at the psychological level. And I'm just going to add a little bit that in the first wave, even doctors, nurses, everyone was scared. Everyone was scared. But I have to say this, that everybody came together and delivered the best possible, and I really applaud all of that. So this is just a vision from our side. And people were really concerned, especially in Mumbai, where people live in very small houses, that if somebody comes to the hospital, gets affected, and he goes back home and he has parents, wife, children, so maybe can he infect, or would he infect the other people? Is he putting his family at risk by coming to the hospital? So there's a lot of fear in that, but I'm happy to say that all this was addressed. But I'm going to come to Krishna for you. One question on this. Now, the key thing about this is the people. How many people, and we have seen that for COVID duties, you needed more people because of shorter shift hours, and you have to give the breaks and so on. So how did you manage the manpower allocation between COVID, non-COVID? And what about the doctors? And what about the nurses? What about because were the same doctors treating both COVID, non-COVID? What is your experience of COVID?
So clearly, your point is very valid. In fact, I think manpower handling during COVID time was the most difficult job. I think, by far, whatever it was, managing patients was one perspective, anxious patients was the other. But really, we all knew that, we were very responsible, as Dr. Shah also said, the responsibility of all our institutions towards employees and their well-being had gone up manifold, because we knew that if there was something, if on one side, as you rightly said, we wanted them to serve, we wanted them to remember that, they were here for a duty. The other side, we also found ourselves duty bound to ensure that they were really taken care of well. And I guess, not affected. So 2-3 things was really done on that. One is we had a war room, which was created by, below our president, Dr. Hari Prasad, who's one of the things for Apollo is handling of scale, right? Handling 1, 2, 3 hospitals is one point. Handling 45 hospitals and each one having their different issues on the ground was a completely different point. And at the center, we needed to have a war room. So we had a war room which was managed by 8 members, and these 8 members at the top really were the hotline to call for when there were issues, etc. And they then used to ensure that all of the processes, guidelines, protocols were actually properly given and communicated back to each of the hospitals. Managing was very, very important. So I guess one thing that we have understood with COVID is planning and execution. I guess that's very, very important. I guess as hospitals, we all took it for granted. But I guess, of course, being part of JCI accreditation, etc., at hospitals also helps a long way, right? Because I guess, at least during those times, we are all really well geared to see how we need to respond to crisis. So I guess the crisis management, and I guess this whole thing about what to do when a crisis comes, I guess we are all gone several notches up now on how to plan for a crisis, how to do certain things in a certain time. So I guess the prediction analysis, when you're talking of even people, prediction analysis were very, very important from this war room, because they said there is a spike here. We are seeing there is a spike in the state, there is a spike in certain hospitals. There is there was some method in the spikes. You could see it, right? So we used to really try to predict at least 2 days ahead, if not many days, and say, okay, here's what we need in the next 2 days. Please ensure that you roster properly. So I guess those were very important. Duty medical officers, of course, were very, very, I guess there was a set of duty medical officers for COVID and a set for non-COVID, period. We need to ensure that, they were properly isolated, they were taken care of well, if required, stay at the hospital and take care of them. Disinfection protocols were, of course, had gone up multifold, right? I don't think, we have seen, I think the disinfection protocol for all hospitals went up at least, I think 7x from what we were pre-COVID to post-COVID. So all of that, we tried also multi-skilling of staff. That worked well. When we said multi-skilling, we have seen a lot of paramedics and even admin staff really take on different roles during this time, wearing a different hat, and not something that they would have regularly done in normal times. So we had seen all of that. There was definitely a set of employees who went outside the call of their duty. We rewarded them differently as well, because reward meaning it's not just about monetary, right? You can't do anything on this. Whatever you do monetarily, it's not enough. It's more about acknowledgement and recognizing that they went out of their duties and really recognizing them, which went a long way. So that is all that helped. And as I guess, planning and execution, that's all it matters, I guess, at the end.
Wonderful. Wonderful to hear that. I'm going to come to Dr. Trehat. You mentioned that Operation Hope or Project Hope, you mentioned about 100 people from Mayo.
Yeah.
So a quick question to you, that in a crisis time, 100 people coming from a different city, different culture, different country to a health services system and working together with the existing team. So what was that experience? How was that handled? What are the challenges there? Any thoughts on that?
It's a very valid question, Gautam. Actually, in fact, it was fascinating to see, especially how our colleagues from Mayo US gelled with us so quickly. They were given some time, about a week or 10 days, number one, to understand how healthcare services work in this part of the world, which was very, very different. They were straight away not given the frontline position, because they were again helping to the people from the backside to move our staff to the front line. So that is how it helped. So when we took our staff to this COVID area, designated COVID area, then we did not want a vacuum in the other non-COVID area where these people came and helped. And it was exciting to see that the new staff from Mayo US they were committed. They came with all devotion, and at that time, you remember, there was no vaccine, so there was still a fear factor. Traveling thousands and thousands of miles, coming to another country, it was really commendable, actually. And we, of course, we all appreciated that, including the national leadership. So there was not a big problem there of them gelling. In fact, the outcome was quite a few of them wanted to stay back. Actually, they did not want to because they liked it so much here. They wanted to stay back, which was actually overwhelming to see that.
So thank you. And I think maybe this is just my personal thought. Maybe this is an example that, people from different cities, different countries, different groups of hospitals can go and help each other in times of crisis. So thank you for sharing that. Thank you for sharing that. So I have a question now to Dr. Nagar. So Dharmendra, you mentioned a little bit about teleconsultation. So any thing you want to highlight to us, that what was your experience in teleconsultation? What was the patient's feedback? Anything you want to highlight?
I think teleconsultation was hugely important during the period, but I still feel that there is a huge amount of resistance to teleconsultation. So it's both a boon, yet its acceptance is not that much. What I've seen is that when there was physical access was denied, then teleconsultation was utilized. But effectively, I've seen post the COVID, it's just fallen off the cliff. So the utilization of teleconsultation is hardly there. So I think teleconsultation is a great tool, is a very effective tool, but it needs to be part of a 360-degree healthcare delivery mechanism. It can't be an isolated thing. If we try to say some companies doing teleconsultation in isolation, we are doing teleconsultation, no. It has to be the whole care paradigm has to fit in. So a patient must have physical access, must be confident that he has the ER access, and then the supporting of teleconsultation will help. So great for the COVID period, but how does it play out in the long term? I'm still debating.
Okay. Dr. Shah, related to this question is that, did you do any mechanism to do home care services or any remote monitoring for patients from your group? Anything? You have to unmute yourself, Dr. Shah.
Did not do remote monitoring, but we did a lot of home care, nearly thousands of patients, because we have home care services in all our 11 units. And there the telemedicine was being used. Our physicians were advising patients on telemedicine. So, nurses and other people, attendants were taking care at home, and doctor was consulting from the consulting room. So telemedicine was extensively being used at that time. Also, we have 4 or 5 hospitals in tier 2 and tier 3 cities. So doctors, senior consultants, and intensivists were guiding doctors as well as patients' relatives in a tier 2 like Jabalpur or Vapi. They were being treated from senior people from Ahmedabad. So telemedicine was really useful at that time. Having said this, before COVID, as far as joint replacement and spine and other orthopedic cold surgeries were concerned, there were no telemedicines at all. Thanks to this, what has happened now, we are doing daily few teleconsultations from distant places. So, they then come directly for the operation rather than coming for a consultation and then taking date for operation. So, now slowly that telemedicine use from distant places is increasing, like 7 sister states or UP, Bihar. If they want to come to Ahmedabad or they want to go to Jaipur, they are using teleconsultation more and more now. So, one kind of hindrance has gone away from mindset of patient that they have to be going somewhere in person to consult.
Absolutely. And I think if I can just add to this, the hesitation was on part of the patients as well as doctors. So both are now comfortable with technology. To just share our example, when the physical OPD is closed, so we started the video consultations, and over a period of time it evolved. Initially, it started with a simple video call, and then now it is at a system where doctor can do a video consultation from home, and all the records, they have access to the records of the patient from home, and they can see it on the system, and patient can upload. And so it's actually exactly similar to physical OPD, except the physical presence and touch. So, we saw that we got patients from around 260 cities in the country, doing video consult with our consultant. So that was a big benefit to, that we are a Mumbai-based hospital. So from here, we were able to give care to 260 cities, and that has continued. And Dharmendra, just to share with you, and I agree with you, it has to be a little overall 360-degree offering. So what we have seen is that initially it used to be 100% video consult, but in our case now it has gradually settled down to 20%, 80-20. 80 is still physical and 20 is video consult, still going on in many cases. So that, and I'm going to ask Dr. Trehan, Ravi, in this case, did you have to use any teleconsult? Because I know the physical area of Abu Dhabi is a little smaller. And any video consult did you have to do? And second question is, did you see any increase in non-COVID emergencies? Because in India, we saw reduction in non-COVID emergencies. So did you see any difference?
Yeah. Well, yeah. So to answer to your first question, teleconsultation. So yes, during the first wave, our OPD was also completely closed. Physical consultations were not there at all. And in fact, we utilized our staff again to redistribute on the COVID front. But the telemedicine has evolved, like other speakers have said, actually, that telemedicine over the last few months have evolved so much, and especially in this part of the world. The telephone numbers, and when the state is providing medication to all their local population. So what we did, actually, we created a task force who were looking only for the teleconsultation. And the patients were contacted, and they were very happy, actually, because, as everybody has mentioned, that there was a big fear factor. So they didn't want to come out. So they were very happy to consult with the physicians on telephone. We didn't do that many video consultation because most of them are the refilling of the medication, nephrology patients or endocrinology or cardiology patients who needed medications. And we had a system, the state had provided a home delivery of the medications as well. So yes, overall, it did improve a lot in about 6 to 9 months' time. And we were running almost a complete OPD with the teleconsultation. And it's still nowadays, we get odd request from patient to do a teleconsultation. The second question about the COVID and non-COVID emergencies, actually. So in the first wave, when we were accepting all the COVID patients, in fact, I did write a paper. We had that one in about 2 months, we had around 1,100 patients admitted with the COVID over time. And so that time, our non-COVID emergencies were really low. The second thing, what government did here, actually, rather than telling them that you're in a lockdown, they used a different word. Actually, they said, we are doing a national sterilization program. And in fact, they did do a lot of national, actually, entire public places. They were doing sanitizations. And then that is how people knew that it is a national sterilization program. We don't need to go out. And compliance was really good. And what it did, that the number of emergencies with the road traffic accident, I'm an orthopedic surgeon, and the trauma is extremely high in this part of the world. So those had come down tremendously, actually. And this is, again, lots of building work is going on, construction work going on. So we do see a lot of actually work-related injuries as well. And because nothing was happening, so those emergencies were down. But in the second wave, Gautam, because we were designated, the lessons were learned, and the SAHA had distributed the COVID patients accordingly. And then we were the non-COVID hospital. So what it did, yes, still we were getting COVID patients coming to our emergencies, and we were actually sorting them out to the COVID hospitals. But the number of non-COVID emergencies actually increased by many folds, because the other hospitals were sending all their non-COVID emergencies to us. So yes, there was a shift, what we saw in the first wave and in the second wave.
Thank you. So Krishna, I'm going to ask you a question. So for Apollo, Did you, as a group, do any campaign on the patient awareness about how to take care of non-COVID diseases? Anything you did? Any examples?
Yeah, we did. I think the two, three areas, I think social media was very, very important, right? Of course, one of the things that, of course, technology is coming of age across all industries, and healthcare is not going to be left behind, as we all know. And telemedicine was one of the areas that we really embraced, as you rightly, as all of us said, during COVID. And definitely with time, it's going to help us all become boundaryless in some way or form, right? Clearly, we see that it's the starting of what we are thinking could eventually become big, right? Be it primary, chronic, etc. So similarly on that, social media was very, very important. So social media communication and the digital communication is something that we really did for public awareness. It was a combination of videos. It was a combination of how you were going to be ensuring that you had short videos from internal intensivists, internal medicine doctors, etc. We circulated that on WhatsApp. Many of that went, of course, one of them was to say how was it that you ensure that you're taking good care of yourself even at home, is one perspective. Second is not to panic when you have COVID. So there were various, I think, reassurance messages was very, very important. And I guess, if it comes from some of the leading doctors, patients definitely get reassured, because they, in today's time, thankfully with WhatsApp and social media, at least, there are opportunities to make some of these good things viral, as some of the not so good things also become viral. But I guess, so we use that to our advantage, and that was very good. And I think clear communication and promotion was done, as we said, across all hospitals, which was also important, so that the hospitals understood that, people communicated from the hospital front, etc. The other thing which we did was also reached out to the nursing homes, which of course in the normal case, as all large hospitals like us have good tie-ups with nursing homes, because if there are cases which are difficult for them to handle, they refer back to Apollo, etc. when it is ICU care, etc. Right? So we continuously kept working with a lot of these nursing homes to see how we can work with the nursing homes. We had come up with something called the Red Book. The Red Book was actually a very comprehensive book, which was done by clinicians and operations, to see what is the protocols which has to be undertaken, how you need to really implement some of that in each of the hospitals, which was distributed to the nursing homes, etc. That also made public awareness go beyond Apollo. So that is something that we did very well during this time. So of course, nonetheless, we could only, I would still think we would have only been able to scratch the surface, right? Because all of us were so inundated with patients, our own requests and everything, especially in the second wave. We did what we could from our side. There was also a patient and family communication app. So, thankfully at Apollo, we had, we have been planning for this Apollo 24/7 for a very long time. We launched Apollo 24/7, which is a patient-facing platform, for not just teleconsults, diagnostics, everything, and because we had this tech team, they created a patient and family communication app, which was a very good app, which worked with a lot of patients, where, even patient families could do a video call with the doctor to get update about their patients. Many of us did that, right? I think all of us, even if not the app, I guess a lot of WhatsApp videos, I guess doctors really went outside of their duty to really ensure that, there is patient awareness on what's happening to their loved ones in the hospital, because we didn't allow patient attenders during that time, right? And even during this wave, it was only the patient, so people were anxious outside. So public awareness is one perspective. The patient awareness was a completely other point that we needed to address also. So I guess all of this, I guess, as I said, we tried a lot. There would still be those irate patients, because the anxiety out there was so high, right? So I guess we did a lot, and I guess, God forbid, if there is a third wave, we would all be in a much better position than the second wave.
Thank you, Krishnan. And I completely agree with you. Simple things like, we just provided an iPad inside the COVID ward and iPad outside, so family members could just communicate easily. It's a very simple use of technology, but it gives such a relief to the patients. And another example I want to share, with all of you, and I think somebody mentioned earlier that, when patients were at home and they were very concerned with who will take care of them because they are not sick enough to be admitted to a hospital, but they have COVID. And so there's a lot of anxiety and they cannot reach the doctor. So, we had this 14-day COVID care at home program. So where you would do video consultation with a consultant, 4 times. And we had a nurse monitoring their vitals every 8 hours, and a physiotherapist online guidance, a dietitian online guidance, and a counselor. All this when you do, so you use technology to deliver the care at home, and it gave a lot of assurance to people. At least in Mumbai, it was a very successful program. The other thing which we realized is that we needed to, we started a campaign called Safe to Visit Hospital. So where we actually did a lot of program on the social media, in main newspaper things, and we did promotions at all the chemist outlets, where we actually showed them the picture of a non-COVID hospital and a COVID hospital. Like we had a separate COVID building. So separate COVID building and this one, and we mentioned the distance between them is half a kilometer. So, it's a very simple thing, but it just reassures the people that it is okay to visit the hospital. So that was my example, but let me come to another question. Question to you, to all the 3 clinicians here, Dr. Shah, Dr. Nagar, and Dr. Trehan, that, when all this happened, second wave, first wave, and we heard that non-COVID patients did not get enough care in the first wave. Did you see any changes in the hospital readmission rates or length of stay, or any other different level of care needed by the non-COVID patients after the COVID thing? So Dr. Shah, let me start with you first.
Well, we did not see any change at all. Only thing was that whenever these patients came, their anxiety levels were very, very high, and they required kind of counseling from a psychologist. And a number of times, even relatives were more anxious than patients, because patients wanted treatment and relatives were reluctant to come. So counseling and a lot of time spending with these people was a part of whole game with our staff.
Dr. Nagar?
Gautam, I think I've seen a clear, so let me take an example of last 2 months. I think we've seen the highest volume, even from the pre-COVID levels, of planned procedures in cardiac, ortho, onco. So obviously something has triggered this. And during the COVID period, these procedures were either postponed and the patients didn't turn up to the hospital. So you clearly see an evidence now that what we theorize, that patients are not turning up, cardiac procedures are not happening. Obviously, they were not happening during those periods. And right now, we're seeing a huge surge in these kinds of procedures. So clearly, COVID postponed a lot of planned and even unplanned procedures. The side effects are also coming. Long COVID cases, lung issues, those are turning up right now. So hospitals are going to continue to face a post-COVID impact, I see, for a foreseeable future. At least next 6 months, I see a tremendous amount of shift in type of work we do, type of diseases we treat. And I think COVID and post-COVID, that is a huge amount of difference. And I think you alluded to it, Dr. Shah has alluded to it. Psychological support was perhaps the most underrated and most in demand. And I think this should make all of us who are in acute care wake up that patient only doesn't need surgeries, and we don't need to create factories in hospitals. We have to support the patient as a whole. And I think this is a great learning.
Absolutely. Ravi, your perspective on this?
Well, I think I agree with Dr. Shah and Dr. Nagar both, actually. There was not a huge change, but there were occasional drops, actually, where we saw that the patient, if they had to come earlier, their length of stay would have been less. Even in old people, I have seen in my orthopedics, with a fractured neck of femur, hip fracture. They just didn't want to come to hospital. They stayed for 4 or 5 days, and then they came. And it does change a lot because these are the elderly population in bed for 4 or 5 days, and lots of things get deranged. So yes, there is a subset of population which required further treatment than if they had come before. The second thing, actually, yes, I agree with Dr. Nagar very well, actually, about the psychological support to the patient, what they always needed, a reassurance to come. But at the same time, what we did, which I wanted to say at the time of, while we were talking about our staff safety, we did a lot of work on a mental well-being of the staff as well. The SAHA had created a task force even as early as in April 2020, actually, and we supported our staff with phone number. There was a dedicated line where they could call. We supported, a group support was there, one-to-one support was there. And it's the same way the patients are so well supported by the government here. I must actually share this experience of mine. I suffered with COVID in May this year. And in fact, then I realized that how good this system is. I used to get call from laundry services to come and collect laundry from my home if I am alone, and they could do my laundry because I'm a COVID patient, and they will bring it back. The food services, they was asking me if I wanted any delivery, any raw vegetables or anything. And they were coming home to do my COVID testing. So yes, I knew these were there, but then to experience this firsthand was really overwhelming. It is really what patients need overall support from everywhere, because many of our patients are alone. They are the workers and they live alone in a room. And so if they were supported with all these day-to-day needs, you get confidence.
So I have another question to you and the clinicians, and then I'll come to Krishna later. That all the patients who got admitted to non-COVID area, do you have a view on how many of them got COVID? What percentage of people got COVID? Or they came for non-COVID, but actually they were COVID positive? Do you have any number? Did you guys do any analysis?
I think, Gautam, if I can answer to that, is that there is no data. I mean, it would be conjecture on our part, how many came in with COVID, how many got COVID post facto because of the hospital-acquired infections, or they turned COVID positive within the hospital. They may not have been COVID, they might have been COVID positive, but the test happened in the hospital, and therefore, my assumption is certainly some hospital-acquired infection would have happened. I mean, we all understand hospital-acquired infections happen even in the most safest of the times. And during these times, I'm very sure. It's just that 99% of the patients during that period were COVID patients. So essentially, you saw, we were fortunate in this country, and in most of the places, maybe Mumbai and Kerala were exceptions, that suddenly a week, 10 days, COVID disappeared. And therefore, we got time to transition from COVID into a normal functioning hospital. So I think to say that how many patients got COVID and how many patients got hospital-acquired infections, the data doesn't exist, at least at our level, but I'm sure it happened. But it would have been mitigated just by the fact that we were treating COVID earlier mostly, and there were very, very few patients who were not COVID.
Thank you. Dr. Shah, your view?
Yeah, by June, our non-COVID cold work started, joint replacement, cardiac, even spine surgeries, arthroscopies. And in June, July, we used to get patients because we were keeping all patients for chest X-ray as well as PCR test. So some of them do have had a positive PCR test, that is, and then they were discharged or they were kept in isolation. Few patients were negative but had chest lesions, because PCR positive patient become negative in 7 days and the chest lesions come after that. So we used to discharge this patient and ask them to come after a month or two once the chest lesions are resolved. So initial 3 months, we had a protocol to test PCR as well as chest X-ray both. Since last 2 months, we are not getting a single patient positive as well as, so we have stopped this protocol. Negative patient coming to hospital and getting positive, we don't have any data because we have not found such case.
Okay. Ravi, any experience?
Well, yes, actually, Gautam. In fact, in our hospital, I will tell you, we did get a few, again, a COVID positive, although they were admitted as COVID negative. But as Dr. Naga said, it was very difficult to label whether it was iatrogenic or they did come with the infection earlier and then it showed up later, a positive result, or maybe they had a negative, false negative before. In our hospital, we are such a huge facility. We have about 741 beds, but almost 95% of our beds are single room. So the chances of mixing patients is extremely low, very, very low. So the getting COVID from one patient to the other is not that easy. But yes, the staff taking COVID and then giving to other patient is well, theoretically it is possible. It was possible, but yes, we didn't see that many cases at all, actually.
Good. Thank you. That's been our experience too. But I just wanted to check that none of them from non-COVID actually got COVID. So I think the protocols we all did were pretty stringent. So Krishnan, I'm going to ask you another question. Now, as the largest group, you had the opportunity as a group to collaborate with other hospitals, other organizations to lead the fight against COVID and manage the non-COVID. Do you have any experience to share on this matter?
No, definitely. I think, so as I said, one of the things which, even in the earlier I had referred to was the Red Book. We started with actually engaging with all these many hospitals across, and that Red Book was actually made made available for all of them. There was a lot of, and as we said, there was this clinician interaction which was happening between their clinicians and our clinicians, because one of the biggest things that we did was we created cohorts of clinician groups, ensuring that, one clinician, which is the internal medicine specialist at our hospital, that, these were the heroes, right, during COVID, and you had those 3 or 4 very important and very busy internal medicine specialists. So we linked one to many of these hospitals such that the doctors or the general medicine specialists at those hospitals could in turn also discuss with these internal medicine specialists on the treatment protocols that is being given on the ground to those patients at the nursing homes or the other hospitals, so that they also recognize some of this treatment protocols. But more importantly, I think what we were really able to do as one of the largest supplier of medicines in India, so we know there was acute shortage of medicines. There was so much requirement for remdesivir, there was so much requirement of medicines. We because of the pharmacy, being the largest pharmacy supplier in India, we had envisaged some of this. We had augmented our supplies, right from all the paracetamols to some of these drugs which were used during these times. And we had really ensured that the right patient outside of Apollo also got these medicines, which was something that I guess the pharmacy team did a brilliant job, because our hospitals was taking care of what was required at our hospitals at Apollo. We also had a pharmacy team which ensured that some of these medicines were made available to the patients who really wanted them at some of these other facilities, because they didn't have the ability to stock and they didn't know where to go. The government was trying its best to ration and give some of these, but it was not coming in the proper manner. So some of these medical supplies was really I guess I would really congratulate our pharmacy team particularly, because they worked 24/7 to ensure that these medicines were appropriately stocked and appropriately given, because you don't want a misuse of these medicines, especially when you realize that it is not available in plenty or in abundance, and you don't want only the people who have to kind of use the benefit, get the benefit of these medicines. So that was a big thing that I saw, and I guess a lot of nursing homes remember this approach, because they know that it's much beyond Apollo. It was really about saying what is it that we need to do in the general, for the general good. And I think that we saw across I think many hospitals in their regions, even outside of Apollo. I'm sure all the others also would have done some of this, tried to really help the people who really needed that help at that time. I guess that was very, very important. We also offered a line of support to their employees. We had a employee assistance program which we had developed as HR to assist the clinical staff with stress, mental stress, reduce staff attrition. We had this, I think someone mentioned about the psychology. I think Dr. Dharminder spoke about the psychology requirement all along, and I guess that was also required for our employees. We also offered that to the nursing homes, and they said, if you feel that there is a burnout happening with your nurses, if you see there are stressed out doctors, because doctors, I'm sure all the others are clinicians. I don't think the amount of trauma that any of the doctors had ever witnessed this kind of trauma in ICUs forever in their last decade or so, right? Because there was so much of trauma, and in the morning, evening you go, you think the patient is fine. In the morning you come back, you realize that the patient is not as fine. And so many young doctors were fighting it, and they were doing it for the first time, and they required mental support. There were doctors who were crying on the ICU wards, and several hospitals and clinicians and heads have been telling us about the support that they had to give to these doctors, etc. So I guess this support was something that was also made available to people and some of the hospitals outside of Apollo. And I guess these were the couple of things that I think is learning that we definitely can augment the supplies of some of these hospitals, especially as larger groups. As you rightly said, we thankfully have working capital. We have capital to be able to purchase some of these goods and keep it as inventory and supply to some of them during those times. So that we did quite well.
Thank you. An example of this is that, like all of you mentioned, so we had initially put a 24/7 helpline with our psychiatrists. So all of them were on a call every day, and we were surprised that we thought only the frontline workers would reach out to them, but of course we don't know the names, but we found out that even very, very senior people in the hospital reached out to these psychiatrists because they were facing different kind of issues. They were not in the front line, but managing the hospital and so on. So that was one thing. The other thing is we understood the issues of the staff. So we launched a program called Sampark last year in July, and we broke it up and said we will take care of physical, mental, emotional, and spiritual health of our staff. So that, in this time, they need everything. So, you took care of guidance on how to do physical, do walkathon and do some other physical activities, teach them on that, some yoga and stuff like that. And, do some quizzes and mentally challenging activities, some emotional guidance, do some music contests, some paintings, and of course, have a meditation on every Thursday and a prayer meeting every Thursday, so people can join. So one of the things was that this itself became a big engagement program for the staff. So, hopefully this has also alleviated the stress levels a little bit. So now we are coming to the little end of our session. So I am going to take a few questions from the audience, and then I will ask all of you for your closing thought. So I have a question for you, Mr. Krishnan, from somebody. They've said that these COVID protocols were a lot of money, which you mentioned. It was a lot of costs. So question is, how much of this did you pass on to the patients in terms of higher prices for COVID and non-COVID? And did you have a differential pricing for the same procedure for COVID and non-COVID?
No, I think I can say that there was no cost which was really passed on by the hospitals we didn't have a PPE, apart from in the start of the break, there was this PPE cost which came up. But then subsequently, if you look at it, the cost really went up the roof. We didn't really charge many of those costs to the patients because, because we knew and understood that, COVID was coming from all quartiles, and we have a tariff which is anyway fixed at large hospitals like Apollo and even all the other corporate hospitals who are being represented here. All of us would agree that our tariff books are always fixed, and we didn't alter our tariff books at all for COVID. That is for sure. In fact, I would go to the extent of saying that all of us actually brought down the cost to the extent possible for COVID patients, because we had packages. We also had certain places and certain states and governments saying that you couldn't charge above X rupees or X rupees per day in a ICU or certain other wards, though it was not to the best of our liking, because the costs had gone up on one side, and on the other side we are not increasing the cost. As I said, the tariff book was always determined, so we never increased the cost at all because of COVID. But on the other side, there was also a pressure coming from government, etc., saying that you should bring down your price. And we all know that we should be careful of media in India for sure, because the wrong things get picked up first and the right things are never seen. And that's a sad part of how we're working today. And I guess we all should know that. But for example, during COVID, there was so much of supply side constraints which was happening because of China not working. So a 1 rupee mask had gone all the way up to 10x. It was 10 rupees. Disinfection costs were non-existent, went up by 10x. PPE costs were never existent before. Every PPE cost 800. In the peak, it went to 1600 rupees. How many PPEs you used, how many you disposed. I had no idea as finance, let me tell you that, because it was existent and we all knew it was required. But other important thing was the rostering cost. No one understood that. As you rightly said, Gautam, one of the things was the short times, the breaks that we gave to the nurses, the rostering costs, the allowances that we paid, all of that was so much, at least 20-25% higher on the cost, which we had not realized, on the operating costs. But I guess none of that was passed on. And I guess medicines, of course, you can't do much. The costs of medicines were what it was. And I guess as India, we should all remember that costs of medicines are only going up day by day, because as there is advancements happening elsewhere in the world, I guess, that is something that I guess we as Indians should figure out how we start innovating on the medicine side also, as we embrace the best of the medical advancements from across the world as hospitals. I guess on the pharmaceutical side, I guess we really need to see how some of these drugs can really be brought down, especially in price, because most of them are imported, right? It was from Eli Lilly's of the world or Abbott or whatever those were, and I guess those costs have to still be passed on. But that's how it was. But otherwise, I think we all were quite responsible. I don't think any of us took this opportunity to charge higher at all.
So I'm going to take this cue and ask this question to Dr. Nagar and Dr. Shah, not in the capacity as clinicians. So as the CMD and the MD, now you are responsible to the board and your investors. So what you heard the challenges from Krishnan. So obviously you also did not pass on the cost to the patients. How did you manage the balance of revenues and the expectations of your board and the investors? So Dr. Shah and Dr. Nagar, your views on that.
Yeah, well, as this started, I would fully agree with Mr. Krishnan what he said. So it was very difficult to pass on the cost, and the costs were ever increasing. I told our board as well as our senior management and gave one slogan to them: make money another day. We will make money another day. We will serve the society, because this is not going to last forever.
Well said, well said. Dharmender?
So Gautam, there was clearly two parts of it. I think when we're talking about the cost going up, the variable cost went up, but the fixed cost actually got mitigated by this sheer volume. So even when the prices were capped, the volumes compensated for the fixed cost. So there was some relief. The first wave, there was no volume, no patient, the salary stood. In the second wave, at least the salary stood. Even if we paid more to our workers, the volumes compensated for the fact. And clearly, there is an upside now. So I think I will just second Dr. Shah that okay, we may have been down and out in the first couple of months, but I think clearly the trend is on upside and the industry is seeing a very good upside, both financially and operationally.
So well said. So that's why I had to ask the MD and the CMD their view on this. This very fundamental question. So I have another question for Dr. Trehan. So Ravi, I have a question to you. So you mentioned earlier about your interest in research and your publications. So from this COVID, did you, I know you did research on COVID, published on COVID. Did you develop any cohorts for non-COVID patients during this time? And are there any research, are there any ways to develop and publish some things for non-COVID patients for this period?
Well, truly saying that no, probably we haven't seen much of a non-COVID papers during this period because everybody was concentrating only the effects of COVID, and COVID has shown absolutely a very, very wide spectrum of diseases and how does it affect the different ethnicity in different part of the world. But I haven't seen actually people making a cohort, especially only for the non-COVID patients. We haven't done so that. But yes, what we did actually is that we were concentrating, in the second wave, when we are not a COVID facility, we were designated as a non-COVID, we did concentrate a lot on these patients, especially the oncology. What we saw, many patients with the nephrology issues and endocrine diabetes, they got a very lots of complications with the diabetes while sitting at home. So yes, we did group them together and then made sure that they are approached and they are given the medications at the right time, but not as a research. I wrote about 5 papers during the COVID time. And in another hospital, actually, we did talk about the ethnicity, actually, out of 1,100 patients, but which did not affect that much. The ethnicity did not affect the results, the outcome. But what was important, a paper which I mentioned, you mentioned that about the Guinness Book, but that was a changing, actually, that changed the surgical practice. We did find out that the patient with the COVID, if they go for a surgery within 7 weeks, the death possibility of mortality is almost 3 times higher than the normal population. So yes, it did change surgical protocols in different parts of the world.
Thank you. So we are now coming to the end. So I'm going to ask each of you to give your perspective on any learnings and what do you think is your preparation for the third day? Maybe a minute each. Dr. Shah, starting with you.
Well, we published a couple of papers, one in International Journal about COVID and doing the cold surgeries, non-COVID surgeries during the time of COVID, certain frugal innovation. That is one part. Second part about third wave, we don't know, but we definitely know that this is going to be around. It is going to become endemic. And it is going to be here 3 to 5 years. So we have to be precautious. We want to be knowing about it, that it is around. And that is the way we will be able to prevent it.
Over to you.
Gautam, I think what we are doing is looking at infrastructural flexibility. So we have wards. How do we convert wards into ICU beds when required? And effectively in the second wave, you saw the requirement essentially was for the ICU beds. So how do you strengthen your supply chain and how do you bring flexibility in the operating side of things? So now we've converted at least 24 general ward beds who can, in a day's time, be converted to ICU beds. So I think those kinds of initiatives on infrastructure are happening. Strengthening of supply chain is happening. More ventilators that are being bought not only as adult ventilators, but they should be catering to pediatric and adult modes, both. So a lot of back-end work is going on, but this work is in preparation, but hoping that we don't see a third wave. We don't want to see a third wave. This country needs a break from all these waves. So hoping and praying we are all healthy and face this endemic in a regular manner rather than see another wave of pandemic.
Well said. Krishnan, your views?
So I guess one of the important things that this has really taught all of us is agility. And I guess, the agility is something that all of us have now significantly learned. And I guess any issues which come in the future, I guess the organization now knows, thanks to COVID, on how quickly it needs to act and how. And I guess a lot of these learnings, and I hope we all document some of these learnings in some way or form, so that, we are, like some of the IT companies in India, which we all know are much more process driven in even the processes and protocols. While we are clinically very strong in what we need to do as hospitals, I guess the processes of operations, etc., which we know as in each unit, how can we institutionalize all of this and ensure that we are very agile for the next whatever crisis that emerges, is something that I guess is a learning that was. We are doing our bit to ensure that all of this is in some way documented and put for posterity. That's one part. And I guess the most important thing is execution. All of that finally comes down to execution. And I guess we will all have to continue to plan and execute to whatever crisis that comes in the future.
Well said. Ravi, any closing comments from you?
Well, yes, Gautam, actually, what I would say, we all agree that this COVID is going to stay with us for some time. Okay. And what we need to do is expect the unexpected, although we all pray that we don't want to see the third wave, but then we should be prepared. What I've seen actually I have studied 4 healthcare system: US because I'm connected to Mayo, UK because I'm from UK, and then I've been studying there what is happening, and India, of course, my homeland, and UAE. What I have seen, the difference between these 4 systems is that the UAE was very well prepared, in the sense that we did not drop any guards between first and second wave. We were working hard. The national leadership was still opening field hospitals. I was surprised that why are they opening so many COVID centers for the testings everywhere, the air-conditioned tents and so many people, why are they spending? But then that all showed up when the second wave hit the other parts of the world, and there was so much of casualty. We must understand, we have seen 241 million patients suffering with the COVID during this pandemic. More than 5 million died. And yesterday, there was still 500,000 new cases in last 24 hours. So COVID hasn't gone. So we shouldn't be sleeping. We shouldn't be actually thinking that, oh, well, nothing will happen because now we are over it. So we should continue. And it's a very old dictum in medicine. We all say prevention is better than cure. So that's what we need to do. We are more than 95% vaccinated in UAE. In India, Mr. Modi has led the campaign with more than 100 crores of vaccination, as Dr. Naga said. So those protocols, precautions, and COVID precautions should not be dropped. We are still in our hospital. We are following the COVID protocols. We have stopped eye shields, but then we are still using face masks. And then that is what I think we need to do. And balancing the COVID and non-COVID diseases, actually, that's very important. If we can come out, I know it's a very difficult, complex system in India. It's not easy to do that because there's lots of private providers. But yes, if we have a plan that these are the non-COVID facilities, so at least our other patients who can be saved are not neglected. They are not missed, actually. So yes, a thorough planning and prevention.
Thank you for your thoughts. And as all of you said, that hopefully in the last 1.5 years, we have learned our lessons. We are more agile, more confident, and our back-end systems are working, so our support systems are working, and we all pray that we'll never get the third wave. But if it comes, all of us are prepared, and we need to continue to take the precautions with COVID appropriate behavior. Like you said, continue with that. And my sincere thanks to my esteemed panel and to FICCI for providing this opportunity and for the wonderful interaction that we've got. I've really enjoyed the wonderful insights from all of you. And thank you again, and all the best.
Thank you, Gautam. It's always a pleasure.
Thank
Pleasure. Thank you.
Thank you, Mr. Khanna. Thank you to all the panelists. It was a very detailed discussion and indeed very insightful. Thank you, everyone, again. To the audience, we would request you to join us at 11:45 for the next session on the future hospital. Thank you.
Thank you, Shilpa.
Thank you, Vicky.
Are we? Shilpa, can we talk for a minute?
I'll call you. This is live.
No. I want to talk to Dharminder. I was seeing him after a long time.
Okay. So if we can go offline, please. And
Go offline.
we can come.
Are we offline?
I have no clue, man. Gautam, you controlling the stuff.
Okay, I'll talk to you later. Let it be.
Call me now. Call me anytime.
Okay, we'll do that.
Okay?
Okay,
Thanks,
done.
buddy.
Thank
Good
you.
to see you.
Take care. See you.
So once again, good morning, everyone. Thank you for joining the 15th edition of FICCI HEAL, the annual healthcare conference. Morning, we had some very interesting thought leadership session on healthcare delivery, balancing the COVID and non-COVID. Now, of course, moving on further, we have a panel discussion on the future hospitals. Post-pandemic, the new healthcare models are being envisioned for ensuring smooth functioning of the hospitals on design thinking and which includes strategic mobilization of the resources, centralized and standalone pooling systems to incorporate bypass systems, earmarked COVID care wards, structural changes like delimited zones and unidirectional hospitals flow aimed towards optimizing the safety and care. So we have a very interesting panel, and we have with us the convener and moderator for the session, Mr. Ainab Devgupta, co-founder and joint managing director, Medica Group of Hospitals. Mr. Devgupta co-founded Medica Group of Hospitals, which over the last decade has grown into the largest healthcare network in East India. Prior to Medica, he spent half a decade at Narayana Health, where he is a part of the core team that planned, commissioned, and operated the group's 2 flagship hospitals at Bangalore, Kolkata, along with several other group hospitals in India and abroad. With this, may I now invite Mr. Devgupta to take on the session proceeding further.
Thank you so much. Thank you for that introduction. And I think it's a pleasure being on FICCI's platform. FICCI HEAL is soon becoming the go-to platform for all policy dialogues and knowledge sharing. I think this is great. Am I audible to everybody?
Yes, sir, you are, sir.
All right, great, fantastic. So I think we've been hearing through the morning, and after a lot of apt inputs that have come in from the operational side and the strategy side of how to tackle with COVID and going forward, what we're going to do with the third wave and how do we keep the morale of people up who are dealing with this on the front end. A lot of this also encompasses where are we doing, where is the work happening, and the work is happening within infrastructure, probably one of the most complicated infrastructure that one can create, a hospital. And therefore, it's only appropriate to discuss what goes into design a hospital. We have had multiple discussions, multiple presentations in the past, but COVID has changed all of this. COVID has made us rethink hospital design from so many ideals that we had, and it's been a paradigm shift in how we go to look at and how do we make our hospitals ready for COVID. God forbid we have a third wave or a fourth one. It's not going away as early as we thought it would. So in that context, we have a fantastic panel here today who we would like to interact with and to understand what would it take to, what has been the learning all over these days, how do we take this learning forward to design more effective healthcare facilities, which will allow us to be flexible enough and not compel us in terms of how we got stranded in the first few months of COVID. The panel that I have here is honestly doesn't need to be introduced because all of them are eminent people in their fields. And to begin with, I have Dr. Chandrasekhar with me. Again, the chief architect for Government of India. It's like the most famous architect in the country, I would say, who anybody would know. Anybody, healthcare architecture and Dr. Chandrasekhar are synonymous with his name. He's presently involved with a lot of things, but primarily, I think I would like to mention that he's helping, advising the government commission all the 6 AIIMS-like hospitals and all the refurbishing and redevelopment of all the medical colleges with a focus on development of more doctors that we lack in our country. This is something that he is really spearheading. He is also part of many teaching institutes, including he advises and teaches at faculty of AIIMS Hospital Management, and he's a visiting professor at London South Bank University. Also, he is the chairman of the IBGC, which is the Indian IGBC, Indian Green Building Corporation that it is. And that is, he is really pushing it very hard from Green Building. Dr. Chandrasekhar, please welcome to the panel.
Thank you very much.
I will quickly also introduce my other colleagues here, who are Mr. Kunal Bhattacharya. He is, again, somebody, we call him Kunal Da. formally, and he's been an architect, known him for the last 25 years. And he was part of starting of the Fortis group of hospitals. He was the first chief architect of Fortis, and you could see all the concepts that he's developed there. He's trained in the US, and he's worked in the Middle East and developed more than 100 hospitals in Asia and Africa. He's very, very passionate. I've seen him a lot of time spending with the doctors in the operating theaters to only figure out how does he want to develop a OT. He is an amazing guy, and private sector perspective is where we would like his inputs on how should the private sector look at designing hospitals. We wanted to bring in an international flavor to understand while India is doing what it is, we saw what happened in Europe, we saw what happened in Southeast Asia. We were all overwhelmed with the burden of COVID, and every hospital had its own learning. So what did these hospitals do to cope with that? What do you think we can do in future? So Patrick is with VKA. He's a director with VKA, and he's one of the leading architects in this part of the world. Designed many hospitals in Europe and Southeast Asia. He's going to share with us his thoughts on how to design more effective and efficient hospitals going forward to take care of the pandemics like this. Patrick, welcome.
Thank you.
Kunal, we would like to say hello to you too.
Hi, thank you. Thank you for that kind introduction. Thanks.
Going forward, we have, again, somebody who doesn't need an introduction, both for FICCI or in the country, Dr. Yashpal Bhatia, the first chairman for NABH. He is, again, synonymous with quality movement in the country. And the standards and the guidelines that he's set up is still what we look up to today. And he's constantly been a source of inspiration in the country to actually drive towards his quality journey. I mean, we would all recollect that 15, 20 years back, quality was only in the books, and he's played a huge role in making it happen in the country. He's also one of the finest medical planners, and also who's designed parts of, lots of many hospitals. So we'll get Dr. Bhatia's inputs and his ideologies around medical planning, what's the impact of it, what's the impact of supply chain, what's the impact of quality of care in the new hospital that we need to design. So that's where we would, Dr. Bhatia, welcome to the panel, please.
Thank you so much, and look forward to interesting discussion.
Thank you, sir. Last and the most interesting part is we have Professor Venkat with us. Professor Venkat is not a doctor, he's not an architect, but then he is a teacher, and he teaches at FMS Delhi. He's a professor, and he teaches in healthcare studies, and he is a specialist in public-private partnerships in the country. He is one of the most sought-after PPP experts in the country, from WHO, World Bank, IFC, you name them, and he is on all the panels. He is presently also advising a global consortium of PPPs across the world, and he's leading the India charge on that. We have some very interesting inputs from him on how does COVID reshape our partnership angles towards in healthcare, private-public partnerships in designing, building, and executing hospitals. So we'll get to hear from Dr. Venkat at the end of the session. So with that brief introduction, thank you, sir. Thanks for coming to the panel, Dr. Venkat.
Thank you. It's a pleasure to be here.
So from this point of view, we would request Professor Chandrasekhar. So would you like to come in first and share with us your learnings in terms of how did we face the pandemic? I mean, we realized that the government went through its huge challenges. I mean, the government is responsible for the public health in our country and delivers a significant part of the healthcare in the whole nation now. But when COVID struck, how prepared were our hospitals? What did we go through at the government side? We were a lot busy with dealing with it, but you've had a ringside view, rather you were in the middle of all of this. We're looking at how the hospitals were trying to cope, what were the challenges, what worked, what didn't work. And how would you want to keep this in mind in terms of going forward? What are the learnings that we accrue? And how would you like to incorporate that in your designs when you advise the government going forward? If we can cover these 3 points in your thought process, I believe you have a presentation, so we could look at it as we speak.
Thank you, Aina. Thanks very much. And in fact, I'm very happy to share my views here. It's a wonderful platform. I'll just share my screen. Is the screen visible?
Yes.
And in the slide mode?
Yes.
Yes, please.
So the post-COVID, see, COVID time we have faced challenges. Now our concern is how to handle post-COVID scenario and what all the lessons we learned. So that is where initially everybody's worry was there were two aspects, one is the green field, how we are going to handle it, that's different. But major challenges, what will be happening to the brown field, that means existing hospital, how we can handle it. So initially, the conversion of operational hospital into makeshift COVID-19, creating a patient biocontainment unit with a separate entrance in the emergency department. That was the first thought, because we go by department, and disinfectant chamber through which staff and patient need to pass through before coming in and going out of the premises. Then by converting private room wards into the isolation room, what are the challenges? And then creating negative pressurized isolation room and treating exhaust air. Remember, treating exhaust air was also equally important, because that also was a greater consideration before leaving into atmosphere. Then trapping and killing the bacteria and viruses by magnetic filterless technology, both in the fresh air and the recirculatory air within the premises. Generally, what we were doing is we were trapping them in the filtration, but we never killed them. So the killing was important. That is why the purification parameter in the HVAC or the indoor air quality played a major role during the COVID. Making necessary changes in centralized and standalone cooling system to incorporate bypass system to create negative pressurized and fan filtered exhaust system, and implication of ultraviolet germicidal irradiation and upper room UVGI in isolation, ICU and OT. Ultraviolet has to play a major role, and when we came to know it's more airborne and airborne infection right at the initial stage, like what we used to do it for TB, but now we have to take a call. Now, first of all, what people started immediately doing in the emergency department was they create a robust one-way triage flow for the hospital emergency department, create a referral screening or pre-triage unit in front of adjacent to emergency department. In the OPD, we started using e-Sanjeevani, and even NIC came up with telemedicine-based EOPD. This has also given a lesson. COVID has taught us that all patients need not crowd around into the hospital, how you can screen them right at the source, and it was convenient for doctor as well as for the patient. And this is going to, we have to encash and further carry on with this telemedicine thing. And teleconsultation with the expert doctor consulting each other has become much more this thing. Telemedicine kiosk in the secondary level and even the remote district hospital, where we used to create a health spot walk-in kiosk, contains a high definition video conferencing system that allows a doctor to discuss symptoms with patient, diagnose condition and prescribe medication. And the kiosk contains several digital medical devices. Then we faced another problem was crowd was the biggest thing. And that is leading to the, when we are saying social distancing and all, and particularly this is a scene of a, our typical AIMS in Delhi, where we have a footfall of around 10 to 12,000 patients in a OPD. We thought how to segregate them. Initially, we tried with the, the pick up a token and sit there, but that didn't work because there were around 4,000 to 5,000 people fighting for the token. Then we realized the best way to handle is to have a call center, give them a timing, and when the patient is arriving, this is one experiment we did in AIMS Trauma Center in Delhi, the JP Trauma Center, where we issued a iPad to all the doctor. The moment patient comes, a photograph is taken, and doctors are not very comfortable in typing. And there what they used to do, they can write it. But bad handwriting may also cause medication error. That is the reason we have given them a drop menu. And that is how, and even the patient who comes after 3 months and he says his OPD ticket is lost, the search engine can find out. This is how nowadays you can see that Safdarjung, RML, Lady Harding, all this Delhi, this thing has gone in for the. And similarly in the private, we have seen the using of robo, where we can use it for touchless, how you can handle the patient. Then self-service hospital guides are needed. We need not be bringing more number of manpower. Manpower is always in short supply. Whenever you build any hospital also, you'll find the infrastructure and manpower both always goes in short supply. And technology is the only answer where you can bring in. Even in the district hospital and remote village hospital, we have seen how we have tried to make a social distancing at the time of attending during the COVID. Now, the post-COVID, what are the important thing? Pharmaceutical will replace some procedure and will decrease the need of admission to hospital, and newer vaccine will treat as well as prevent disease. Minimally invasive surgery will reduce hospital stay and promote outpatient operation. And robotic surgery is already in place, and sensors will change central laboratories and intensive care unit of today. So many technology innovations will be taking. When in the Government of India Ministry of Health, we saw the COVID hospitals are meant for managing only COVID positive tested individual, then we divided them into 3 levels. First level was where we can only do the quarantine facility, where normal, which doesn't require any oxygenation or mechanical ventilation. Second level, where we gave them an isolation facility where oxygenation is required but non-ICU area. And the third level is where you need a critical care, that is the ICU is needed. And that is how the 3 levels were created so that we were able to do so. Meanwhile, we realized in the IGBC, we came up with a guideline, because so many places, these kind of setting up of 100 bed, 500 bed, 1000 bed things were happening. So we thought that might well give them a guideline. And in that guideline, we tried to give them that how the separate zoning can be handled, and even the air quality can be controlled. So the pink area which you are seeing, this is the area where patient enter, and the green area is where the staff enter. From here, after the test, he waits for his result. If he is negative, then he goes out. If he is positive, based on that, whether he is in level 1 or level 2 or level 3, he has been placed. And the staff also had a retiring facility. We had seen them that they had spent almost weeks together inside the hospital, and their facility should be there. And here there is a donning area when they go out to these infected area or to attend this patient, and when they come back, they doffing. And this area is also have a separate air conditioning system. So these entire things are already been given in the guideline. That one typical model was of 75 bed. We thought, based on the requirement of a different district, how you can keep on add on level and level in a modular fashion, and you can keep doing. Even in the Niti Aayog, they set up a committee, and all the NGOs who are working with the various districts, they were to be guided. Therefore, this is the guideline where we made a fast track and emergency facility for treating COVID-19 patient, which can be downloaded on www.igbc.in. Here we are given also accommodated in the form of annexure the required medicine, the consumable, and the specification, and even the tender document for any district to carry on, because everywhere the engineering and other support facility may or may not be there, and that is why we are done. We recommend pre-engineered structure for such this thing for faster and speedier construction. And even if it is a RCC structure, how you can make it a huge column-free area where we can use the dry wall partition and create a wonderful free spaces, like even the ease of services of medical gas pipeline with dry walls, and walls have pre-built edge slots in framing for MEP services, and then the sensor-based automatic door from entrance to all hygiene practice. You can have an antibacterial paint and get seamless look, and application of modular pre-engineered solution where you can make a courtyard fills or wraparound model or on gantries or over roof. These small pieces can be added in the existing scenario so that you can be able to handle that. This is what we call it plug and play method. Even you can have a set of things which is available in the containerized form also, where you can make it a separate one. Now, I'm just trying to show you, for the interest of everyone to know the infection control parameter, that how the circulation happens, how the lab and doctors, when they come in, they come and change, and after that they enter to the clean corridor, they do the donning, then after that they get into the corridor of the patient room, and from patient room also you have an anteroom entry, and then when they come out, they come to the other area which is doffing area, and the patient entry is already there through this ramp, where patient can be taken in, and even if in case of death, the patient can be taken out. So it is supported with their dirty and clean utilities, gas manifold, and space for plant room. Number of district hospital has created an isolated unit of COVID. And even in the private beds, sometimes people have started, this is the patient entry, this is the staff entry, and when they go out, they have this biohazard room and then dressing room, and they go out in a different way. This is how one side we have tried to do that. And then isolation, everybody is aware that you have an anteroom with the facility and also with the negative pressurization. And this is a typical ward design we try to recommend, because government cannot afford a single room everywhere, and there is a demand for this. So how you can have a male one side, female one side. Even if you want to do a design in which specialization can be had, you can have a cardiology one side, cardiac surgery one side, neurology one side, neurosurgery one side, you know the way. And this is what, when you talk about green, patient is connected with nature. Every patient is having closer to the window. You can have an open courtyard, you can have a cross ventilated, and even if you want a mechanical ventilator. So higher level of, natural light. And if I show you in little detail, even if it is going to be a teaching hospital, you can have a facility of teaching. And you could see further detail here. Each patient is viewing out. Connecting with nature is a great thing. And the nurses station can take care of, because we have also shortage of nurses, these manpower requirement also to be seen. This single wall can take the services of both the sides, and it will something look like this, in which you can have an independent room like this thing. Even in the air conditioning system, you can create a pressurization and try to create a different version. And one more thing which I would like to add, nurses spend 90% working time traveling between nurse station and patient ward, and highly integrated computerized nursing card to optimize patient care process and enable mobile point of care. So going mobile at the point of care, you have shortage of nurse. So with minimal nurse, you can do the maximum output. And some finishes which you have to be very careful, cleanable finishes, material withstand repeated cleaning, easy to maintain and repair, durable, and resistant to microbial growth. Remember, copper in all touch surface, 80% of our infection happens through touch surface. So copper is an antimicrobial which kills its bacteria itself. So grab bar, IV fluid stand, or even your bed rail, etc., you can have a copper. And non-porous joint means infection. So have a seamless kind of a thing, and pre-engineered performance-based will be preferred construction technology. Just 2 shots on this thing. You have to remember airborne transmission, risk of airborne transmission, we handle it. Up till now, we were handling through pressurization, like negative pressure in isolation room with respect to surrounding. And second was dilution, high ventilation rate, that is air changes per hour controls particle by removal through ventilation. You can use the forced mechanical ventilation, push the air from one side and take it out from the other side, also by processing it. And the third one was the filtration, which we used to use the pre-filter and microwave filter and HEPA filter. But what we were missing, and COVID made us realize, is the purification. So destroying infectious agent in air through exposure to UV radiation, or PHIs, photohydroionization, or HEPA MD. HEPA is high efficiency particulate arrestants. MD means microbial destruction. You have to kill the pathogen. You will not allow the colony of pathogen happening in the filter bank. So these are the certain facilities with the robotic that you can send it across after the process of this area, and even the striking solution or light strike robots, which can be used after any discharge of the patient or anything happens. Thank you very much. This is my email ID, and thanks for the time. Thank you.
Thank you, sir. You were amazingly crisp and just in time. Thank you very much for that. As always. I have a few questions for you, but I think we'll take that at the end once we are done. So without wasting any time, can I request Mr. Kunal Bhattacharya to come on the next speaker's slot? Kunal, the question to you would be: we've heard what Dr. Chandrasekhar mentioned. He pretty much covered what needs to be done in terms of a new hospital and how do we go about doing it. But the challenge in our country still is we have a lot of existing hospitals already, and they are what they are. I mean, government has a massive number of facilities. So do we have in the private? While we know what Dr. Chandrasekhar said will be very useful for us to design new hospitals. And the two questions to you. One is, how do we manage them in the existing hospitals? We've designed them with a certain perspective in mind. We've designed them with a certain air conditioning norms in mind. So to cater to what we have done has really also challenged our existing thinking. So one would be, what do we do with the existing hospitals, if you have a thought on that? Two, converting of non-healthcare facilities into COVID centers. If you could share some thoughts on that, because it's impossible to build so many more hospitals overnight when a pandemic strikes. So we have to be ready with how do we quickly convert without compromising on the quality of care. And three, cost impact of whatever we're trying to talk about. And at the end of the day, while it looks fantastic to have copper, and ideally we should, and everything else, the robots, everything comes at a cost. And healthcare, unfortunately, while the costs are increasing, revenues are going down. So sustainability becomes a big challenge for us. So we need to keep that thing in mind. And if you could help us see through these few points. Over to you.
Thank you, Anna. It is always a challenge, speaking after Dr. Chandrasekhar, because he in fact, I mean, has such a wealth of experience and tremendous understanding of healthcare. So he in fact covers everything, and everything even pictorially. So precious few left for us. But as I always do, I'll try to get into the fundamentals rather than getting into the nitty-gritties of what needs to be done. Now, when we are looking at a COVID situation and post-pandemic situation, a natural reaction is to create hospitals in future for COVID patients. Now, in future, it may not be COVID-19. It could be something else. So the point is, how do we prepare our hospitals for handling unexpected footfalls? So higher capacities, which is how to handle surge capacity. And the second most important thing is we have to, due to our complacency over the past few decades, due to our success in handling communicable diseases, we had completely neglected communicable diseases in our hospitals. So we have to go back to how to handle communicable diseases. And you would remember that in the past, we have seen a lot of old hospitals with separate blocks for tuberculosis. And, there are many such communicable diseases which had separate blocks, etc. So the idea was to segregate the circulation of these patients. And one thing I was planning to actually talk about is preliminary triage, which Dr. Chandrasekhar has very, very clearly explained. And later on, I hope I would be able to hear something about it from Patrick, because Singapore has done tremendous amount of work on emergency medicine and emergency design for emergency medicine. So we would like to know from him how they have handled the preliminary triage, which Dr. Chandrasekhar mentioned in his presentation. So when you design a hospital, you look at actually progressive filtration of the population that goes inside. So unless that is done, if you are allowing everyone to go in, if the design does not facilitate effective crowd control, effective footfall control, you can never expect to handle infection control. And therefore, the fundamentals are that you have to design for progressive footfall control. Vertical course, that becomes, during this pandemic, one of our experiences was that several small hospitals actually closed down, shut down, because they couldn't handle two types of circulations, and they couldn't handle circulation of the staff from the circulation of the patient. Even if they were handling only COVID patients, they could not separate these circulations because their vertical circulation elevators mainly were not capable of handling them. So either they had one core of vertical circulation, or they didn't have a lobby which could be separately pressurized and air thrown out. I mean, they didn't have any provision of protecting protecting those cores. So movement throughout the hospital could not be effectively segregated, which is the reason why they had to shut down. Critical care capacity has been a big issue. It is not very simple. I mean, we have at several point of times, we have seen international discussions on agile spaces in hospitals, managing agile spaces in hospitals. It's easier said than done. One idea of acuity enabled rooms is to quickly transform any kind of general care ward into an ICU if a patient crashes. But it is more of a manpower issue actually than an infrastructure or design issue. In design, it can be handled, not too difficult. But then how do you suddenly get trained critical care manpower into that, and how do you sustain that, and what happens to the void created elsewhere from which you have drawn them? So is there a pool of staff that would always be ready to handle that? So that is something that needs to be taken care of during design process and design discussions. During this COVID times, we have found tremendous oxygen shortage, because average COVID patient was consuming 3 to 5 times oxygen. So again, oxygen storage, which in a liquid form gives you much higher capacity, almost 800 time capacity. So oxygen storage, and then the distribution lines with possibility of designing the pipe sizing for extra consumption. I mean, that is something that we need to handle. And Dr. Chandrasekhar mentioned staff safety, so separate staff changes, staff lounges. I mean, those are something that in Indian hospitals, I mean, we have always ignored those stuff. When you look at these adaptability, because we have to quickly adapt different kinds of buildings. We take a brownfield project and we can easily shave off 2 years in the gestation period. And therefore, you look at these brownfield projects. In brownfield projects, one very important aspect is what kind of building is getting converted. A residential building can never be converted into a hospital because their grid sizes, their column locations, etc., are totally inconducive to healthcare service delivery. So you would be more looking at commercial and institutional, which would be more educational. Those buildings can be easily converted. A lot of people think that hotels can be easily converted. Hotels, of course, if the column column locations are conducive, then hotels can be adapted into hospital use. But from a private hospital perspective, when, as Anna clearly mentioned, when your cost of service provision is going high and your tariffs are coming down, you are tremendously stretched in resources. In that kind of a situation, you cannot afford to lose in space efficiency. So space efficiency is a huge factor for private hospitals. So we usually try to get to a structural grid system where you do not have to compromise on critical care service provision, but at the same time you want to be as tight as possible in that, because every square foot saved is money saved. And therefore column grid sizes, when you go to hotels, you usually land up with larger grid sizes, which a private hospital in India cannot afford. So therefore, I would look at structural grid sizes, column positions, very important. Floor height, that becomes very important when you are designing hospital, a host of services to go. But as I said, commercials usually have more floor height than the residentials. Schools have pretty good floor heights normally, but the stair widths and ramps, in schools, you do not have a problem. In commercial, you do not have a problem. When you are taking over a hotel, it's usually a problem. So you have to adapt, and the elevator sizes. In commercial, you usually do not have a problem. But with schools and hotels, you might, we have actually landed up with problems where we had to create additional elevator spaces. In a lot of states in India are asking for a patient ramp. So that again creates a huge hurdle when you are taking up a brownfield project. If you are looking at a finished building, say for a hotel, to quickly convert it, and the door size becomes very important. Sometimes in hotels, the door sizes are not as wide as are required in hospitals. Now, when it comes to creating some of the temporary constructions or emergency constructions that we have seen. In Calcutta, we have an example where a hospital actually created or spent 4 crores for a construction for COVID. And post-COVID, they do not know what to use that space for. And that is why we have been thinking as designers that we need to create spaces that can be used for multiple purposes. In non-pandemic times, they should be used for some purpose, because if you do not use it, you never maintain it, and therefore that space, and you cannot put in money for an exigency. So therefore, one solution that springs to mind is to use car parking areas. Car parking areas, which are nothing but open spaces with columns, side walls open. One idea would be to use car parking spaces and quickly convert them into hospitals. And we have designed a hospital in Saudi Arabia, where in Riyadh, where actually we had the car parking above the 2nd floor. There were 4 floors of car parking, and then the rest of the hospital went above. Now, in our country, for example, in Kolkata, we have faced a problem where the fire authority does not allow this kind of parking, which they call sandwiched parking. Means the parking spaces are sandwiched between 2 healthcare or 2 treatment spaces, hospital spaces. They do not allow it. Now, if Saudi Arabia can do it, if other countries can do it, we need to learn how they are able to create safety around that. So if we can do that, that gives you a very good possibility of quick conversion to hospitals. So again, to end it, last point is that we need to actually, rather than innovate, I think we need to go back to basics first. We need to design to facilitate patient flow, to facilitate, to create separation between different kinds of circulations, which will come in handy when you are getting into a situation where you have to segregate those circulations.
Thank you
Thank you
very
very
much. I think that was very insightful, and thank you so much for sharing your thoughts on this. We'll come back to you when we have queries from the audience. Thank you very much. Patrick, can I quickly request you? We're running a little tight on time, so if you could share your thoughts, and you have a presentation to make. And
yes,
Singapore is known for being the most efficient, so we're looking forward to it.
Okay. Just to disappoint you, I do not really do Singapore projects, but we have been working on Europe and Indo-China's projects on it. As the topic suggested, the first thing is that we are talking about the future hospitals, as the pandemic itself has actually ruined us quite a lot. I've been locked in for almost close to, almost 2 years. The crisis itself for COVID has actually made a lot of direct impacts and indirect impacts to us. It actually disturbed the whole healthcare delivery disruption, but actually also helped in a way that it fast-tracked a lot of medical research and development and approval itself, just like our vaccination. It also actually disturbed all the supply chains, no matter international. As a Singaporean who has been in Singapore for the last 2 years, we have faced a lot of supplies from overseas. That's what we have been having. And there's a lot of so-called limitation of personal movement, where so-called all these social distancing has been done. We have been working from home. These are some of the indirect things that we are, and government regulations are always changing due to the handling of the COVID situation. We also have indirect impacts. When we talk about so-called quarantines, no matter it's 14 days, 21 days in some countries, it actually affects the wellness of the families and even affects the mental issues of some of people who are supposed to be isolated or whatever because they are in contact with COVID cases. But we see this that, as Albert Einstein has stated, the midst of the crisis itself lies rich opportunities. Okay, when we look at the development of hospitals itself, we have always been looking at from BKA side or from architecture point of view is that we always look at logical sensitive point of designing. And we also look at human-centric, not only just staff, we're always looking at centric things that belongs to the patients, those people that are using to the healthcare system, no matter the hospitals or the medical centers, before they arrive or even after they arrive. We also try to be flexible. Actually, one of the things that our Europe counterparts, my colleagues, we always do is when we look at design, we look at it in a flexible way and a modular way. I would like to share some of the projects that we have done before and which really works during this pandemic season. When patients are being stayed there, no matter it's 14 days or 21 days or even a month, I have heard of some patients that will stay almost close to 100 to 200 days in the hospital just because of COVID. They need soft space, they need dynamic space, they have to be recovered itself. And based on team medicine itself, COVID not only just affect our respiratory system, we also actually affect a lot of things from heart to other systems that is affect. We always need doctors together to work in the way. And because of COVID, we also have to attract back more talents, the healthcare to serve the nation or to serve the system itself. That's why hospital system itself is not only about architects, it's also not only just about operators, it's also actually about even all the policy makers that we have to look at it. Okay, when we look at the driving forces between the new modern hospitals, we are actually driven by legislation so-called pressure. We try to deal with effective planning and reduce the wasteful planning spending itself. Just like a hospital that we have in Europe, it used to be, the current size is 700 beds. But the problem is that previously it was 5 hospitals of there was 5 hospitals, which all 200 beds each, been scattered around Belgium. But the government, using the policy, centralized everything together to make sure that the resources is being well spent. The doctors are being well trained. They now have lecture rooms. They even have better facilities. At a smaller hospital, 5 times 200 doesn't make 1,000. We build it at 700 beds. We make it more efficient. We reduce the bed. We change the quality. So just like all the crises, there's always a triggering point, and there's a reality, and there's a correction point before we go for the new norm. This is versus the tradition itself. Okay. We also look at what is the effectiveness of things. Everything can be integrated and connected. And we also look at what is operational. It can be green, the logistic way of things, and the other thing is how the design is set up. It can be from day one that we work together with the operators itself, how the airflow, the quarantine, the antibacterial itself. From day one, we can select it all the way to the construction itself. And we also have to look at the telemedicine part, which is now the trend, which everything is going digital. And to us, we have been looking at this perspective is where the virtual crowd hospital is going to be established soon, with smaller acute centers, more diagnostic centers to diagnose different specialists like cancer, like different specialists where the doctors actually are located in all these diagnostic centers. That will be the new norm itself. Financial problem, financial pressure. We also try to make sure that all the projects that we design itself are compact with logical medical planning so that it reduces the staff movement itself. Actually, to reduce the staff movement, you will also help with staff retention. Imagine 1 year you're working less than 20% less. Over the years, 10 years, you are almost working less and less and less. But like our project itself, we try to make it simple. We do not make it expensive as well. We are healthcare architects, which someone always tell me that our form actually is following together with our function. We make sure that all the lines, all the flows itself actually is crucial to a normal operation day and also for emergency when we plan all our hospitals itself. Environment itself, it has been talking for ages and everyone has been working at it. But hospital has always been the number one so-called energy using building itself, because once it's open, it works 7 days a week, 365 days a year. So we have to look at exactly how the environment impacts by selecting materials itself that is consume less, pollute less. We work with our vendors itself that, for example, this flooring itself, it actually needs less cleaning in maintaining the covering, and it's non-treatment itself. It saves water and detergent. This is not only just in design, it's also for the maintenance of itself, because once it's open, a hospital, in Singapore, we are talking about a hospital, once it's started, maybe you add a small bit of here and there. For 20 years, we do not renovate it. But in other countries, maybe 10 years, whatever, you add a bit more, add a bit there. But we always think about the long term of the hospital itself. Okay, medical development. We have been working on this with a lot of vendors. We have been working with my planners on this, especially when we look at what's the norm for the future. We're talking about new day hospital concept, where doctors work there and patients actually just come here for day surgery and they are returned there. They do not stay there anymore. All are keyhole surgery, which they can recover within the day and go off. And it will be monitored by smart integration itself, which we are working with people like Alcatel, where they have monitor system where the patients actually get to recover at home. This is the future integration where hospitals and homes, the line is totally being blurred. That's the future that we are talking about, where smaller hospitals, where the healthcare system spread out their wings to everyone. Okay, when we were talking, we were being questioned about what is the transformation, like Kuna just now was saying about the car park thing. happy to share with you, this is something that we have done and something that has been used during this pandemic. It's a hospital in Belgium that we have done. We built a multi-story car park. It's not very tall, but because this is only a 700-bed hospital, because of the surge capacity, the SC that we have planned for emergency, this was a hospital that is completed in 2018. Happy to say that it has met with some of the challenges that was thrown to us from the pandemic. We are able to convert the multi-story car park itself to build extra beds overnight or within 40 hours where the crucial things is needed. During normal operation, it's a car park, but when there's an emergency, it can be turned overnight to be something else. The infrastructure cost that is built from day one already has some capacity. But the thing is that we are not wasting extra money when we design for it to become a surge capacity operation model. This is some of the things that we look when we're as the designer from Europe or even myself itself look at on this. Okay. Roughly this is you can contact me on this and we can have when we talk about future hospital, it can go days and days and days because there's every ideas from every operators or even architect about different things. And I'm happy to share with the panel here on this. Thank you.
Thank you, Patrick. Thank you very much. This was as informative as always. And I mean, time within the time. Thank you so much. Really appreciate it.
Thank you.
With this, can I bring on Dr. Bhatia? Sir, we would like to get your perspective now. We've heard three perspectives from three eminent architects. I mean, one from a government, public health, large hospital perspective, we got a private sector perspective, we got an international perspective on what's happening elsewhere. From your point of view, sir, as a doctor, as a medical planner, as somebody who's so passionate about quality, how do you see healthcare that was impacted significantly during this time? I mean, the non-COVID patients had a huge setback, but then even otherwise, you know, with the workload and the pressures, we've seen quality getting compromised. How do you see that? Do you see that as a concern at all, or do you think we have resilience in our systems that would take care of it? One was that if you could address that aspect, and second is if you could also help us look at sustainability of, say, the online consultations, technology interventions that we could actually engage with going forward in this ways, which could enable us to tackle future pandemics in a better way. Time available, I would love to ask a few more questions on supply chain, but I think we'll keep it to this for now, sir.
Thank you so much. I think this has been one era when the thin lines, between architecture planning or medical planning, or practically everything went into one loop that we had to put our heads together to find the answer. Pandemic we had heard about, but pandemic can be that taxing on the system. We had probably never imagined. None of us could imagine that the pandemic can have that kind of impact or that kind of situation. Where all the speakers have been saying right since morning and yesterday when we heard that. Point remains same. Number one, we were not prepared. Number two, we were caught in a situation when we didn't have the precedences to go back to that. Okay, this is a precedence we can look forward. From the point of shortage of the beds, the shortage of critical care beds, the expandability of the organization, the isolation facility. Now, these are the things which were brought in, and at that stage, we had nothing, no answers for them. We are, in retrospect, talking today, all our architect friends and all our planners, we can in retrospect talk that, okay, this could have been done, this can be done. My question which remains is, are we future ready? We are talking about it today, but suppose the third wave comes with the vengeance, are we ready for that? Also, the second question comes is the situation like now in Delhi and many parts of the country, we are talking about dengue. So we are getting the pressures from the government, okay, reduce the COVID beds, move to the dengue beds. Let's keep on changing that scenario. Now the healthcare will remain dynamic. COVID will probably not be the one which will be driving force for, today in the hospitals with the number of patients of dengue being overflowing. It's not something we are concentrating on the COVID, we are concentrating more on the dengue, and the bed requirement for that has gone up. And that dynamics is going to be here. So I think what we have to do and look at is the flexibility and the adaptability. The situations may come, and those situations will probably be different in the different times. And every time we cannot say that, okay, now we'll modify our hospital for COVID, and now we'll modify our hospital for dengue, and now we'll modify our hospital for something else which is coming. We can't keep on doing it. So somewhere down the line, we have to start thinking about the flexibility in the designs, the adaptability and acceptability in such a manner that if the situation comes, we are future ready for that. Even from the medical planning point of view, this is what we have to look at it. That in the COVID situation, we had a lot of requirement of critical beds. The dengue, now the pressure is on the blood banks and other such situations where a lot of RSS needs are there, and we are there for that. So are we addressing it in our medical planning in that way that today it is one pandemic, tomorrow there may be different pandemic. And if tomorrow we are talking about different pandemic, are we ready to handle it? This is where I would like to bring the point of oxygen shortage by itself is a example which everyone has to look into. We were practically living at a situation when most of the hospital at many times had 2 hours of oxygen supply available in the hospital. And at that stage, the whole management is sitting together that what to do next. How are we going to address it? Okay, today we are talking of each hospital to have oxygen concentrators or whatever, that solution be taken. But are the adequacy of this being looked into? Now, this is where I think so. The lot of it has been touched by Dr. Chandrasekhar and Patrick and Kunal regarding the air quality. The internal air quality has never been a discipline which has been touched so well, except during the COVID period now. So, are we taking any preventive steps to ensure that the internal air quality is going to be a method on which we are going to be? I know that in Singapore there is a law by which all the public institutions or public buildings, they have to have their internal air quality reporting done every quarter. Do we have that kind of system anywhere in India where the internal air quality check is required? So we are now probably going to get into a situation where even if the COVID is past, can we start working on the policies that let any situation come, we will be dynamically able to adapt to that and adapt our institutional system to manage with that. This is where I feel as medical planners, as architectural planners, as services people, as the HVAC system, as the internal quality, as the infection control, as the isolation, all those things, they have to be thought in a scenario where probably at a fixed periodicity, we look at the adaptability of the system of what is unanticipated, what may come and what may suddenly hit us. Today it is COVID. 3 years down the line, there could be some other pandemic which may hit us, where the character may be totally different than what we have seen in COVID. Again, we'll go back to our drawing boards. Again, we'll go back. Let us do something which can be adaptable to that system. Can the healthcare economy afford that? Can every time you say that we do brownfield hospital, we change them now to a new situation? So I think that's one thing which I want to bring in when it comes to medical planning is concerned. The convertibility to the critical care, the convertibility to the emergency care, the convertibility to the isolation and infection control environment, I think these are the areas which we have to look into very seriously. And one thing which I strongly advise and advocate is that on the internal air quality, We have to have the preventive policy rather than the corrective policy. That somewhere down the line, we have a strong monitoring system where at every time we are ready for it, not that we do it when we are hit by a situation like this. Coming to the point of quality, again, it was a very unprecedented situation. The staff was not trained to handle. The staff attrition became very high. The panic became so much that many of the staff they felt it better to leave the job and stay at home rather than working in the hospitals. Reason? Again, lack of SOPs, lack of precedence of such situation, and ultimately no standardization of standard operating procedures anywhere. So every organization, every institution, every hospital was trying to experiment and come up with answers. Whatever instructions and others we were getting from the government agencies or from the guiding organizations, I think they also had, because they were also doing it probably for the first time, and there were a lot of ifs and buts related to that. And everyone wanted it in a hurry. But at the same time, the lack of direction in that hurry was creating the situation. The oxygen management is by itself a case study which one has to look into. The way, the hospital beds and vis-a-vis the COVID vis-a-vis non-COVID bed balances and imbalances that have been going on at previous times, that itself is a situation. So ultimately, there have to be, now we have the time. Now we have a situation where we could actually draw the plans that in case that situation comes, and this is the kind of environment, if the country is hit by that kind of numbers, this is how the country is going to behave. So our contingency plans have to be drawn now, respect to the quality of operation in the organization. So I think now is the time, rather than when the situation hits us and then we start drawing up our plans. I think this is the time we have to put out the contingency plans and put them into order. Lot has been said about digitalization, and I think lot of digitalization apprehensions which were there in the minds of the people, they have actually been shown to give good results during COVID period. Whether it was telemedicine or teleconsultation or OPD consultation, telemedicine. Now, which was earlier not given a legal status, which has been given a legal status. So I think the era of digitalization and its sustenance has come in, which will have its impact on the crowding in the hospital, as Dr. Chandrasekhar very rightly brought out. And the future era has to be the digital ready era, whether it is, consultation, whether it's diagnostic, whether it is cross consultation, whether it is, the triage, whether it is, whether we really need the hospitalization or domiciliary care. All these things will ultimately, now is the time it has come for digitalization, and also the diagnostic and the reach to the healthcare professionals has to move through digitalization, and the now with the artificial intelligence also playing a major role in many of these systems where the touch can be virtual rather than touch being the real. This is what we have to encash upon, which we have to sustain the system on that the times to come. Yes, there were what you brought out very real regarding our readiness to do the testing. That became a very major task, or whether we were able to do the testing, and now the readiness for the vaccination, that became the second task. So again, I go back to this, that our contingencies have to be together. Now is the time for putting the contingency plans together, and what infra, what digital platform, what virtual platform, what supply chain management system need to move that contingency in the place of contingency. And the contingency status can be defined. That contingency one could be meaning, this kind of percentage of the population has been impacted, and percentage two, contingency two could be under this kind of percentage. And that can be further divided and characterized in what is required to be done. So in short, I think if we have to be future ready, my question again, I come to where I started. We went through all this. we did a lot of changes. We brought in this temporary structures and brownfield hospital changes, and a lot of discussions coming up about the future hospital in that manner. But are we future ready? Future ready doesn't mean only the construction of the new building and platform. Future ready means that are we ready from the point of view of managing those situations in totality, where we can assure the population the overall methodology of their being looked after if the situation comes again. Thank you so much.
Thank you, sir. Thank you very much for your inputs. And I think, like you said, Singapore has a regulation where you have to report your air quality on a monthly basis or a periodic basis. One of the finest examples is when there's regulation which is there, people are expected to adhere to it. I think whatever you're saying, a lot of these inputs could actually would be attributed or could be added to the NABH requirements and become a part of the accreditation norm. I think we'll see a lot more compliance happening around all of this. So hopefully we'll get there, sir, on that. I would like to make a quick small presentation on what we did in Calcutta around COVID and around converting a couple of healthcare facilities which were not healthcare facilities or were not being operated. At least one of them was not being operated as a healthcare facility. Not because we know all why we had to do it. Could we have that presentation, please? Shilpa, if you could help us with that.
Yes.
So we were all overwhelmed. I mean, on a everyday basis, we were having to refuse about 100 patients, and that was heartbreaking. I mean, despite best of our efforts, we couldn't accommodate them. Our lobbies were full, our parking slots were full, wherever we could park a patient, we vacated our administrative buildings for accommodating patients, but yet we were falling short. Medica, as a group of hospitals, we treated almost 10,000 patients over the COVID 1 and 2. And yet there was a situation where we were not finding beds. So somebody has to operate it for me. Dr. Roy is been leading the charge of COVID in Eastern India from the very front. And as to his nature, we went ahead and actually embraced an opportunity which was put to us, a challenge rather, saying, could you take up a hospital which is a 120-year-old building, which was a police hospital, which was not operational almost last 30 years, was almost dysfunctional. And I said, can you make this a COVID hospital? And anybody can convert an old hospital to a new one. But the challenge was, can you do it in 2 weeks? And that's where all hell broke loose. We literally had our teams, Udayan Lahiri, who's our managing director, was literally camping at the site for the next 2 weeks. And we couldn't finish it in 14 days, but it took us about 1 week more. And we actually transformed this entire facility upside down, got everything out, and this was race against time. Please be mindful that we were treating 1,000 patients while we're doing all this parallelly, and was quite a nightmare. But then the thing was that when there is a will, there was a way, and we actually could put in the gas pipelines. We could, and it was amazing collaboration between private, public, and donor agencies who came forward to support a cause like this. We had corporates who came forward to pitch in as corporate social responsibility. We had donor agencies who put in money. We put in our own equipment into it. The government put in all its impact on regulations. You can imagine a lot of clearances and licenses were required, which were expedited overnight. And to make something like this happen was a mind-blowing exercise by ourselves. I wouldn't take much time, but the pictures will tell for yourself what was achieved in about 20 days to accommodate over 300 patients at any point of time in this facility. We'll just run through it. And was an experience that we have documented. It's been for the next time. What is more important is we have done this many times. We've all built hospitals in the past, but have we actually documented what went right, what didn't? We have done it this time. So there is a report that we have created for internal use. God forbid the next pandemic comes. What did we do right? How could we expedite? What was the supply chain? Which oxygen pipe? What agency? What material finish? And how do we get our manpower going? I mean, setting up hospitals is the easier part. Where do you generate manpower for 300 new beds in such a short period of time? How are human resource department recruited overnight people to actually make this functional was mind-boggling. Siemens, and other equipment companies who normally would take longer time to deliver equipment, they came in overnight. They said, okay, we would bypass other supplies and supply here. It was some fantastic private partnership. The number of man hours that went in, we just tried adding it up. It was mind-boggling. But then we wanted to see this kind of effort can make things happen. We can actually make wonders take place. This is how the hospital looks today in terms of the donning, doffing, the areas, the segregation that was done here. It was a changed hospital. People who had come there earlier couldn't believe that they were getting into the same hospital. And the quality of care that goes in today it's become one of the best hospitals in town. The staff came in, and this was one day before the 21st day, the 20th day picture, where we were all set. The picture speaks for itself, where we could have been done. So why am I talking about this? I mean, my reason for getting into this is, while we could build new hospitals and design new ones, modify existing private hospitals, there are so many such hospitals in our country which are lying there, where we could actually engage with the private and public partnership could be exposed, and some meaningful mechanisms could be evolved to actually deliver care at the grassroots. And that's something which probably the next speaker is Dr. Professor Venkataraman, who I would ask in terms of, we've seen a lot of collaborations like this happening, not only Calcutta, across all the states, Orissa, Andhra Pradesh, Bihar, Jharkhand, we've seen everywhere such collaborations. But are these collaborations going forward sustainable? Can you actually make these into a longer one? This is another one which we also wanted to do is, we also added a stadium was available to us. And they said, would you like to add beds there? We said, give us anything and we would like to start off. And this was again done within 2 weeks. Luckily, this infrastructure was better. It's a new infrastructure, so we could mobilize things much faster. There's another COVID treatment facility of 200 beds that was created within record time. And fantastic kind of support that we got from everybody, which we could save so many more lives. So my question based on this, I think we can stop the presentation, Shilpa. Thank you very much. So I'd like to bring on Professor Venkat here and ask him that, are these partnerships sustainable? Can we actually go forward with these kind of models which are more sustainable? We saw a lot of this partnership. Will they fizzle away after COVID? Or do you think there is a way to make this into a policy dialogue where we can actually take this learning from what happened and the collaboration that happened, document them, legislate them to make it more permanent in nature? Professor Venkat, if you could come on, please.
Thank you, Ainab, for setting the context. Am I audible?
Yes, please, sir. Yes, sir.
Yes. Thank you, Ainab, for setting the context. I am also thankful to Dr. Bhatia also to provide that kind of perspective that long-term vision is needed for post or beyond the COVID stage. So I'm going to take 10,000 or maybe 30,000 feet above the hospital level and speak about what are the possible interactions or collaborative opportunities that exist beyond COVID between the government and the private sector. Thank you once again for FICCI to give me this opportunity. It's a privilege to be part of this discussion and also to address our gathering. We all know that there is a huge gap in the health infrastructure in the country. It's not something unknown to any of us. This got accentuated during the COVID pandemic. For example, the demand for hospitalization, ICU beds, oxygen, etc., that far outstripped the supply, only kind of indicated to us that we are well short of the kind of infrastructure that is needed. It's also a wake-up call to all of us, and the key message is that neither the public sector alone nor the private sector alone is sufficient and is capable of catering the healthcare needs of the total population of the country. So that really is the key message here, because unless you work together, and it's like all decks on board kind of approach, it is impossible to really address such pandemic. And if tomorrow something else happens, perhaps we need to come together all over again. So, but even without this pandemic, the need for more hospital beds or health infrastructure was well known to us. A lot of estimates that came from different industry sources indicated that India requires almost 1.8 million additional hospital beds. What it means is that an enormous investment that government alone will not be able to make. Therefore, it only indicates that a necessity and the urgency of collaboration between the government and the private sector. During the pandemic, there is also a kind of a substantial collaboration between the government and the private sector, whether to build temporary wards or preparing test or treatment guidelines, or even admission of patients under government schemes are raised, or even the even what I have presented as the brownfield projects to convert existing dilapidated hospitals into something of a workable COVID care centers. But whether this collaboration was a mutually accommodative one, or was there certain kind of a coercion or unilateralism on the part of the government, we perhaps will continue to debate this. Perhaps we also missed more opportunities for such kind of a collaboration. For example, as Aina pointed out, there are many district hospitals or regional level hospitals that are under disrepair. What could have been done is that to have thought about rehabilitating such kind of hospitals and operationally getting it managed by the private sector, especially the COVID ward part of it, with ICU wards or ICU beds and oxygen supplies, etc., or including even the laboratories. I wrote about this way back in June 2020 in a op-ed. It is not about only to respond to the COVID pandemic, but such partnership kind of opportunities help the district hospitals to be future ready. That means that it can provide the specialty services in the future once the COVID services are rolled back. But this opportunity continues to exist. It's not that it is a door closed kind of an opportunity. Somebody has to seize this opportunity and move further. India has such as enormous potential for PPP, not only in augmenting health infrastructure, but also in operational management of underused government health facilities, which has been repeatedly being mentioned now in this discussion, and also in terms of purchasing of services from the existing private sector facilities. There are also examples of well-functioning hospital PPPs in many parts of the world. For example, La Ribeiro Hospital in Valencia province in Spain, popularly known as Alzira model. St. Bartholomew Hospital or Royal London Hospital in London, La Trobe Victoria Hospital in Australia, Karolinska University Hospital in Sweden, and many more. These were, some of them were in the last 1 decade or so. These projects followed models such as private financial initiatives or design, build, finance, operate, or even integrated models. One of the data from PwC says that as of 2018, nearly 700 hospital infrastructure projects on PPP mode were there all across the world. And 75% of them were in Europe and North America. India too has some examples of PPPs in the hospital sector. But the experiences from the Indian context only suggest that we still have a long way to go before we are able to kind of leverage the enormous potential of hospital PPPs. In my view, we still need to lay foundation or groundwork for a mature or a professional approach to PPPs in our country, especially in the health sector. What impedes the PPP in health sector, and what are the key fundamental issues that we need to address? I now kind of look at it from a FICCI perspective rather than only from the government or a partnership perspective. First of all, we need to build sufficient political and administrative conviction. I am not using the word commitment because commitments are not necessarily permanent, but conviction to to recognize that the PPP is a long-term sustainable option in the health sector. Unfortunately, the private sector engagement in the health sector is a hostage to political economy and a negative discourse from various quarters. Despite having a constant interaction with industry bodies, neither government nor the private sector till date is able to bridge the trust deficit. We also need to recognize that PPPs are not ad hoc solutions to a problem that a minister or a bureaucrat wants it to resolve today. That's unfortunately the way the COVID pandemic was handled, as a kind of ad hoc solution. Now everybody is kind of retreating into a shell saying that, okay, we'll see tomorrow what would happen. Absence of such kind of a political or administrative conviction only increases this trust deficit, and it doesn't augur well for long-term perspective. How do we translate this political and administrative commitment? I move to the second part of this, or second element of this. We perhaps have to, when we say is the private sector and the public sector together, need to facilitate development of a health sector specific policy and institutional framework towards the private sector, if not on PPPs. Unfortunately, very few states have any sector specific policy towards the private sector or PPP. We need this as a consistency of government action. A policy is the only way that government will be able to demonstrate certain kind of a consistency of direction or action. This would only improve the confidence of the private sector. It's also important to advocate for a private sector nodal authority within the health ministry. Unfortunately, there isn't a single nodal authority within the Ministry of Health or in the government which can kind of liaison with the private sector in a regular basis. We also need to build the technical and managerial capacity to conceive, design, and manage PPP contracts within the ministries. Very few states have a private sector nodal officer. Absence of a policy or a dedicated unit only increases that uncertainty among the private sector about the seriousness of government on PPP in health sector. The third is that we also need to recognize that hospitals are not just infrastructure projects. It's not building alone. Many of the disputes occur not on the building component of the PPP, but on the costing or quality or access to the clinical services as interpreted by both the parties. We still have a long way to go in developing a mutually acceptable costing and the tariff fixing models. I am aware that various industry bodies have undertaken costing exercise, but are still unable to impress the government to go beyond, let's say, CGHS rate or PMGAY rate. The fourth element is we also need to impress the government to create a fiscal space besides the VGF kind of element that the government proposes for private sector engagement to avoid payment related risks. There's also need to create a mutually acceptable dispute resolution mechanism to avoid escalation of such kind of issues. It's well known that India is ranked low in terms of contract compliance. We all know that too. Lastly, we need to pay attention to mutually acceptable regulatory and governance framework and the role of the public sector as the oversight responsibility. Unfortunately, the word regulation in Indian context looks like as if the government wields a stick and beats around people. Regulation is not a punitive or coercive action, but a harmonious coexistence within a broad framework of patient safety, affordability, quality, and public good at large. We perhaps have to need to recognize that a substantial proportion of hospital revenues in the future may come from government purchasing, and therefore it is critical and imperative to quickly resolve these regulatory and governance principles at the earliest, which are mutually convenient to one another. At the end, let me conclude that both government and industry bodies should lay these foundations so that the private sector engagement is not something like once bitten, twice shy on both the sides. Thank you so much once again for giving me this opportunity. I hope that this was helpful.
Thank you, Professor Venkat. I mean, coming from you, this thought process would go a long way. I think the best part about these conferences and knowledge sharing platforms is that we get to hear such diverse perspectives. And when we go back to our works back, we get to implement a lot of these. For example, I mean, when you're talking to the government next time, I'm sure a lot of this thought process would also get carried there, and everybody will benefit from it. Yeah, thank you, sir. Thank you very much for your insight. We probably have just about a few minutes, actually, I think 2 minutes left to get some questions in. So from the audience or anybody else, we'd be happy to take some questions for our panelists here.
We only have a minute left now, so I don't see any questions as of now.
All right. So we could always, if at all it comes across, we could reach out to our panelists for an answer and we could circulate them around. Great. I think this is fantastic. We had a fantastic session. I enjoyed it thoroughly and it was very insightful. We heard about future hospitals, future designs, collaborative models, and how to make them happen. And I think this is very useful. Thank you, everybody. Thank you very much for your time. Really had a good time. Thank you.
Thank you. Thanks very much.
Thank you, everyone.
Thank
Thank you
you.
to all the panelists and Mr. Dev Gupta. Thank you.
Thank you.
Thank you so much. Thank you.
Half an hour, sir, with you.
Okay.
Very good afternoon, everyone. Very good afternoon, everyone. After two interesting sessions in the morning, I welcome you all once again for a very interesting fireside chat, which is going to deliberate on the impact of pandemic on health insurance sector while highlighting some key suggestions for the government and the industry. With me are two renowned industry members, Mr. Mayank Bathwal, the CEO for Aditya Birla Health Insurance, and with him in conversation will be Dr. Ashutosh Raghuvanshi, MD and CEO for Fortis Healthcare. Mr. Bathwal set up the Aditya Birla Health Insurance in 2015, and he has been with the Aditya Birla Group for over 26 years now. He has held multiple leadership roles across insurance and financial services sector, along with manufacturing, energy, power in India and Indonesia. Mr. Bathwal is a chartered accountant and a member of ICWA and ICSI. We all know Dr. Raghuvanshi very well. He's a seasoned healthcare professional with an illustrious career spanning over 27 years. He's a renowned pediatric cardiac surgeon. Prior to joining Fortis, Dr. Raghuvanshi was associated with Narayana Health for over 20 years. He has a strong track record of building successful healthcare organizations. With this, I would invite Mr. Bathwal to take the session forward, and we all look forward to some very interesting conversations ahead. Thank you once again for joining.
Thank you so much, and very good afternoon to all the delegates who are have joined the session. I hope we will be able to kind of make it interesting for you, and I'm sure we can, because I've got someone as esteemed as Dr. Raghuvanshi to have this chat with, someone whom I've always admired in my short stint in the health side now that I've been part of health industry for the last about 6 years and have had the fortune of interacting with him. So I look forward to this discussion with you, Dr. Raghuvanshi. Before I start, so what we'll try and do is to just look at this whole interface between the health insurance industry and the healthcare delivery industry, and how the COVID time has impacted the health insurance industry and how we feel the opportunities ahead are. And so I'll try and give you a perspective from being a practitioner in the health insurance side, but it's very critical that we get a perspective from someone like Dr. Raghuvanshi from the healthcare delivery side on how he sees the category moving forward and what are the opportunities both to work together and also create more value for the final entity, which is a customer. So just to set the context, I think from a health insurance perspective, the way I look at COVID time is that it has been very interesting indeed, because I remember when the whole thing started in March of 2020, it was, hey, I mean, for how long will it, survive, and for how long will it stay? A question like that to finally, how do we really deal with this, pandemic, which is becoming more and more serious and more complex to handle. The basic thing of shifting from an environment of working in a very different approach, or working from home, meeting the expectation of the customers, to kind of suddenly seeing that this has created new set of opportunities for the category, because the whole consumer response to health insurance suddenly changed, from where it was pre-COVID. And because there was a realization that this is much more relevant today than claims, both in wave 1 and then significantly more in wave 2, which created its own set of challenges for the category. Firstly, in just dealing with the making sure that we were able to provide the customer the right kind of experience, but also dealing with the financial impact, because this was a completely unexpected set of additional claims that were coming to the category. But it also threw up other opportunities, which was how you can revisit your processes, how you can revisit the whole journeys, how you can revisit the whole proposition, including where the regulator supported with many other things, which we'll talk into more detail. But I must say, to start with, that it has been very, very interesting time, challenge at one level, but as I always like to see, opportunity if you just flip the coin of how you can do things differently. So before we get into the more detailed discussion, I'd like to request Dr. Raghuvanshi to share his own opening comments on how he saw the industry and category and the role that it can play, or role it has played, and as a healthcare practitioner. So your comments on that, please, Dr. Raghuvanshi.
Thank you, Mayank, for a lovely introduction and to the topic today. I think, this has been a very trying time for the entire universe, and at the same time for different industries. and healthcare has been at the focal point of all of this. The challenges were multifold. We had to serve. At the same time, the business was challenged as well. And I think the relationship between the payer and the providers is a very intimate one. It has come to the focus during this period even more than what it ever was. Some of the challenges which the providers faced during this period were supply chain disruptions, and also the normal business getting impacted. It was a very unpredictable time. But I think, as Mayank said, I completely agree with that, that these times are when these kind of challenges are thrown at us. These are also opportunities to be able to recalibrate some of the processes and some of the things which we do, and get out of the complacency of trying to do things in the same manner. So I think that has been, in my view, a silver lining in this dark cloud, which is the use of technology interface. And also one of the benefits of this phase was because every part of our ecosystem was impacted. There were a lot of dialogues which happened, like dialogues between the providers and the payers, providers and the medtech industry providers and the officials, pharma industry. And these interactions were actually they had become easier simply because of the use of technology. Normally, it would have not been possible to get so many people together, but we were able to do that. And these dialogues, I think, have resulted in a little better understanding of the challenges which different components of our ecosystem face. And I think what is very important to understand when we are talking about the health of the health insurance, we also need to understand that the entire ecosystem, and the ecosystem is always a system which is dependent on the other components to survive and thrive. So each component, unless it is healthy and it is thriving, the entire ecosystem gets affected. So I think it is very important to have these dialogues, and it is even more important to rebuild a trust between the various components of ecosystem, and that would help to rebuild the trust with the central component of our effort, which is the patient.
Dr. Vanshal, I'll pick on that point, very, very important point that you've made, right? That finally it's an ecosystem. And I think, in any case, the word ecosystem has become a buzzword today, because if any industry, any category you talk about, everyone is talking about building this ecosystem. But the fact is that, and my personal belief has been that ultimately, the payer provider connect is to serve the third P of the triage, which is the patient, as you very rightly said, because the objective of the healthcare delivery mechanism is to serve the patient as a consumer, as a customer for the health and intervention need. The objective of the health insurance industry is to kind of take care of the funding part of that whole proposition, right? So ultimately, whenever I talk to my colleagues in the category, I say that I'm not sure we are really part of the financial services. We are at the amalgam of financial services and healthcare delivery, and therefore we have to see ourselves as one of the components of that entire healthcare ecosystem, and delivery being one part. So, and one very interesting point that you made is that during these very trying times, one very positive thing that happened, and I can share that from my own experience of the kind of number of interaction that I must have had with my colleagues, and counterparts on the provider side, is significantly more than we used to have in the pre-COVID time. Which means that, and we found solutions. Of course, we had our own set of opinions, which were not. We don't necessarily need to agree on everything, but there were many areas that we were able to work together to kind of finally solve the problem of serving the patient and the consumer. What from your experience would be some of the things that the payers and providers can do to make it even more, I would say, institutionalized or wholesome, and can be like a process as usual? I mean, some thoughts on that side, Dr. Raghuvanshi.
Yeah, I think that is a very important thing, how we can collaborate and work together. And I think you made a very, very important, pertinent point, is that health insurance cannot be treated as just a financial product. And the transactionary approach between the hospitals and the provider and the payers also is not healthy for this. Healthcare is a very emotive subject, and people react very differently compared to any other product or industry. So the expectations are very high. Sometimes, one feels that the expectations are so unreasonable that everybody thinks that the insurance premiums should be low and the hospital tariff should be even lower. The medicine price should be also very low, and new and dramatic cures should come at the same time. So I think there has to be a balance amongst all these things. But I think what is very important between the provider and payers is a transparency and an active collaboration, not a transactional relationship. And I think that is the need of the hour. There is no doubt in my mind that insurance is going to play an important part in financing healthcare in India. And it is going to become even bigger and bigger as the time goes. And we have seen that during the pandemic, the penetration has increased dramatically. It has come to people's attention that this is something which is not optional thing, but it is something which is a must-have. It's not a luxury anymore to have an insurance, and it is absolutely mandatory for people to have it. So because of that, I think the coverage, as it gets enhanced, it will become even more important that there is a complete transparency between the two. And that can be brought about very easily if there are technological solutions where the entire journey of the patient is being monitored on a similar or on a unified kind of platform. That will also help in reducing some of the wastages which happen in healthcare system today, because patient has to access things in piecemeal. So I think bringing all this together is possible if the payers and providers work together. There is a transparency, there is a standardization as to how the products, how the procedures, etc., are coded and they are monitored, and the data flows seamlessly. Right now, there's a lot of asymmetry of data. What the hospitals know, the payers don't know. And what the payers know, the hospitals don't know. So the hospitals may be creating services which possibly are not required, and the payers may be able to guide them as to what exactly they should be focusing on. So I think a continuous dialogue, a technology platform which is seamless and brings in transparency, standardization, is extremely, extremely important. And I think both the hospitals as well as the payer have to have already realized, but I think that has to become institutional, that the mutual trust has to be rebuilt, and that can be built only if there is a complete transparency. And I think that is very important, and that cannot come about unless until there is some sort of standardization and a technological platform which allows patient to access care in different setups seamlessly. So these, I think, are some of the important considerations which I have in my mind.
Very, very important and relevant, Dr. Raghuvanshi. And, I think just to carry that discussion ahead, I mean, a couple of things immediately come to my mind, which probably can help take this, aspiration of yours ahead. One is the whole enabled by, this independent platform Swast, It was so encouraging to see that, a platform like SWAS was able to bring together, a lot of entities, both at an institution level like FICCI, CI, etc. They all came together. Whereas, healthcare providers came onto the same platform, the insurance companies came, and the recent launch of the whole, the standards for developing a health claims platform, which can be used to then create, it is an open source standard which has been created by the healthcare delivery side and both the payer and provider stakeholders coming together and making it. So your thoughts on that becoming real? That is one, and because I'm very personally very excited about this opportunity, because one thing that, as you also said, I've been wondering is that why are we not interacting with each other on a tech platform? Because I've seen this with our partner in South Africa, because our shareholder comes from South Africa, that if the entire claims process is there, completely seamless, paperless, humanless, and it kind of just moves, data moves from the provider to the payer or the payer to the provider, and there is a consumer experience is extremely good. And and India being the technology exporter to the world in so many areas, why can't we do that? So I'm very excited about that. So some thoughts on that from your side, on how do you see that taking shape, the whole health claims platform possibility now, given the standards being there. And the second one is that with the National Digital Health Mission now being announced by our respected Prime Minister, I see the whole issue of health data now. If one is there a standardization, and then the data being created in a form that can be then be used based on the patient consent, and data moving in a standard format between all relevant stakeholders, the impact of that on overall not just the health insurance industry, but from a healthcare perspective, how do these two initiatives in your experience, how can they play out to help what you just said get achieved?
Yes. No, I think what you mentioned, SWAS, which is definitely a great initiative, and it is the effort in the right direction. And I think that will become even more robust and important with the National Digital Health Mission, because that probably is like a highway, and there are going to be multiple solutions which are going to be developed on that open source platform as well. And I think SWAS could possibly lead that kind of initiative, because they have started much before the time. And that will play a very important role. There are, of course, concerns about data privacy, etc. But with the consent mechanism, etc., being built, I think for the larger good, it is important that there is widespread adoption of the digital health ID and the consequent use of that information in an anonymized manner, or a kind of unidentifiable data which can come out of that, and that can be used to create so many public health models, kind of services which need to be delivered, etc. And I think one place where we can get help from the finance industry, and I think that is where the expertise of the health insurance come into play, is that they have perfected the technology platforms, where the information flow happens seamlessly and it happens in real time. You can have transactions and you can move huge amounts of money across the world and do whatnot. So why should it not be possible to do that similar thing in healthcare? I think that is probably the ambition of the National Digital Health Mission as well. And I think if we embrace both the payers, providers, and all other components of the healthcare system, if we embrace all these initiatives and start building on it, maybe it may not happen in the near term or short term, but it definitely will happen in midterm, and over the next 5 to 6 years, we should see a real transformation. And I think the way the financial world works, I think same way the healthcare information flow should also happen. So I am a strong believer that only way we can get the wastages out of our healthcare system and make it more efficient is through technology. Now, dramatically, the costs will not go down, but the costs can be rationalized and the wastages can be eliminated. At the end of the day, the kitty which is available to treat all the patients is limited. And I think neither the insurance companies nor the hospitals can provide that kind of support. So these organizations have to be viable on their own. That is when the investment will come into these industries, and that's when the larger pool will get created. However, it is very important, I think, for the policymakers to recognize that these businesses have to be viable on their own. Unless that happens, we are not going to get the desired result. At the same time, in a country like India, with the economic demographics which we have, it is extremely important that the public sector also steps up. But then public sector should be measured, and it should have a similar flow of information as to what a private sector has. So whether the patient gets treated in a government hospital or a private hospital, the process flow should essentially be same. The data flow should essentially be same. So I think the technology is going to play an important part, and the role which insurance can play to make sure that things are standardized and they are on a common platform is very, very important. To get the hospitals together, I think if the insurance says that this is the only way you can function, nobody will have a choice. So I may be, people may think that I am probably not speaking for the providers, but I think it is important in the larger interest of the society that these things are standardized and they are seamless. And insurance can play the leader's role, in my view, to achieve this balance.
Very, very, very well made point, sir. And my personal belief is that finally it will benefit all parts of the ecosystem. It might seem like some initial cost and investment, and I think that's where your point about making sure that the stakeholders believe and are able to see the value in the investment that they will have to make this kind of vision really turn true. But having I'm sure we've all seen in different parts of the globe how this really can help, not just in that particular transaction, as you said, but the fact that that health data, if it is in the standardized form, it can move, of course, through the consent mechanism, through the process. Today, as typical consumers, I mean, we're all used to maintaining our files of interactions, the prescriptions, etc. And who will have their files 10 years back old, and so we don't even know when we go to a medical profession today. We don't really have the whole history, and therefore the whole process starts once again, maybe maximum with 1 or 2 years old data. And if we have the entire set of data, not only is that interaction much more meaningful, but even as a health insurance company, I mean, we see today we have got lifelong relationship with our customers, but are we really able to intervene to say, hey, this is where you need to kind of take some kind of intervention based on your risk profiling and all? And from the very limited experience that we've had, as we have started investing in digitizing the data, it is helping us actually make the conversation with our customers much more relevant, and I would say much more useful, because we're able to talk to a customer and say, this is your risk profile. But if it's really, and therefore you need to intervene here, but if it really becomes the way of doing stuff, then I think the macro impact of that on the economy through better health outcomes can be significant, I think, in terms of what the country can gain. Just taking the technology point ahead, one of the things that we saw during COVID, Dr. Raghuvanshi, is this whole advent of digital health. And I think the whole acceptance of digital health by all stakeholders, whether it was a patient, whether it's from the provider side, people just using teleconsult the way they did, or even the e-pharmacy and so on. So one of the things that is exciting me is the whole opportunity that the delivery of healthcare using digital and technology can do, not just the movement of data. And why I say that is also because the fact that today our health insurance industry is catering to primarily what I call secondary and tertiary care intervention funding, whereas a lot of cost is being, is being, and I would say should be spent in the primary care side, which is the preventive and primary care, the first set of interventions before an event turns into secondary tertiary care, which is not kind of funded today at all. But with the coming of technology, I see that happening more and more, because technology can not only provide these interventions, but also take care of the potential risk that we have in mind of fraud, waste, and abuse if it is done in a physical manner. So some thoughts of yours on how this whole digital health opportunity will move, and how much of that will stay on or become more or less, once COVID turns on, and the possibility of creating more offerings, funding opportunities around these part of the healthcare care chain.
Yes. I think what has happened during the pandemic is that all this has come to focus and people have realized the power of it. Both the providers, payers, policymakers, everybody has understood that this is a way to provide solutions to people. And one of the points you made about the health outcomes, I think that is extremely important, and that cannot be achieved until there is a technology interface. Because I mean, I'll tell you, in clinical settings, there are times when certain important information is missed out simply because somebody forgot to mention. Like many times during my clinical practice, I have seen that the patient has come and everything is decided. He's going to have a surgery on a particular day. Everything is fixed. And then as he's moving out, when he's getting out of the door, and then he says, "Oh, I forgot to tell you that, that I have a thyroid issue or some chronic issue like that." And these kind of informations, when they get missed out, sometimes they can make a difference in the outcome of even the simplest of procedures. So I think that is a very important part, and to make the healthcare more efficient and make the outcomes better, it is very important. Similarly, the health part is, I think, even more important, and as you rightly pointed out, that a larger amount of investments should go towards preventive and primary health. And that is something which has been traditionally neglected a lot. But there are examples, like you mentioned in South Africa, that the insurance was incentivizing people who were buying healthier products from the store. So these kind of things where there is a proper feedback loop for better health can be provided only with the interface of technology. So the outcomes automatically will be better if the information flow is seamless. And I think there are more than enough examples and reasons why it should be done. And I think one of the benefits of the pandemic has been that everybody has realized that it is possible. Otherwise, the whole thing appears so big that there is an inertia as to where we are going to start and how we are going to start. But now people have realized that there are smaller initiatives which can be done, and then eventually it can get aggregated with the newer technologies. So I think that's the direction. We should not try to find one huge utopian solution for everything. I think smaller initiatives which standardize information, help information flow, digitize the information which was earlier carried on papers and files. I think that is what is going to go a long way to make health outcomes better.
Very important fact. In fact, we were trying to kind of work with some of the healthcare provider network side that, can we even have, primary care protocols for people with, based on different segmentation. The segmentation could be age, gender, some existing health conditions and all. And, we realize that there's some work to be done there itself. And so, we're trying to do a few pilots there, as you said, that, you don't try and boil the ocean, try and do a few things, try and see what model can work and then try and scale up. So exactly on the same line, trying a few things, let's see how it works. And I think that's where the entire payer and providers had to come together to try out a few experiments. So just on your point on outcome-based, things. So and your comment on, South African model of incentivizing. I mean, that's what we have attempted to do even with in our case, that how can you as a health insurance company focus on the health element rather than and just the pure play funding of it, from as insurance. So drive better health outcome, incentivize consumers to kind of demonstrate better health outcome, and of course that will require health data, etc., which we spoke about earlier. And there have been discussions on this whole issue of can we work towards creating outcome-based model in the country, and there have been some work that has been done by different committees and agencies and all. Your view on that, Dr. Raghuvanshi, that is that a too much of a utopian thing, that moving from a fee-based or outcome-based, and if at all it is possible, then what role can the payer provider can play together in that?
Yeah. So ideal system probably should have a kind of outcome-based payment system. But unfortunately, the problem is that the actions which are done in order to provide treatment and therapy, and the various people who are involved in delivering that care, I think they are doing actual effort, whatever may be the outcome. So it becomes very difficult to balance out the activity-based payment systems versus outcome-based payment systems. And then how can one part of the system take the responsibility for outcome when they have no control on the behavior side of the patient, for instance? So I think outcome-based payments would work well if they were part of a comprehensive system, which is a captive system. And some of the examples of earlier managed care organizations, which were very popular in the 80s and 90s, I think those models can achieve something like that easily. That doesn't mean that this model will not survive in the other environment. I think eventually one has to move towards an outcome-based payment methodology that essentially puts the accountability on the providers to a large extent. Now, to balance that out, certain mechanisms will have to be formed so that the entire risk is not on the provider. Some degree of that risk will have to be shared by either the payer or the government, because essentially the duty and responsibility to provide healthcare to all the citizens sits with the government. So it is unfair on the part of government to expect a private organization to provide the entire risk cover for something which they were supposed to provide in first place. So I think that is an important point, but always one should attempt to go towards a outcome-based pricing model. It may not be feasible right now, but I think if we start thinking about that and start putting the various things together, that is certainly the direction in which we should go.
Yeah, very, very true. And maybe, as you said earlier, maybe there's an opportunity to try out of a few small pilots, or some try out at a small scale, of course. But it's not just the payer and the provider, but the government will have to play some role there to kind of enable this whole thing, as you very rightly said. So I think we have just kind of touched about the time that was given to us. So your closing comments, Dr. Raghuvanshi, what will your advice be to the health insurance industry in terms of what can looking at where we are and what you've experienced? Some closing thoughts from your side.
I think the insurance industry should stop seeing the providers as a vendor who's just giving service. I think we have to start looking at each other as partners. That is very important. The trust building has to be from both sides. Currently, what happens is that we have, say, a one TPA person sitting there who's expected to understand all the fine prints and everything. So obviously there are errors and mistakes which happen. And I won't deny that there are instances where probably they may be deliberate as well. So in this kind of an environment, to bring that trust together, we have to collaborate more. We have to have continuous dialogues, and we have to work towards creating technological platforms and standardization so that the information flow is so seamless that the patient doesn't feel that they are moving from the payer to the provider. It's a kind of a seamless process. So I think the building of trust can happen only if there is a regular interaction and a partnership and not a transactional relationship. So I think that both sides have to step up to do that. And that is something which I strongly believe, that the providers have to make the move to make sure that the insurance concerns of the insurance industry are taken care of. And insurance has to do the same as well. But that can happen only if there is a regular interaction and a partnership.
Absolutely. So I think the key is that, please come to the table, with the element of trust, be transparent to each other, and maybe, in today's environment, technology can actually help you in that whole process to really build a kind of partnership that is required to give that experience to the consumer, the patient. So thank you so much, Dr. Raghuvanshi. It was really great talking to you. Thank you to FICCI for providing us the opportunity. I wish all the delegates, a very good day ahead. Thank you for the opportunity.
Thank you. Thank you so much.
Thank you, Dr. Raghuvanshi. Thank you, Mr. Bathwal. The session was great, great insights and deliberations. We'll pass it on to the industry and the government too. Thank you and a very good afternoon.
Thank you.
Yeah, we can start.
Good afternoon, everyone, once again. After 2 sessions and a fireside chat, we are ready again after lunch. And the buzzword is vaccine. We all know that today is a momentous day when we touch 1 billion in numbers. And we have a very exciting session which will throw light upon the current and future COVID vaccination scenarios, various types of vaccines, new offerings, as well as how mutating virus can impact the global healthcare system. I have with me Smriti Mishra, Advisor Life Sciences from EY. She has a very enriching experience with the life sciences sector for over 15 years and has been working very closely with FICCI on a lot of our endeavors. Along with us is also Dr. Professor Y.K. Gupta, and he's of course a renowned name. Thank you, sir, for chairing the session, and a very esteemed panel where we have Dr. Ella, Mr. Sarthak Ranade, and Mr. Samir Desai. With this, I'd like to invite Smriti. Smriti, the floor is yours. Thank you so much, and we look forward to some very exciting discussions.
Thank you, Praveen, and the rest of the FICCI team. It has been an honor to be here and sort of mod a particular session. It's a very pertinent topic, and I welcome all the esteemed panel members on this discussion today. We've got an hour and a bit more time really to conclude on this. We'll be touching upon all the topics which basically concerns the vaccine and what next, and what are the imperatives really for this particular industry. A quick introduction of the panelists for everyone's benefit. We've got Dr. Y.K. Gupta. He's somebody who does not really need introduction. He's been sort of leading the pharmacology, and other such initiative for AIDS. He's been associated with AIDS for a very long time. We've got Mr. Ella. He's again has been a name which every child in the country would know as well. He does not need any introduction. It has been a year. We are all safe due to somebody like him sitting here amidst us. We've got Dr. Sarthak, Mr. Sarthak Ranade, apologies, from Janssen, part of J&J for a very long time across geographies, across therapeutic group. He's leading the operations here in India and a very, very experienced pharmaceutical professional. We are looking forward to hear your perspective on the industry. And then last but not the least, we have Mr. Samir Desai. He joins us from Zydus. Again, a very long-standing, high reputation, professionals, been heading the, vaccines initiative. So very, very pertinent voice in the mix today. Let me start off by just giving a context why we are all here. I think vaccines really been a buzzword. It has been an answer to all the queries, concerns, economies, and all the geopolitical movements which have happened last year and a half. And I think it has been the year for pharmaceutical industry, life sciences industry, and somewhere the industry has stood up in the way it has, been totally recognized for the strength it brings in. There's been a level of collaboration in this industry which has never been seen before. Across nations, across bodies, there's been startups, big pharma combination, which has led to a mapping of the whole, genomic sequence of this very dreaded disease in a manner by which the first, the vaccine had been delivered to its recipient in December last year, which has been an unbelievable feat by any standard. And I think this was made possible because I think all stakeholders came together. And there's been such seamless collaboration of data, resources, bandwidth, and there is a certain imperviousness to the financial risk involved. And it was distributed across to all stakeholders. And hence there was an ability to really come up with answers. I think there are really some very good, case studies which can be looked at for times to come, really to draw inspiration from. But at the same time, there are lessons to be learned of how it could have been managed better. And then what next? And I think this session will really focus on all three aspects today. I'll first go to Dr. Y.K. Gupta for just his perspective and views on the vaccine industry in India, what he expects to see in the session today, and then I will go out to all the other panelists. Dr. Gupta, just, over to you.
Thank you very much, Smriti. You have set the
stage very right. And I must say that I feel myself to be very proud because I'm chairing a session which I see Dr. Krishna Illa, a long time my friend, but now is a popular name in the country because not only that he has made the vaccine, but he has made this vaccine available to the entire nation. And we are proud of you, Krishna. And also we have Dr. Mr. Ranade, who is in charge of J&J, which is also making a wonderful news in vaccine, and so is Samir. And so Zydus is now coming up with again the vaccine. So three giants of vaccine, which has made India proud. So I would say that COVID was a major challenge. And this has become a very important success story in India in terms of science, because in the shortest possible time, which we used to call as a 10 years or 15 years is long journey to make a vaccine, we have made this vaccine in a very, very short time because of technology. And we have not only made this vaccine, which is useful for the country, but several countries have taken this vaccine. Now, there will be several challenges which I will be putting to them. And these challenges would be, now this is the one stage. We have come to a very comfortable stage, I would say, where the vaccine is available for the entire country. But do you think that we have now good enough vaccine where there will be no shortage? It will be available free at the market, and as and when anybody wants can use this vaccine. Two, when you have a multiple type of vaccine available, how the consumer will decide that which vaccine he has to take it? Is there a guideline which you, consortium sort of it, can say, yes, this is vaccine best? See the cost. Once it becomes a market commodity, then how the poor people, how the people who cannot afford their lively, how they can afford this vaccine. Of course, Government of India is making this vaccine available free of cost as on date. Next question would be, which I will pose to all of you. This has a natural history and a must for a virus to mutate. Now, fortunately, after this Delta and other mutation, virus of concern are declining. Have not many virus of concern has been. Now, but there is always a possibility. So how our plate, do we have a platform technology and readiness if the virus mutates, then what will happen and how we are going to handle it? And I will also put it to Mr. Ranade and Mr. Samir, that you see, this is the stage where vaccine or vaccinology or has provided us a challenge which we have successfully handled. It has opened so much of collaboration between industry and academia. And the burning example is how the Krishna has come with the Indian Council of Medical Research, Zydus has talked with the BIREC, Department of Biotechnology, and so on and so forth. Each vaccine has not only collaboration in India, but transboundary, across country collaboration with different academic universities abroad, and that's why this is a collaboration. It is a success story, not only for science, it is a success story of managing science, managing product of such a large, and I happen to be the member of task force of vaccine supply chain management, and it is Herculean management. So no simple MBA can do it, and I am sure Samir and Ramandre will appreciate how much management skill will be required so that vaccine wastage is prevented, vaccine hesitancy is compromised, is taken care of, and it reaches, whether it ICMR has recently put in a drone to take this vaccine to the remotest corner. I think these are the success story. Easy to mention success story, but also it is easy to mention challenges. Difficult is to get the solution. So I cannot expect any group better than these three stalwarts who will give the solution to the challenges which the country is facing. You have given already solution, but future solutions also. Over to Smriti.
No, thank you. I think very, very good questions and outlines. So I'll go to Dr. Ella Reddy directly to hear his perspective of how has the journey for Bharat Biotech has been last year and 9 months. What really led to where we are standing as a safe country. We've got the danger has not passed, but I think we are in a much better situation than we were beginning of the year. What has been some of the challenges as well, and also what do you recommend going forward as an industry we should be doing? Over to you, Dr. Ella.
Thank you very much. FICCI was my parent organization. So I worked with FICCI for 10 years when Amit Mitra was the Director General. So I think I'm honored to be here, and I'm really honored to see my well-wisher, good friend, V.K. Gupta. He looks younger. I don't know, he's getting younger. So thanks my other colleagues, Sathik and Samir. But I think, India is in well position, to be frank with you. I think this one field, we are ahead of the game over any other field in this country. I'll tell you why. Take example of us. We are the first one to make a typhoid conjugate vaccine first time in the world, when even US was not thought about it. And we have done the human challenge studies in UK, Oxford. Okay, we have done effectiveness studies in 6 different countries, and 2 publications has come in New England Journal of Medicine in last month on effectiveness studies. Shown that yes, transborder, when Dr. Gupta said transborder, how do you partner? We partnered and made that vaccine. And now chikungunya in the phase 3 trial with the IVI, they started trial in Costa Rica, Colombia, the Philippines, Thailand, and India. Okay, phase 3 trial chikungunya. And I think we are the first vaccine company in the world to patent the Zika vaccine, even before Americans thought about the Zika spelling. So we were the first one. So that way, we are new startup like us are thinking India differently. We are not looking like a generic vaccine company. We are looking at it how to change the Indian ecosystem in innovation. And I think that pressure we are creating in the country on intellectual properties, on innovation, and how the startups should survive, how the regulatory system, and I know Dr. Gupta was an IND committee, how proactively he supported some of the startups. I've seen myself. Okay, when others were so skeptical. A good example of chikungunya vaccine, they said you should put in emergency care. A person should be clinical trial, should be done in intensive care, not outside. So how V.K. Gupta came and rescued some of the things is a very interesting story of our story. But I think India is well positioned. Like Covaxin has come, Covishield is doing, Janssen has come, Zydus has come. That clearly shows the country is leapfrogging in terms of it. I think the greatest story for us is, I think, a political commitment to vaccinate 100 crores is not an easy task, honestly, I'm telling you. So you look at Europe and US put together, there are only 90 crores vaccinated. Okay, whereas India has crossed both Europe and US itself. That's a significant factor. I mean, including even Australia, if you come by, we're still higher than that. All 3 continents put together. I think India has done a great. I think we have to appreciate the political commitment, and also this gives the Prime Minister's mission, Atmanirbhar program, a startup for the future. So this gives a confidence for the foundation for the few. Many startups will wake up in the country and start positioning themselves, and they will going to lead the country. And I see a great prospect for the country itself. Thank you.
No, that's very well said, Dr. Ella. I will come back with some more questions, supplementary questions here, but let me first go to Mr. Ranade for his perspective and views, from where he is, from his vantage point. Over to you, Mr. Ranade.
Thank you, Smriti. So first of all, I want to really thank FICCI for having me here, and it's my absolute share the dais with such distinguished people out here. So really, thank you so much for that. I think at the outset also, I want to,
I think we have some network issue here. You all can hear Mr. Ranade? No?
No, I think his network has some
Network
problem.
has died off. So by the time he comes back,
Yeah, Samir can start.
yeah, if you could just give your perspective, Mr. Desai. You're on mute. Oh, you're on mute.
Yeah.
Sorry, my apologies. I guess.
There he is.
No, Samir.
Okay. Okay.
So sorry, Samir. You can continue. I can go in.
Please stop it. You were about to. Let's hear you.
Okay. My sincere apologies. I don't know, something just went wrong. I was logged off of the meeting. But I guess since I'm back, I just want to once again congratulate the government of India for this great milestone of 1 billion vaccinations. And Smriti, I couldn't think of any better day than this to have a conversation on this very important topic of vaccination. So, Dr. Gupta, to your team as well, fantastic job. And I would also thank all the healthcare workers and nurses who actually made this happen. So it's been a great example of collaboration story, I would say. So Smriti, going back to your question, I think from my vantage point, very clearly, I think, I would just concur with what Dr. Ela said as well as Dr. Gupta said. This has been a great success story for us. And in fact, just before the meeting, we were discussing with Dr. Gupta, and I said, India is known as the vaccine capital of the world. And he said, it's long recognized as a vaccine capital. Now it should be called as a national capital region of the world. So I completely agree. I think this is a fantastic example. Strength of India clearly on global display. Being a multinational company, let me tell you that Johnson & Johnson is absolutely proud and of our partnership with BioE, which is again a leading vaccine manufacturer based at Hyderabad. And one of the reasons why we are particularly proud is because at the start of the pandemic, we quickly realized that the whole world would need this COVID vaccine. So it's important for us to reach out to as many people as we can who would be able to help us to scale the manufacturing of this vaccine. And I think at J&J, our philosophy has been, it's not about competing, but it's about collaboration. So let me tell you, I mean, we want everyone to succeed. So the more vaccine players are there, it's always better for the world because the whole world needs it. We are so proud of our partnership because BioE is going to be a very important part of a global supply chain network. We are looking forward to supply the vaccine to India as well as to the world. I guess this is just some great example of how people came together to collaborate. And I was also talking to Dr. Gupta, and I said, it's not just about collaborations between companies, but it's also collaborations between academia, we have seen examples of how ICMR and Department of Biotechnology was always there to help all of us actually at every stage, so remarkable facilitation and collaboration. And not just that, I wanted to give an example from the Johnson & Johnson world. In the US, we actually partnered with MIT for data sciences and analytics, because we were very keen to understand, where do we place our vaccines studies, because where is the burden of COVID? How is the virus moving across the world? And I think all those work really helped us to understand, where the virus is mutating, which regions have which variants. And actually that gave us a lot of, I would say, information and knowledge to move our vaccine forward. So maybe this is just a quick summary, Smriti, which I would like to share. A great story of collaboration and success.
Absolutely well said, and I think again we would have more supplementary questions. We'll come back to you later during the session. I think we'll go to Mr. Desai. He had just started speaking, and apologies for that little bit of a disruption. Please go ahead and share your perspective.
So thank you, Smriti, and good afternoon to everyone. Thanks, FICCI, for having me here, and it's indeed a privilege to be part of a panel made up of such eminent personalities. COVID, like it has been, like each one of us has been saying, has been a great challenge, but has also been a great opportunity in the sense that the industry has really shown how can it step up to the challenge and deliver healthcare security to the world, I'd like to say. The 1 billion mark obviously is a great milestone, and that would not have been achieved without the fantastic collaboration that we've seen. See, developing vaccines is a challenge. Manufacturing vaccines
is yet another one. Distributing them is yet another significant challenge. And getting vaccines into arms is yet another different challenge altogether. And I believe within a very short span of time, the industry, the government, the healthcare workers, the entire infrastructure has really, kind of stepped up. I'd go back to some of the opening remarks that Dr. Gupta made, and one of the important concerns that has been there as part of the vaccine development challenge, especially with regard to COVID, was developing platform technologies that actually help us tackle the challenge of variants, because we do understand RNA viruses usually mutate much more rapidly compared to other viruses. And we've already seen quite a few variants of concern, undoubtedly. A few are now getting recognized in the past few weeks, but one never knows. And I think at Zydus, our endeavor was not just to develop a vaccine in a short span of time, but also to ensure that we develop a platform technology that not only yields to a quicker adaptation for emerging mutants as far as COVID is concerned, but also going forward in future to tackle various other diseases that we haven't really been able to address as effectively in the past, and maybe emerging threats or emerging diseases as well. So the plasmid DNA technology platform that we've been able to, kind of bring up, and this is, as you know, ZyCoV-D, the world's first plasmid DNA vaccine. It not only shows the ability, as I said, of the industry and our company in particular in this case, to tackle a challenge head on and in record time, but also the ability to bring a platform technology, not just a product, a platform technology that represents a significant advancement in vaccinology per se. And I believe that's what makes us, I would say, it humbles us in the sense that, it was possible for our teams to work together in such record time and bring such vaccines. And I think another issue that somehow doesn't get as highlighted, as it should be, is the willingness of the regulators worldwide, including in India, to be open-minded and flexible around the regulatory challenges. One of the significant developments that happened during this period is all these rolling submissions that have been allowed by various regulators across the world, which expedited the development of vaccines and made it possible that within exactly 12 months of time, the first cases were reported around Christmas time in 19, and by December 20, you already had a vaccine out on the market. And in January, India already had a vaccine available to us. I mean, this significant speed was achieved not just because, like you mentioned, risk was spread across stakeholders, everybody came together, collaboration obviously has been the buzzword during the past 18 months or so, but also more importantly, because we saw developments not just in vaccine science and manufacturing technologies, but we also saw significant developments in regulatory science. And the support that one received from academia, from the government institutions, and especially our investigators and volunteers. You've had large clinical trials, 28,000 plus volunteers in trials, 25,000, 20,000, 28,000. These are large numbers, and conducting such large trials in such short span of time, I believe we've kind of demonstrated our capability as a country across different sectors. And indeed, the biggest, I would say, challenge for us would be now how to ensure this capacity keeps getting leveraged as we tackle coming challenges. Thank you.
No, absolutely, great points, Mr. Desai, and a lot to ponder there. I think the point which you made around the pace of innovation, given that it was a public health emergency, and hence the regulators, stakeholders came along, and there was a certain blueprint which was being made for fast tracking the innovation. in this particular context. How do we take away some of the good practices of this fast tracking, more around technology, more around processes and system, and easing government involvement in the whole process? I think those are some of the positive takeaway. And I would want to sort of go to Dr. Ella for his experiences as a first indigenous Indian vaccine manufacturer, to sort of talk about how the collaboration with ICMR went by, and how did we arrive at this point. I think just reflect back on the history a bit so that we can take some learnings from there for the future. Over to you, Dr. Ella.
Thank you. No, the public-private partnership, it works in the infrastructure project. Airports are working with the public-private partnership. I don't know why it cannot work in science and technology. And I think I'm a strong believer of public partnership. And our rotavirus vaccine was developed Indo-US Vaccine Action Program, bilateral country program. We worked with CDC, we worked with NIH, Stanford, we worked with the DBT, we worked AIMS, we worked with the CMC, we worked with KEM, all these hospitals. We have done the first efficacy trial in the developing world. That was the first efficacy trial done on the newborn infants in the country. I mean, we have at least overtaken even Chinese in that angle, on efficacy trial. So we have done that, and we have typhoid conjugate. We have done with the efficacy trial in Oxford with Academic Institute in UK, human challenge studies, and we are doing effectiveness studies with the University of Liverpool, University of Oxford, University of Maryland, all of them. And then we're doing a phase 1 trial we completed in US, with the University of Maryland, Baltimore, for NTS project. We've done the clinical trial there. And we're doing clinical trial more than 14 countries now, all over the Asia and Africa and Latin American countries. So I think we have a tremendous experience working with the government, public, private partnership. Good example of ICMR. And I'm telling you, the partnership with ICMR, NIV, and Bharat Biotech is a significant, I can tell you. We are benchmarking today in the country. Okay, what is needed here is a commitment from the management at the company level, top management, and commitment at the secretaries level. And sorry about some. So I think you need a commitment both the level. And I think, I always believe that 1 + 1, if they're truly like-minded, it becomes 11, not 2. And I think that's how the partnership with NIV Pune and I is, we share a lot of data together, openly, transparently. All of us work together. And what makes the science of doing this science? And I think it's a tremendous partnership. And I think these are putting a benchmark that this is how the benchmark should be for the country. And a lot of startups will be benefited out of this relationship. Thank you.
Absolutely, and I think this one will go down as a case study for history. I think we'll all keep talking about this for a very long time. But we need to see more of these, and as you rightly said, we need to scale up as a country. We need to be able to manufacture a lot more, not only for us but for other countries where access is not so high and there are resource constraints. Going to Mr. Sarthak Ranade. Being an global MNC here in India, having got a partnership with BioE, how do you see India as a market? Where do you see the regulatory ecosystem facilitating an entry, and what you need to have this kind of pointed towards the change you expect to see in Indian environment for you to really make this a established manufacturing hub for somebody like yourself? It'll be good to sort of hear your perspective.
Thank you, Smriti. And look, I think at the outset, I would just want to let you know that Johnson & Johnson has a long history of commitment to India. So we have been here for more than 70 years, and we have a substantial footprint in India, which consists of manufacturing plants, R&D centers, and also partnerships like the one which I just said before about BioE. So where we possibly don't have capabilities within, we look for opportunities. And I think during this whole pandemic, everyone has realized the importance of having supply chains at the right places, right? And I guess that's where the opportunity for India lies, because everyone is now focused on having stability in the supply chain. And India has always been known as for its strengths in the generic space, and even the vaccine space. So as we know that 60% of the world's vaccines are supported by India. So very naturally, I guess this is the strength of India, and this is what India can offer to the world. Now, what do we need to do more to make India attractive? And obviously, I guess one thing which I would continue to harp upon would be the excellent facilitation which we have seen from the government of India during over the last 19 months. I mean, absolutely incredible agility, facilitation, and I guess that needs to carry it beyond the pandemic. Also, in terms of regulations, I would say, we have seen, I think Samir mentioned it, the need for regulators also to be agile when you are facing such a extraordinary challenge. And we saw that happening in India. So the DCGI and his whole team has been absolutely wonderful in terms of being flexible, being open to suggestions and ideas. And that really helped many of us, not just to deliver a vaccine, but also to continue to supply our normal other drugs, because at the end of the day, what happened is during the COVID pandemic, everyone was so focused on COVID, but people forgot that there are people dying of cancers and other so we have seen a lot of facilitation and collaboration from that side. In terms of regulation, I would say, there's a lot of learnings which we can carry forward out of the pandemic, agility, flexibility. How can we work closely with the government to see how the reforms can enable us, and mostly MNCs, to bring their innovation quicker to India. So I'll just quickly point out, there is something called as the Rule 101 in the new drug clinical trial rules, where the rule says that if a new drug or if a new innovation has been studied and approved by developed markets like Japan, US, and Europe, you possibly don't have to do clinical studies in India, because the moment you do clinical studies, it just delays the launch of the product in India. So and we have seen that that has not been sort of implemented. So these are absolutely low-hanging fruits for all of us to think, how can we accelerate innovation and launch of innovation in India? So I guess this would be some of the things I would definitely like to put on the table.
So I think that's a very, very pertinent point. And I think at this point, I would want to sort of invite Dr. Gupta for his perspective. I think we are discussing now regulators, and no better than him to sort of, reflect on that point and actually give his perspective. And then I'll go to Mr. Desai for some more questions around, vaccines and the future. So over to you, Dr. Gupta, for your thoughts on what the panelists are discussing, and your perspective on what India needs to do from a regulatory infrastructure ecosystem perspective.
Thank you, Smriti. I think what Rana Desai has said about the regulation, and that has been my area of interest, because I chair the entire NDCT now, what is called as the NDCT 19 regulation, and we had several, hundreds of meetings for drafting each and every line. And this is one line which I insisted that why unnecessarily we do clinical trial in India, unless, and we specifically added that if this drug or this product or this IP is established in different countries where it is a well regulated, we just said well regulated, we did not specify the, yes, there is a reason to say that this person or this population will behave differently, metabolic enzyme different or kinetics may be different, then it should be considered as a potential low-hanging. Therefore, you can either waive off the clinical trial or you just do the bridging study depending on the need. And you will not believe, when this pandemic came, just 3 months before, we had a 3 workshop with ICMR and THSTI and AIMS on what could be the emergency use authorization. We never knew that this will be applicable so soon. And that is what brought the change in the mindset of the regulator and the expert, that you have to really think risk versus potential risk, I would say, versus potential benefit. And then you put this into the emergency use and then see very carefully what could be the future of this. And then you go ahead. So innovation thinking, mindset change, that is what important. And I was just mention one thing. This COVID vaccine has taught us a lot of things. First thing you start, has any leadership in any country, like PM, our Honorable Prime Minister, going to individual sites which are going to manufacture this? How much boost a scientist will get it? I think nowhere this example would be there. The Prime Minister himself visiting Krishna Illa's lab and maybe Ahmedabad and maybe other things. This gives this so much boost. And then the regulator has to come into the same stream. So that is what, and I would just put it. I wish the regulator will become equally enthusiastic, pragmatic, innovative, not only for vaccine but for any pharmaceutical product. Why not we give the product same strategy? Ultimately, anti-cancer drug, anti-diabetic drug, or that is also important, as Sahab has very rightly said. So I am sure that the regulatory system in India is going to be the best in the world. Potential, pragmatic, and proactive. And that is what we are looking for. The one thing I will like to just raise this question to all the three industry experts here. You have admitted and you utilized the academic institutions collaboration. Krishna LA has given number of academic institutions, more in outside India, but several in India also. Now, and so is the Johnson and Johnson. You could not bring the product into the public unless there was an extensive clinical trial in India by Indian investigator, by Indian sites, approved by Indian regulator. Everywhere Indian. So now, what is Dr. Krishna and or Samirji, what you think that how you can strengthen the capacity of Indian academic institution to give their best to you? I think we have been talking industry academia collaboration for best output, and I chaired the committee of Indian academia and industry collaboration by Department of Pharmaceuticals. So I would just like to have your commitment now for strengthening the Indian academics. And then I would be very happy when Krishna will say next time 10 Indian universities and 2 academic institutions outside India. Reverse order. Over to Krishna and then
over to you, Dr. Allah.
Also, why not you create an university of regulatory science? Join, give 100 crores, 100 crores, 100 crores, make an autonomous university which will only talk about the evidence-based regulatory science in pharmaceutical and devices sector. We don't have to use that this is written in US FDA, this is written in EMA, therefore we are adopting that. If the evidence-based factors are coming based on your experience, a regulator's experience, and we have to create this university. And this university should be funded by consortium, by all industry people. And then government should ask the government to give the matching fund. You be the faculty, all of you. That will be giving back to the academic scenario in the country. Over. I would like you, all of three to respond to this.
I think I'll respond. I think the last point he said about regulatory university is an extremely good point, because this is one way to educate the regulatory system in evidence-based, science-based regulatory system. When our regulatory system is still not matured in science, and if this sort of regulatory university can create and model of case studies, how a science and evidence can put in this thing, and that model case study report gets into the regulatory system, that will be the fast track in our regulatory change that can happen. I think it's an extremely good idea. First time I'm hearing that idea.
So now just a second. So after this, I would like you to commit 100 crore to the consortium, all three of you.
Why not I start the university myself for the regulatory university? I think I'm looking at starting a university, creating these sort of intellectual property issues and regulatory, youth role in the regulatory system, not my idea. And I would borrow that idea and implement that.
But we will take it from you, no problem.
And I'm really keen about this sort of very good system where we change the regulatory system in the country in a fast track mode. Otherwise, it's difficult to change. By recruiting people, you can't change it. So I think this is a good idea. But coming to the academic relationship, and I think what academic people have understood is a publication. They want publication. So this is one of the things I understood from the global academic institutes, whether Stanford to CDC, NIH, and University of Maryland to Oxford. Everybody wants our publication. So that's a partner. Yes, I'm interested in the research too, together. And that's how we produce more than 125 publications. I don't think any company in this country has got 125 high peer-reviewed journals from New England Journal of Medicine, Lancet, and PLOS, and all the top journals in the world, Nature, all those journals. I think ICMR, look at the very good collaboration, 14 articles, 14 journals, 3 Lancet, 1 Nature, and 2 iScience, and Travel Medicine, 3 or 4. So 14 publications. And I think, so we satisfied what academic wants it. We also built the scientific credibility for a company and scientific credibility to the country. And we built it as a win-win situation. It's not just a product alone. So the product is intangible things are the publication, research, and understanding of the expectations of each other. I think we built that one. And how do we create this model, multiply, is going to be challenging. And I think that needs a different thinking at top level, and tax structure and other issues.
Great.
Thank you.
Mr. Ranade, your comment on this.
Sure. So, Dr. Gupta, I mean, first of all, I guess, at Johnson & Johnson, we are absolutely open to such kind of partnerships, and we value, our partnerships with academia, and we have, many of them. And I just wanted to sort of bring out one notable thing, which, which is very important, I think, was one of our scientists, Dr. Anil Kaul. And in fact, he is incidentally the one who is also the researcher of bedaquiline. And I'm sure I saw a smile.
Good friend of mine.
He's a good friend of yours, I know. And as you know, that he was on a secondment at the IMTech Institute, so we're very proud of his contributions and his relationship with the academia. So we would continue to leverage these partnerships. And every time I speak to Anil, we keep on discussing what more we can do in India and what kind of partnerships we can strike. So absolutely open, and would love to take this forward. Thanks.
Samir, your thoughts?
Sure. Thank you, Dr. Gupta. And indeed, I believe another thing that has gotten really prominence during this COVID challenge has been the contribution of the academia to this, to the response, the challenge, whether it is, originating in the academic institutions like what started in Oxford and later on became vaccine, which is now present in most countries worldwide, to what industry started and partnered with academic institutions, like in our case, with, whether it was Department of Biotechnology, BIRAC, NIV. We've had past associations as well with NIV in rare diseases areas, bringing surveillance diagnostics to Indian market. And I do believe very strongly, and as an organization, we believe very strongly that partnerships with academic institutions is what brings new breakthrough ideas into the research pipeline, because discovery research or breakthrough research usually originates in the academic institutions, and it is the industry's province, I would say, to translate it, to develop it, and later to commercialize it. Regulatory sciences is certainly an area where a lot of improvement can be brought about through formal education and training, and the University of Regulatory Sciences or a faculty of regulatory sciences in one of the universities focused on pharmaceutical sciences in general, I think is a great idea, is a wonderful idea, and something that the industry would certainly welcome and would be happy to participate. And like I think both my co-panelists have also mentioned, I believe the sense of urgency and a call to action that was brought about by the impending challenge that was posed by the pandemic really made all of us, and I would say when I say all of us, I mean both the industry, the academia, as well as the government and the regulator, all of us, far more open to collaborating and far more willing to work together. What is really very, very important is to ensure that it doesn't take another such challenge for the same atmosphere to continue, that it becomes part of our day-to-day life, where we look forward to each other as collaborators, as people who could contribute sectors and provinces that could contribute value to each other in meeting challenges that the world faces, rather than looking at each other and seeing who can run faster. The idea is not really that. The idea is together all of us can certainly achieve much more, as we have already demonstrated in the past 18, 19 months. And should we be able to carry this forward and make this a default mode of collaboration, I'm sure both the industry and academia will be enriched by it. Thank you.
Thank you very much. And before I request Smriti to take over, just one quick comment here. And before I make this comment, I will just say that I'm not asking 100 crore rupees for all of you, but I will asking for endorsement of this idea. And I advise that you, at least you 3-4 people, pledge to become professor of this virtual university, honorary professor. And let us make the faculty and let us have a meeting so that we create a university for regulatory science in pharmaceutical sciences or life healthcare products, and which will generate evidence, and then these issues will never come again. That why this SEC saying so, have we everything defined and let the answer come from this. I think that's my wish list. Not only list, this is my only wish. So, and I would just ask you one thing, all of three. Corona, we have almost achieved success, victory. Challenges, mutation, platform are there and meeting the need of the entire country. But as Rana rightly said, that we have forgotten, we have the other disease condition have for the time being gone in the background, like AMR and all those things. Now, once we know that we have shown the capability of developing a vaccine in the shortest possible time, gone are the days when our slides we used to show for teaching the 12 year, this many $1 billion and this and so much, and those slides are now in dustbin. Now the emerging slides are how fast you can develop drug, how fast you can develop vaccine, and how fast you can do the collaboration. Can you think of 10 more vaccines in next 10 years and say we can increase the canvas of vaccine preventable diseases? We are talking of vaccine for tuberculosis, we are talking for a vaccine for cancer, we are talking of vaccine. Can you think of vaccine for cataract? Can you think of vaccine for Alzheimer's? Which is people are working on that. So why not we can look for, Krishna, see the conventional vaccines are there already. Now you have shown the path that we can do, Bharat can do. And Bharat Biotech and Bharat is the same. So what can be done for how you envisage the future vaccinology in India?
I mean, the changing the technology is going to impact quite heavily in the future of vaccine technology, like whether it's mRNA or DNA vaccine or other platform that is going to come in. But each platform has got its own limitations. And we don't know yet the safety profile of over the 5 years, 10 years period of the time. And so we have to wait and watch.
You're mute.
Drastically, like bringing it 1 year regulatory system for the children vaccine, I doubt we should not do that. We should not hurt the children under any circumstances by bringing a shorter regulatory to make it to child to be vaccinated. Pandemic, yes, it's okay. We can have two different regulatory system, one for pandemic, different regulatory, children vaccine, totally different regulatory system where the safety of the future of the child is more important. But I think we need to look at that angle. But certainly the future of the vaccine, the mRNA, although it has come, how that is going to have safety profile over the period, we need to wait and watch. But what changes will gain, cancer vaccine will be a reality. It's going to more important. This technology platform can get into that segment. And coming to mRNA vaccine into the bacterial vaccine will be difficult, will not happen. And you were talking about the AMRI, good point. We implemented our typhoid conjugate vaccine first time in the world in Pakistan, where XDR, extremely disease-resistant strain developed, including not responding to cephalosporin also in Pakistan. Children are dying there, school children. And we vaccinated the entire Karachi province of Hyderabad province and looked at it, no antibiotic. So the child was not responding to antibiotic also, controlled the disease, typhoid. So showed the first time vaccine can prevent the antibiotic resistance strain also works. That is published recently in Lancet Infectious Disease, recently by Pakistan, Aga Khan University. I think, the game will change now. Can we use a vaccine in antibiotic resistance point of view? This is a field will start emerging out now. And we are looking at as a company strategically in that direction. Antibiotic resistance is a game plan, whether it's tuberculosis or the Salmonella, Salmonella typhimurium, and other meningococcal and other vaccines. So I'm looking at as a scientist, how can I visualize that and move those ideas into the direction? We are moving in the direction, that angle. Thank you. Over.
Sorry, if I can.
Yeah, please, Ram.
Sorry, Samir, you want to go on?
You please, Ram.
Yeah, thanks.
And that's okay.
So thank you, Dr. Gupta, for bringing up the topic of AMR. And I guess, as you rightly said, that's going to be the next big issue or pandemic for all of us to handle. And it's estimated by 2050, AMR could cause 10 million deaths annually globally. So recognizing that, sir, I just wanted to inform you that Johnson & Johnson at a global level has joined, along with 20 distinguished partners to launch the AMR fund, what we call as the Antimicrobial Resistance Fund, which is investing $1 billion, with the goal to bring forward 2 to 4 antibiotics in the next few years. And, I just wanted to sort of exemplify that with an example. And you know it very well, our work in MDR TB. So bedaquiline has been the first drug, in the last 50 years to work against multi-drug resistant tuberculosis. And we are very proud to move forward such a molecule, which is really coming to the rescue of MDR patients. And as I said, when I speak to Dr. Anil Kaul, he is absolutely excited about new mechanism of actions, what we can put in place to, ensure that we eradicate MDR TB from India, or rather TB from India, which is obviously also the vision of our honorable Prime Minister. In terms of vaccines, I definitely see an opportunity for all of us to work together. Currently we are working on the HIV vaccines. There's a lot of work which is going on. Zika, in fact, we have a European approval for that. And also, of course, the next generation of COVID vaccines. So clearly, sir, I see an opportunity for all of us to collaborate.
Thank you, Mr. Samir.
Thank you, Dr. Gupta, and I think you raised a very, very important question. Indeed, vaccinology has moved forward in these past 18, 19 months. And I can tell you a few things about what we've been trying to do as an organization. We are working on a couple of non-transmissible NTDs, like ones, you gave certain examples, and there are certain other NTDs, that non-transmissible diseases that we are working on. to come up with a vaccine approach. There are therapeutic vaccines, cancer vaccine was mentioned, and therapeutic vaccines that we are working towards. And vaccine preventable diseases is certainly a goal that we should be able to, as global citizens, we should be able to prevent every death or disability from a vaccine preventable disease. And I think towards that, not just in terms of developing newer vaccines for newer targets, I think what is also very important, and again, something that doesn't really get such a prominence, and when we talk about how the industry has stepped up to the challenge, is to realize that we've kind of more than doubled the vaccine capacity as a globe in the past 1 year. By the end of this year, 12 billion doses of vaccines would have been produced, which was like about 5 billion last year. And by end of 2022, we estimate, as vaccine manufacturers, we estimate 24 billion doses of vaccines will get produced. Now that is growing the capacity, global capacity, by almost 500% over a period of 24 months or so. Now this is unprecedented scale across any industry that you really look to. And what is also significant is to note that all of this has been achieved while ensuring supply lines for every other disease and every other therapeutic area remain uninterrupted. We faced major, severe challenges as an industry, and yet there were no shortages of life-saving medicines across different therapy areas. You very rightly pointed out, Dr. Gupta, that antibiotics were rampantly misused during this pandemic period. And obviously, for a long time, nobody knew what to do with this new disease. And a whole lot of experimentation must have happened. And that would have also contributed to the growing challenge of AMR. We've been part of GARP, so we know. We are working on a tuberculosis vaccine. We are working on a single-dose anti-malarial drug, a small molecule drug. We've been working on monoclonals for certain infectious and non-infectious diseases. And therefore, I believe the industry does recognize AMR as a significant challenge, as a challenge that it needs to meet. It's not just in developing newer solutions, but in also making sure that our manufacturing processes, by way of seepage into our water supply sources, do not really contribute to AMR. All our biotechnology products are produced through what we call a green gene technology, where we don't use any of the antibiotics, and antibiotics are used in biotechnology manufacturing processes. We don't use any of those antibiotics which are used for human use, so that we don't contribute to antimicrobial resistance or the increase in antimicrobial resistance. Tuberculosis, malaria, these are problems that our country in particular and the globe in general, especially the developing world in general, faces as a major existential challenge in certain civilizations or societies, I should say. And these are areas that we as an organization are committed to. We've been working very hard towards it. And I echo your thoughts when you say that we need to move forward as far as vaccinology is concerned. These new technology platforms that have come about have had extensive academic work that has happened over the past 2 decades or so, whether it is DNA or whether it is mRNA. No issues of biodistribution, no issues of incorporation, no issues of any other such safety challenges. And we know some of these have been used, though not in humans, but in veterinary usage. And we've not really seen any of the initial fears coming true. I believe we need to embrace these new technologies that have come about. And these are the technologies that would help us to address the next big healthcare challenge even more, I would say, faster and better than what we were able to do this time. As you very rightly said, those slides which would now be consigned to history, where we used to say a new vaccine development takes anywhere between 10 to 15 years and billions of dollars, and billions of dollars it has certainly taken, but then it was spread over various stakeholders, and that made it possible for everyone, for all sectors, to really kind of bet on these new solutions. But the time was compressed primarily because we've been working on these technologies for a long time. And what this pandemic has taught us is that we need to have these scalable and adaptable technology platforms, which can yield themselves to a much quicker development. While we talked about developments in regulatory sciences, I believe there has also been significant development in clinical sciences. We now have new clinical trial models. We now have new ways of trying to understand as to how a vaccine or a pharmaceutical product would actually behave when deployed in the larger population outside the trial protocols. And I think these are the learnings that are going to stand us in good stead as an industry, as a company. I would once again like to say we are all committed to causes such as AMR. I know a cause that you hold very dear to yourself. And so it is to all of us, because we all know that AMR can be the next big challenge that mankind would face. And I'm sure the learnings from this pandemic and our response to it would really help us kind of meet this challenge head on. Thank you.
Thank you. Over to Smriti.
Thank you. Thank you. I think very, very engaging. And I think, very pertinent part of our agenda got covered, Dr. Gupta. Very well timed questions from your side. I think both adult vaccination and AMR was something we wanted to touch upon. And I think it has been done justice to. I just realized we are at the top of the hour. We will be closing in next 12 minutes, and Dr. Ella has to leave earlier. So I would just throw open one point as a sort of summary question from my side. I think the point you just made earlier, Dr. Gupta, around the preconception or the established norms around safety and quality been revisited in a very real manner during this COVID crisis, and a lot of assumptions have been kind of taken care of in terms of timeline, in terms of data, the technology being playing a very important role in all of these innovation. I think India as a country can pride upon the fact that it has a history of frugal innovation since a very long time, and I think this frugal innovation has come into effect with a lot of efficiency during this period. How do we utilize and leverage all these learnings and existing good practices within the industry to focus on some of the unmet needs, which we talked about? India as a country needs to prioritize area where we need to meet up some of the expectations from the customer base, which is the patient. Then moving on to adult vaccination in a big way. And I think COVID has taught us that the prevention and the wellness and somewhere repurposing some of the vaccines which are already there. Infectious disease has been a point of focus for us always, given the kind of climate and ecosystem we all live in. How do we leverage this whole knowledge and focus on the adult vaccination and preventives and areas of unmet needs as a country, both from an Indian company perspective and as a global, pharma majors? And do you see that as a big potential for us going forward? So over to you, Dr. Ella, for your thoughts, and then I'll move over to other participants.
I have a radical thinking process. My worry is, if the COVID is gone, what will happen to all this excess capacity that we created? What excess manpower recruited? What is going to happen to all these things? How many companies are going to sustain the facilities that are built in the late, and how are they going to sustain? And I think it's going to be a big challenge for globally, actually. Okay. So I think, having said that, adult vaccination, yes, new field opening up for the vaccination, but it will not happen like a pandemic. Okay, there are a few educated people will take some flu, like a flu vaccine, like that. Some people might take some vaccine, but not in general. Like it's not going to expand. It is still going to be a children vaccine. vaccination is still going to be children focused, unfortunately. That is going to happen. Once pandemic is gone, then everybody is going to forget about the memory. People's memory is very short. What we read yesterday in newspaper, we don't remember today. So that memory is there. So I think our worry is actually as a vaccine manufacturing, we created 3 new facilities. How are we going to sustain this if the pandemic is gone? Today we want more production. Tomorrow who's going to buy the production capacity? And the recruitment, what we have done is going to be challenging for us. Already I'm seeing people movement already from other companies to various places. They're scared already. So I'm seeing the trend happening, okay? So I think it's going to be a challenging period. But what we learned in this last 1 year, how do you scale up? We learned the game of scaling up. And how do you do wonderful clinical research of global standard, not Indian standard alone. It is in addition to Indian standard, it's a global standard. And peer-reviewed journals, everything will learn the game. And I think that's going to put us on par with anybody in the world. And nothing less than us. Our quality standards are all same. We're WHO TRS, whether Johnson follows or Merck follows, GSK follows, everybody follows the WHO TRS or US Pharmacopoeia, all are merged now. European Pharmacopoeia, US Pharmacopoeia, WHO TRS, all are merged. There's nothing different now. So I think, we're coming to that level right now in the vaccine field, mature science, mature manufacturing, mature clinical research. So I think we'll learn the game. And I think we will be doing like as unmet needs, like multi-drug resistance, we're done in Pakistan trial. And we are now partnered with a malarial vaccine to work against multi-drug resistant malarial pathogen. Like that, we're already focusing in different directions. And I think India will do in vaccine, and India will help the Africa. India will help the entire Latin American country and also Asian countries. And we're also looking at how do we move out of India and help the other countries. So I think it is going to happen, and it will happen. Thank you.
Thank you. Thank you. I think that's the answer to the capacity ramp up, Dr. Ella. Once the export starts, I think it'll all fill up. You'll need to put up more lines. I think clearly that's where the answer is. Now moving to Mr. Ranade, I think given your global exposure, I think compared to other countries and more developed countries versus India, did you see a trend of adult vaccination being a potential for Indian market? I mean, does Johnson & Johnson would see India as a potential adult vaccine market in future? What are your thoughts?
Yeah, absolutely. I think, when it comes to adult vaccination, and we know it's a very broad topic and we don't have enough time to discuss it, but I guess a lot of awareness needs to go in, right? Because even today, if you believe or do some surveys, you will find that 2/3 of the Indians feel vaccination is for kids. It's not for adults, right? So I guess it starts with as primitive something as increasing awareness about people and how through vaccines you can prevent some of these diseases. But Smriti, I would possibly go back to your earlier question of, what learnings we had and how we can leverage from here. So one is, and I'll keep it short for the benefit of time. So one is, obviously we all have learned a lot of lessons. I think when we look back, we should be all proud as Indians that we have been able to handle this pandemic given the size of the country very well. We also have learned that there's a need for government and everyone to invest in healthcare, and good to see that investments going up. And one thing which actually struck me, is how underused technology was in all aspects of our life, right? I mean, even as a company, when I look at, we were not really using technology to the extent what we should have. Most of our doctor contacts were in person, but given the pandemic, when all doors were closed, we all quickly pivoted to a technology model, right? Most of the calls became virtual, and today also we are discussing this on a webinar. And technology, I mean, what India really can learn is basically how do you use technology to leapfrog and bring in the reforms in healthcare, and especially in a country like India, which is always going to be constrained when it comes to resource. We would never have enough doctors, enough nurses, enough hospitals to serve all the people in India. But we have seen during the pandemic how the government moved very fast, very agile to put up teleconsultation services in place, the e-Sanjeevani concept of the government of India. I think these have been phenomenal success. Even the COVID, I think we should actually credit the Indian government for creating something like a COVID, which was able to deliver to 100 crores vaccines. Now, these are all great examples which have become case studies in the world, I would say. And I would only encourage that how we can use now technology in much better way to address the inequities in health. So maybe that's a quick summary from my side, Smriti.
Thank you, Mr. Ranade. I'll quickly move to Dr. Ella. We'll let you go. I know you have a hard stop, but it was absolutely a great experience talking to you, sir.
Krishna, just 4 minutes left. 3 minutes. We are just fine. I think
Another one
we
starts at 11 to 3:20 exactly.
Okay,
I'll
no,
quickly
I'm
go
just
to Mr.
joking.
Sameer Desai for his thoughts. I think, vaccination in particular, but overall, I think India being the pharmacy of the world and perceived and in real being one. How do we maintain and sustain that going forward, and also led through sort of innovation kind of engine, and then not only the version we have been historically very comfortable with. Your thoughts, Mr. Desai?
See, one of the significant, I would say, fallouts of the COVID pandemic has been that while everybody knew about India's success story with small molecules and being the pharmacy of the world, as you referred it to, most people, for a change, suddenly realized that 60% of global vaccine demand is also met by India. What it has done is it has brought vaccines into public discourse. Childhood vaccination is something that was left to parents or to the government, and would be a dialogue between the pediatrician and the parents, or in a government hospital where the child is born, a vaccination calendar is provided and a national immunization program just simply runs. But over the last 1.5 years, I think if you pick up the two, if you did the word cloud analysis for the past 18-19 months across the globe, I think COVID and vaccine are the two most important words that have been spoken about across the world. Right? So it has brought about a significant, I would say, awareness that vaccines save lives. It has also, for the first time, created that awareness that adults need to get vaccinated. With COVID, and that was a very, very important point made, we have delivered 100 crore doses to adults in India. We have now a rich database. How does the government plan to use this to create more awareness? The industry obviously will have to work at improving awareness. But then having created a platform such as COVID, where we know who all have been vaccinated, and we possibly, COVID is a very expansive platform, and it has data on various other comorbidities and various other challenges, health challenges that people may be facing. So there is data, there is the backbone now. There are adult vaccination, opportunities. Flu is just one such example. I mean, we were the first in the country to develop flu when 2009, 2010, the swine flu epidemic happened, and now the quadrivalent flu. And I'm sure there are many other opportunities. The industry would certainly endeavor to bring that about. But to maintain the discourse in the public domain and to use the data that has been developed through the COVID platform, I think the government can also do a great contribution in improving adult vaccination awareness, and that would really be a big, I would say, outcome of what we've been able to achieve in the past 19 months. Thank you.
Very well said. I think this sums up the whole sort of topic very, very well. I'll go to Dr. Gupta for his last comments, observations, and then I'll summarize the meeting quickly.
Yeah. I think we have completed the time 3:30. So my only comment is, Krishna Ella, I knew very well. He was a good, dear friend. Now I respect him. And so is the case with Ranade and Mr. Sameer. I respect you. And the respect is because you have done tremendous thing for Indian science, Indian population. And this spirit must continue. And I would say one more thing. We have developed vaccine for corona. We are yet to adopt vaccinology in our day-to-day life, which our Prime Minister says, Safai Abhiyan, cleanliness. And you can just see in spite of so much effort, so much drainage problem, still long way to go. So much of mosquitoes in the day and in the night. Insomnia is one problem, but the dengue is associated problem, I would say. And then when we will get rid of these things, vaccine we are producing for disease. Now, before that, we used to teach, we used to learn about the social and preventive medicine used to be one subject. Now this is time to practice it. So thank you very much. And this was such an engaging discussion. And with the five of you, and Mitra Saab is also here, Smriti and Krishna and Ranade and Samir Saab, that I would have loved to be here for next 3 hours without any drink or without any effort. So much thank you. So much thank you, Praveenji, for inviting me, and wonderful opportunity by Smriti given to me. Thank you.
Thank you, sir. Thank you so much. Really, thank you. It was a very interesting discussion. Smriti, you may like to finally close this.
Absolutely. I have never had such a great a discussion just on vaccine. I've been part of many discussions with Vicky, very meaningful and engaging, and lot to take away. And I've made notes, and we will circulate that shortly. But one thing I would want to sort of say right up front, I think the industry as such has responded like never before, and it has stood its ground. It stands vindicated. It has kind of led by example, and I think this has to continue. As Dr. Gupta said, the innovation led engine has to continue. It has to sort of look at areas of unmet need, equitable access, and affordable healthcare for all. It's going to be a very outcome driven approach, maybe in some time, in future, but that's where we are working towards as a group. And I would like to thank Mr. Ranade, Mr. Samir Desai, and Dr. Gupta for really great comments. Dr. Ella will write separately too. It has been really a pleasure for all of us and audience to be part of this session. Thank you, Vicky, for giving us this opportunity. Praveenji, over to you.
Thank you so much. I'd like to thank Dr. Gupta for his always available to us, and for that insightfulness and guidance. Thank you so much always. Thank you. Dr. Allah, of course, has left, but really thanks to him, Mr. Ranade, and of course, Mr. Desai. Thank you so much once again. It was a very interesting session, and yes, new technologies that are being developed for producing vaccines for mutating viruses, for tuberculosis, for Zika, for cancer, malaria. I think what Dr. Gupta said, there has to be a vaccination abhiyan also, not just for about COVID, but otherwise as well. And I think that really is the need of the hour. And going forward, that should be the overall focus of the government, industry, and as a chamber, we continue to infuse that energy amongst the people. So thank you so much once again, and it was a very nice discussion. We'll join back again on the next session in another 10 minutes from now. So thank you once again, everybody. Stay
Thanks
safe.
for having me.
Thank you, everyone. Bye-bye.
Thank you. Bye-bye.
चलो भैया वैक्सीन करना हम पे हैं स्टैंडला था बायोमेट्रिक का वैक्सीन चल रहा है स्टैंडला दूसरा पंकज पटेल का वो क्या नाम है जाइडस तो ग्रीन वाला 26 का एमएसएल Johnson come on. Johnson की वैक्सीन आ गई
This is always fun.
Dr. Sharma is here. Thank you, sir. We are going live now.
We are live now. Yes.
Good afternoon, everyone. Welcome to another great session on digital health technologies, lessons learned from COVID. This is the 15th FICCI HEAL conference. Today we have Dr. Vidur Mahajan moderating the session on digital health. He's the chair of FICCI Digital Health Task Force and the associate director at Mahajan Imaging, and also the head research for CareIn. Over to you, Dr. Vidur.
Hi, thank you so much everyone for joining. As Shilpa mentioned, I'm Dr. Vidur Mahajan. I run Mahajan Imaging, which is a chain of imaging centers here in Delhi. And I also run CareIn, the Center for Advanced Research in Imaging, Neuroscience and Genomics, where we work with more than 40 research groups across the world on a bunch of very, very interesting things. But more importantly, today I'm joined by a very, very elite group of people from literally from across the world and we'll be spending the next hour and a half talking about how digital health technologies have essentially transformed over the past year and a half, and how COVID may have driven a lot of this change, and how governments have responded, how industry has responded, and what can we do using these same technologies to prevent the scary third wave. We have with us today, chairing this session, Dr. R.S. Sharma. Thank you so much, sir, for joining. It's an honor to have you here. And today is a big day for Dr. R.S. Sharma. We complete 1 billion vaccinations. It's a proud day for, I think globally everyone, because COVID is a global issue. It's not a country specific issue. And I'm sure sir will enlighten us in a few minutes about that. I'll quickly introduce Dr. R.S. Sharma and then introduce the panel, and then we can go ahead with the proceedings. Dr. R.S. Sharma is the CEO at the National Health Authority, the NHA, of the Government of India. He has the responsibility of spearheading the national effort for providing COVID-19 vaccines to the Indian population. He was the first Director General of the UIA, which was the Unique Identification Authority of India, and was subsequently appointed as the chairman of TRAI, the Telecom Regulatory Authority of India. He has, as the first director of the UIAI, he helped create the 12-digit identity number. So he is the creator of the Aadhaar, which is available to all eligible residents in India. And he's also authored a book titled The Making of Aadhaar, the world's largest identity platform, which describes this project. He joined the Indian Administrative Services in 1978, belongs to the Jharkhand cadre, and in 1986 he programs. So he wrote a program in DBASE, DBASE, a programming language that would keep record of all stolen firearms in crime-prone districts. And as soon as a firearm would be found, the program would run a search query amongst thousands of age-old records, and the software enabled the solving of 22 cases in just 30 days. He held responsibilities in his home cadre of Jharkhand, as well as in ministries of the central government, including as Secretary, Department of Electronics and Information Technology, and the Chief Secretary of Jharkhand. On the education front, he joined the University of Allahabad, from where he earned his Bachelor of Science. He completed his Master's in Mathematics from IIT Kanpur in 1978, and while on leave from the Government of India, he earned a Master's in Computer Science from University of California, Riverside in 2002, and subsequently a PhD from IIT Delhi. I think in the interest of time, Dr. R.S. Sharma, if you would like, we would love to hear your thoughts on the subject. How has COVID accelerated the adoption of digital health solutions, about NDHM, about the CoWIN platform. So we are all fans and beneficiaries of it. Would love for you to share your thoughts, sir. Sir, you are on mute, sir.
Well, thank you, Vidur Mahajan, for that very, very generous introduction of yours. And good afternoon to all my fellow panelists and all the people participating in this conference. I'm really grateful to FICCI for
organizing this conference and inviting me as a chair to address during panel session on digital health technologies. I have been a participant in FICCI's various sort of fora, and in my earlier avatar as the chairman of TRAI, I was sort of interacting with the telecom segment of the FICCI, and now of course it's my turn to interact in the health sector and health segment. So yes, first of all, let me say through your forum that it's really a proud moment for all of us today, because today we have achieved a real milestone of 1 billion jabs in the country, and that I think is I mean a very significant percentage of the total human population on Earth. So that's the way it is, and the real credit of that goes to all our doctors, our health workers, our nurses, our vaccinators, who have been assiduously and continuously working since last 9 months. As you know, our Prime Minister launched this program on 16th of January. So it has been just just little over 9 months. And it has been a phenomenal journey, starting with 200,000 on that day to 2.5 crores, that is 25 million on some of the days. And of course, many days we have done more than 10 million in a single day, those vaccinations. And interestingly, we have created a very, very scalable, robust and interoperable platform, CoWIN, which actually tracks the vaccination progress in a real-time basis. Not only that, it also ensures that the guy who has got a first dose of vaccine X will be reminded for the second dose of the same vaccine. He cannot get any other vaccine so as not to mix up, vaccines, which is currently not advised, at least. And of course, he shall be reminded when the vaccine becomes due. He has the freedom to get vaccinated anywhere in the country. So which means that I can get my first jab in Delhi and second jab in Calcutta. There's no problem on that. It's entirely portable, the whole system. So it's a single source of truth in some sense. And actually we have a very, very granular data on each individual's vaccination history. And we made this platform inclusive. We made this platform interoperable, and we made it based on open APIs, with the result that we could now connect to more than 100 partner applications, which actually people are able to book reservations, book their slots, vaccination slots, book their, register themselves on the platform. So I think it's a fairly interesting platform which we have been able to create during this pandemic. And the idea, of course, came from our Honorable Prime Minister, who said that it's not a small number that you are going to vaccinate so that you can monitor it on a piece of paper or some Excel sheet or something like that. It's a humongous effort of vaccinating 1/6 of humanity. And therefore, it will require a very robust technology infrastructure. And that's what we actually ended up creating. So that's one part I wanted to share with you. The journey has been extremely interesting because initially people had a lot of suspicions, and many channels in this country, they started saying, no, it's not working, it's failing, it has glitches, and all kinds of stuff was rumored. But then all those rumors were false, and we have steadily continued to on the promise of scalability. Then of course, this other news which came some time back is that the Britain had approved the Covishield but had concerns on our certification process. And that was quite a news to us, because that really never happened. None of the British, UK people at the diplomatic level, at the ambassadors, at the high commissioners level, nobody had raised any objection. In fact, we were trying to understand their system. They were trying to understand our system. But unfortunately, such news just was created saying that they have a concern, and it was later clarified. In fact, our certification process is absolutely digital certification process, which is verifiable, which is auditable, and which is encrypted, QR coded, transparent, everything is there, and it is as per the WHO standards, or whatever the data elements are required to be done are there in that certificate. So the compliance to the world standards is there in our certificate. This platform enables people to publish their vacancies, the hospitals to publish their vacancies, downloading of the digital certificate of vaccination, registering, searching for the vacancies, ensuring vaccinators to the vaccination. So this actually is something which is a result of this pandemic. So there have been, obviously this pandemic has been a disaster for the world, but then there are certain positive outcomes also of this pandemic. Every crisis has got some positive outcomes. So this is one such outcomes, and the vaccination, as you know, has been going on at extremely fast speed. Of course, we have a huge challenge because 1 billion is more than the population of entire a continent of Europe. So that's how that's the scale of this, the magnitude of this. Now, COVID has also taught us multiple things. One is that it was very difficult to go out in these times. So even if people had some sickness or some illness, they were afraid to go out because they were afraid that if I go out to the hospital, I'll probably catch COVID. So that's one. Elective surgeries, elective other kinds of things were put off. Every hospital was converted into a COVID hospital. So I think we have seen really, really very, very bad times. And the second wave hit us like a tornado. And actually it created a huge amount of disruption in our entire lives, and the entire country was dealing under that kind of disease or that kind of pressure. Now, this also brought us the fact that there are different ways of conducting meetings, conducting interactions, and one such way is what we are doing now. Meeting on the video conferencing, because in normal times we could have sat together in a hall or something and spoken and then had a cup of tea and probably lunch. Enjoyed conversations freely among ourselves. But now, we are doing it on the internet, on the web. And interestingly, we started liking it. We have now become very comfortable with it. It was like speaking before a camera was definitely quite unnatural and difficult, sort of thing in the beginning. But now we find it absolutely natural, and it looks as if we are all sitting in the same room and we are in front of each other. So what has happened is that COVID has also taught us that digital technologies can be used for many interactions. Now, looking at the health sector, I think you will all appreciate that the health, health kind of episodes have a number of stages. The first stage is that you consult a doctor, and then, of course, doctor prescribes you certain tests, and those tests get done, and then you show it again to the doctor, and then finally, doctor prescribes you medicines. And in an extreme situation, doctor also prescribes, and okay, you get yourself admitted in the hospital and get operated upon, or there will be some other reasons also. So hospitalization is only one of the stages, and almost everywhere, in every case, the last stage as in, in the whole interaction, if nothing works out, then they say, okay, going for surgery or going for hospitalization. Now, then we should realize that like all transactions, prior to the hospitalization, prior to the operation, it is possible to conduct all these transactions online. It's possible to conduct transactions through video conferencing. So this is how this whole concept of digital health started. In fact, the Honorable Prime Minister had made me the chairman of a committee, which is what is called Platforms Development Committee. In the initial period, probably it was in January or something like January of 2020, something around that time when the first wave had come, not January, March, April 2020. So there what happened was that, there were a lot of eminent people, Mr. Chandrasekharan of Tata Sons and Mr. Mahindra of Tech Mahindra, they were members, many principal scientific advisors, etc. There I got the idea that, look, the video conferencing will be very, very useful. Video consultation will be telemedicine, whatever you call it, will be very useful in these difficult times. So we started, I started thinking of a project, and then, we went ahead, and then the whole idea converged into what we call the digital health mission. So the digital health mission basically now, seeks to build on whatever digital infrastructure India has built. Now, some people ask me, why can't every other country do the digital health mission or digital use of digital technologies, the way you plan to do? And my answer to this is that India, during the last decade or so, has built certain digital public goods at a scale which actually enable this play to happen. And let me explain to you. So one is that in any digital transaction, what you require is to fix your identity. Because unless you are sure as to who is the person to whom you are talking on the other side, and this is not, among yourself who know each other, but you have to fix your identity. And India has created Aadhaar, the digital identity infrastructure, and it's a digital thing. It's a number, not a card. It's just a, you can plug this. It's available. It's authenticable online in a remote manner. It's actually possible to get the electronic KYC. So that infrastructure our country has built. That infrastructure will be useful, will enable digital interactions in a trustworthy manner, because I think in any digital interaction, what is also important is the trust. And the digital trust, which if it can be established non-repudiably in a transparent manner, then that is the best thing to happen. So that India has got. Then, of course, when you consult a doctor, you have to pay to the doctor his fees. I mean, just I'm relating as to how the digital public goods which India has created, how they are actually enabling these things to happen. So if you pay the fees, and India has developed what is called UPI, the Unified Payment Interface, and that UPI we are doing more than 3 billion transactions a month, worth 600,000 crores. So this is the, you can pay digitally. Basically, you can't pay cash when you are consulting a doctor from afar, Bombay to maybe Bihar. Then you can't just sort of send cash to him. So basically, digital payment system is there. Then, of course, you have to see the record of the patient, and that record of the patient requires consent. As you know, in a digital world, data consent is absolutely necessary. And India has created another public good called digital consent artifact, which essentially ties to your digital identity and ensures that you are the one who has given consent. So you can share your previous health records and other kinds of documents with the doctor with your consent. So that is privacy preserving, consent preserving. Then finally, doctor writes a prescription to you. And that prescription also has to be digitally signed in case you have to get medicine on the basis of that prescription. So then it has to be digitally signed. Now, India has created another artifact which is called e-sign, which means without using any dongle, you can digitally sign a document because your identity is on the cloud, and therefore your what is called the key pair, the digital signatures can also be downloaded each transaction, and you sort of sign that document. Where with that can be presented to any pharmacy to get medicines, and pharmacists cannot oppose it because this document is digitally signed, which is verifiable. So therefore, that digital signature is also available. So as you will see, the entire range of transactions are possible because India has made those digital public goods. Now, on to the connectivity. India now has, and connectivity is also an extremely important prerequisite because you can't have video conferencing if you don't have connectivity. So that connectivity, India has 1.18 billion phones. India has got 700 million, more than 700 million internet connections. India has got more than 600 million mobile smartphones, and smartphones growing at the rate of 25 million a quarter. So this is, I mean, I understand that it's not a great infrastructure. Let me tell you, great in terms of quality, because what happens is that wireless, it's all wireless infra, it's all wireless connectivity. Very small portion of this minuscule portion of only 20 million is the wired or fiber connectivity. Of course, fiber connectivity is increasing now. But because of the wire being connectivity, you always have, for example, in this conference also, you are having low bandwidth and, kind of people are going out and coming in, that kind of thing is happening because of the reliability. And wireless is obviously less reliable than the other part. But I think broadly, this connectivity has gone down to rural areas. And today, data rates are the cheapest in the world. India is wheeling to 8 exabytes of data. The per capita use of data is 12 GB per month per person. This is the highest in the world on a mobile network. So I think India must be the only country where people are watching films on the mobile. In their fields, sitting in the villages, and they are watching films. So essentially, because the low cost of connectivity, because the ubiquitous connectivity being there, because of the penetration of the smartphones, it becomes possible now to conduct video conferencing in a very easy manner. So essentially, all the elements, of course, you have the jam trinity, Janadhan, Aadhaar, and mobile, whereby every Indian, 82% of adult Indians have got a bank account. And this is actually more than many developed countries in terms of percentages. So this is again very, very interesting, thing. So we have jam trinity, as the Prime Minister, coined that word, Janadhan, Aadhaar, and mobile. So Janadhan is like a financial account, Aadhaar is identity, and mobile is the device to communicate. And this becomes an extremely powerful trinity, which can enable all kinds of transactions. So this is what we have, and that actually makes it possible. So what we are proposing to do in the digital mission, the digital health mission, is essentially, first of all, utilize the underlying horizontal, public goods, which is Aadhaar, which is e-sign, digital locker, electronic KYC, authentication. These are, and of course, the latest one is e-rupee. E-rupee is basically a purpose-specific and a person-specific, voucher. So I can pay to somebody a digital token I can give for vaccination. Now that person can use that money only for vaccination, nothing else. So it's a person-specific and purpose-specific instrument, which is being done. So that actually, this is the base layer. Then, of course, on top of that, we are creating registries of doctors, registries of the facilities, registries of drugs, all those, domain-specific registries. And on top of that, we are creating what we call unified health interface, which means that, this will be a gateway to all these registries down below. And of course, the accessing all these, what is called horizontal facilities. And on top of that, you will have applications. And we are developing this as an interoperable network, which means that it will not be like a silo network. It will not be like an Amazonification of the whole, health sector. No, it's going to be any application. You can use any customer-facing application. It will actually show you all the doctors, all the hospitals, all the drugs. And so any platform can be below, any platform can be above. It's like UPI. UPI, as you know, is one of the specifications of protocols, which actually unbundled the payment system from the banks. Similarly, this is going to unbundle the entire, it's actually going to unleash the value of non-silos or in interoperable systems, like CoWIN has, for example, done. CoWIN is also a completely non-siloed interoperable application, and it is scaled up to 1 billion. Similarly, the scalability will not be a problem. Diversity will not be a problem. Language will not be a problem. So this is how we are going to structure and construct the digital health mission. And I think the entire healthcare fraternity must really, support this move, because this move is not for government. Typically, the project is for the government, by the government, and of course, not for the government, for the people, by the government. Now, this is a project where every private sector entities will have to participate. They have to really come together to make it a success. And I think this country has shown that we can develop these platforms, we can make a success out of them. And ultimately, this will reduce cost, because it will reduce transport, travel from the people. It will utilize doctors' services much better. So it will reduce cost, it will be becoming more affordable. It will also become accessible, because the distance will collapse. It doesn't make a difference as to where you are sitting and where the patient is and where the doctor is. So distances will collapse, which means that ubiquity, it will actually benefit people in the remote rural areas. And ultimately, it will improve quality because one can put in expert systems, AI, machine learning, all those kinds of systems can be put on this platform. So I think we must leverage technology to the best possible extent to deliver quality and affordable and accessible healthcare to our people. And that's what is the vision of the Ayushman Bharat Digital Mission. I wanted to share these two things with you, the CoWIN application, CoWIN platform, and also the Ayushman Bharat Digital Mission. You are all familiar with the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which is actually the largest insurance and assurance scheme of the world, which benefits 540 million people. We are making all kinds of improvements in that, revising the rates, empaneling more hospitals, and of course, ensuring that the payments to the hospitals are done in a very, very quick manner. So these are some of the thoughts which I had on the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which I have already shared with the members of FICCI at various points in time. And we will continue to consult you. We will continue to be open in the digital health mission. Also, we have actually issued 3 consultation papers. One is on the unified health interface, one is on the facility registry, one is on the personal records, personal health records. So all these papers are out, and we have had a very, very vibrant consultation process, and we always will remain consultative. We always will, because we believe that the industry knows much, much better in many areas than what the government or what the bureaucrats know. So I'm aware of the limitations which we have, and we would like to supplement our limitations with your capabilities, your knowledge, deep knowledge, your wisdom, and your experience. That will be very, very helpful to us, and together we will make this happen for our country people. Thank you so much.
Thank you so much, sir. And sir, before we let you go, just one question or comment on, to do all of this, we need a lot of the technologists in our country to switch over from non-healthcare to the digital health domain. So if you could say something to all the youngsters out there at our engineering schools and, who are studying in universities, to kind of get them to switch over from e-commerce to, say, digital health e-commerce, or that movement, what would you say, sir?
Well, I think this is a very important question Vidhu have asked, and I think it's really contextual in the sense that the difference between a silo platform and the network which we are creating, I'm not calling it a platform, is this that in a silo platform, as a startup, you have to build everything yourself. So, for example, if you are a 1mg or a Practo or some other startup in the health sector, what you have to do? You have to get hold of some doctors. You have to get hold of the professionals. On the supply side, you have to arrange for doctors. On the demand side, you have to allow, you have to ask people to download your app, right? So you have to arrange for everything. You have to get the customers, you have to get the suppliers, and you have to get the, for example, you need some doctors to write prescriptions. That's what you can do, and you can tie up with some pharmacists, so supply the medicines. This is how all the e-commerce platforms work. On a let's say on the Amazon, you have to have sellers and you have to have buyers. If there's no seller, no buyer, the platform is vacuous. The platform doesn't operate at all. But for becoming operating this platform, you have to design your own APIs, which are proprietary. You have to design your own, you have to get your own sellers and your customers. You remember Zomatos and the Swiggies, initially they had to run around the restaurants to get them the business, get them on their platform. Now the restaurants are running around them to please take us to our customers, and the customers have been disconnected by this intermediary from their suppliers. Restaurants don't know who their customers are. This is the world. This is the way world is operating. Now, what we are saying, friends, this is a ready-made network. You have access to the entire country's, doctors' registry. You have the entire country's registry of drugs. You have the entire country's registry of hospitals. Now, when you build a solution, you just build that layer and you just plug it. So now you don't have to do the entire thing yourself. it has become very easy for startups to plug into this. And we have a very vibrant sandbox operating in National Health Authority, where we have more than 450 people participating, 450 entities, and many of your here participants in this conference will also be integrating with our sandbox, because what we are saying, you just conform to our APIs and you are good to go. So you don't have to build the entire thing. You just have to, whatever part of the solution you are doing, the rest is all available to you as a digital public good. So this is what makes a startup flourish. This is what should happen. And this is what we propose to do. It's a non-discretionary network where all the startups are welcome. And I'm sure many of your startups, and we have a brilliant set of people, let me tell you, when it comes to innovation, when it comes to these things. Given a chance, our people are second to none in the whole world. And I'm sure we will all be able to come together. We have to provide the right environment to them. We have to provide right incentives to them. We have to provide right incentive alignments to them. And that should happen. And if we are providing a platform, I think we should be able to get them on board. So I like to say that, look, this is a great thing which is going to happen. And if we can do it, well, this will be a great transformation for the delivery of health services in our country. But then the question is, if we can do it, that's the big if. And that if will be sorted out only when all of us participate actively with a real good heart, saying that, look, my objective in life is okay. Earning money is one part of the objective, but other objective in life is to help people, help the needy people. And I think you have many people amongst you, your fraternity, who are really doing so well for the society. They have done much better things for the society, and that should be the spirit of all the startups, all the participants involved in this game. Thank you so much.
Thank you so much, sir, for that inspirational, lecture. It's always a pleasure to hear from you. And I was especially excited given that today, the 1 billion jab also happened. So thank you so much for joining us, sir. It's an honor. Thank you.
Thank you very much, Sidhu. Thank you very much, friends. I'm sorry I had to log out because there are some other, I'm in Ranchi, I'm not in Delhi, so not very sure whether I'll be able to participate, but
please. Thank you so much, sir. Thank you.
Thank you very much. Bye.
So folks, we'll move on now to the latter part of the session, where we'll start speaking to the elite group of people that we have here. So I realized I missed out introducing everyone, so I'll get that done first. So maybe the way we'll do this is I'll very briefly introduce each one of you, and then if you could speak for about half a minute to a minute about your work, about your passion. I always feel that sets a lot more context to a discussion. So we'll start with Tav, because that's the order I have here. So Dr. Tav Pritesh Sethi, he's an associate professor of computational biology at the IIIT Delhi, and he's a fellow of the Wellcome Trust DBT India Alliance at AIIMS, and he's also a visiting faculty member at Stanford School of Medicine. Tav, why don't you tell us all a little bit about yourself and your work?
Thanks, Vidhu. Thank you for having me here, and I'm so excited to be a part of this panel. Thank you for that. My background is in medicine, but for about 20 years now, we've been working on the space of data and building models for the bedside. More recently, we started working towards public health solutions, building public health solutions for the public good. So in the last couple of years or so, we've been working with data, including COVID, building systems that can be then put in place for the masses, starting from informational systems to early warning systems for pandemic preparedness. And I think I'll talk about it more later. Thank you.
Sure. Thanks, Tav. Thanks so much. Next up, Mr. Jan Hersoff, who is the president of Elsevier's global healthcare business, which delivers information analytics solutions to hospital systems and academic institutions. Jan, would love to hear again a little bit about yourself and your work and your passions.
Vidhu, thank you so much. Very honored to be here. I remember last year when we had the panel, we were at a very different step during the pandemic, and we had a very very, very good conversation. So I'm really looking forward to the panel today. So what drives me is really, from the start, I have always in my working life worked in healthcare. It's extremely purposeful, as Dr. Sharma mentioned before. It's one of the most purposeful domains you can work in to help society. So when I look at my background is in information infrastructures, so I'm really excited about this interlink between healthcare and technology that we will cover also more and more today. Yeah, so really looking forward to our discussions today.
Thank you, Jan. I will certainly ask you about information infrastructure, in due course. I think that's first time I'm hearing those two words together. Next, we have Ms. Sigal Atzmon. Sigal is the founder and CEO of Medix Global, which manages 7 million patients across the world, across 90 countries. They have offices in 13 countries. Sigal, a little bit about yourself and your company and your work, please.
So I have a little story. Being always passionate about healthcare, even when I was a child, I actually wanted to become a doctor, but I wasn't the best student in class. I do not share that with my children, I admit, but God bless, they don't listen to all my presentations. So I went and studied law and economics and went into the world of finance, had a great executive career, ended up managing a book of investments of $4.6 billion. And I'm married, I have 3 beautiful children. And after my 3rd child, I said, okay, Sigal, you need to revenge in life, and you need to show your children that if you have a dream, it is never too late to give it up. So I still didn't think I was smart enough to become a doctor, and I didn't go and study medical school. I was also not young enough anymore, I assume. But I did decide to take all the knowledge and mainly the passion and to connect with that meaningful purpose of driving globally the democratization of healthcare, reducing unwarranted healthcare variations, improving inequalities of care between doctors, hospitals, cities, countries, regions, and basically back 15 years ago, at the end of 2006, I founded the Medix Group, which today, as you very nicely shared, services millions of customers in over 90 different countries, 20 different languages, with real medical operations in 13 different countries. I have to say India is very close to my heart. There are days, and this is absolutely one of them after having heard Dr. Sharma's introduction, but when we look at what India has achieved, I would be very proud to be an Indian, and there are days I regret I'm not Indian. And that day was when, as a first nation, India exported and provided free vaccinations to its neighboring countries, understanding that COVID-19 is not a problem just of one country, but we have to collaborate, and driving that digital health mission, getting the data and getting this health ID in place for such a big nation is something that should be more spoken about in the world. And I try to be a very strong ambassador of India's achievements alongside the struggles and the hurdles that it had to face as such a big nation during this pandemic. So I'm proud to lead the Medix Group today to democratize healthcare, and even more proud to work very tightly for the Indians and with Indian leaders.
Thank you so much, Sigal, and it's very gracious of you. Your passion is obviously very infective. So next up, we have Mr. Brandon Robery. Brandon is the CEO for digital health at the Aster DM Healthcare Group, and he's been, across. He's been an investor. He's run providers. He's done insurance. So Brandon, a little bit about yourself, please.
Sure, great to be at Aster. Frankly, I think Dr. Sharma took my pitch. Accessible, affordable healthcare for as many people as we can get it. That's what Aster DM Healthcare is all about. That's what I'm all about. And I think via via digital technologies, we'll be much further getting on there. Like you said, I've been around the space in many different aspects and look forward to talking on the panel today.
Nice. No, thanks, Brandon. So, Brandon, why don't we start with you only? You know, like I'm sure, like you have an interesting perspective, having worn so many hats over the past, you know, uh, well, I was going to say several decades, but I'll say a couple of decades now. Why?
Ouch! Wow, really? We're gonna go there already? All right, keep going.
No, so digital health, coming back to track. How do you see from all of these perspectives, you know, what are some of the changes? We know the changes that COVID has brought on board. What are some of them, and which of these changes do you think are going to be sustained as far as digital health solutions go?
Yeah, I mean, when we talk about digital health in the land of COVID, first of all, hats off to all the COVID warriors over the long term. I'd be remiss if I didn't thank them, not obviously just at our provider network, but around the world. They've done just tremendous amount of work for so many. So having said that, though, the silver lining, like Dr. Sharma said as well, is the much more rapid adoption of certain digital technologies and behavior change amongst us as, you know, amongst the clinicians, amongst patients, amongst consumers, et cetera, that probably took it at least a decade further than it would have otherwise. Frankly, because we had to, right? That's when we change as humans, is when we have to, not when perhaps we might want to. So some of the things that I think that we're seeing, and we're not seeing the adoption drop off significantly, sort of, I don't want to say post-COVID, because we are still in the middle of it, but we're seeing just the entrance into regular virtual care, right? Virtual care is not a new thing, but the adoption rates are a new thing. We were standing this up 15 years ago in America at a different company that I was working at the time. It was nothing remotely like this, and so we're seeing that. We're also seeing the ability and the adoption rates of home care, home labs, all of those kinds of things where they're not going away. It's a whole new world because people are expecting that to come, and you're seeing generational changes as well, which continue to make that happen. It's pretty exciting. Obviously, for a guy in my line of work, maybe it's a little bit selfish to see that and say that, but what it also gives us the opportunity to do as providers is to spread a asset-light, low-cost model much further amongst many other geographies where we would not have had a chance to do such. That is me, right? That's the kind of mission that I'd like to be on, is being able to do that, not just across the Gulf Coast countries, not just across India, but many, many other places where people still don't have great affordable access to healthcare. And I think we're seeing that happen.
Well, that's super interesting. So you're saying that a lot of these trends, you know, of home care, of virtual consultations, etc., are not seeing a decline now that, you know, we're kind of coming back to normal. So how is Aster, you know, like what are some of the initiatives? Like, are you ramping up these initiatives significantly, or are you waiting and watching? Like, how do you approach it from a strategic standpoint?
So right as COVID hit, every provider in the world ramped up significantly. And part of that was just due to nations, regulators, and rules saying, do what you have to do to care for the people, right? We were all, remember back then, it seems like a long time ago if you've been in healthcare, but it wasn't that long ago. Just do what you have to do by whatever means necessary. So we could cross geographies, we could share information, do some things that weren't technically allowed before. Now we're coming back and we're having to revamp that. So what caught on and the things that we have ramped up are, you know, the ability to launch apps and have a virtual care network, people to have their medical records and information in the palms of their hand, an ability to connect pharmacies, clinics, and hospitals all together where you don't have to go and, you know, re-register at one or the other, so it's actually all seen there. Not just at Aster, right? You look at different countries, different governments, different provider networks are managing them in different ways. And what we're seeing now is a coming together, a sort of greater collaboration amongst those data sets now, if we can do this the right way, that will then move us even farther forward. Obviously, as we have these data sets, we can do really, really cool things, which much smarter brains than me can talk to you about all the interesting algorithms we're laying on top of those to drive what we're going to drive. But I'll save that for the super tech geeks out there.
Oh, thanks, Brandon. It's super exciting, and as I'm sure, like all of us have been, very very excited at how quickly people have switched from like a brick and mortar to a virtual world uh, in terms of just accessing healthcare. And a byproduct of that access is, of course, the data, as you mentioned. And, Tav, I'd love to bring you in at this point. Like, your world is data, it seems. You did a lot of work with the government, right? So for those who don't know, Triple IT Delhi is a Delhi government engineering school, university. Tav leads the healthcare entrepreneurship wing there. The computation, it does a bunch of work in computational biology there. And can you tell us about the work you did with the Delhi government, and also some of the work you did with, just multitudes of data that you acquired from places that one might not think there would be significant data?
Sure, Vidur. Thank you so much. I think um, the work actually began much before COVID, when we were thinking about how do we bring the right information to the right people in the right format at the right time. And that started with our work in ICUs. We were working in the ICUs. We realized that nobody reads WHO documents, even doctors don't read it, leave alone the common folks. So essentially, we were building machine learning systems that would match what is happening, what is interesting and happening in everyday news, and match that with what the WHO documents were saying, and basically use summarization approaches, AI, to summarize it, provide it in a text-to-speech format as bite-sized pieces of information. So when this was before COVID, about a year before COVID, when we started doing this about WASH, water sanitation and hygiene. But this became really important when COVID struck India. And so our application, the WASH Karo app, was one of the first apps in the world to use AI to bring an informational system to public and deliver it in their own language in Hindi as bite-sized audios, so that common people know what to do, what not to do. Remember, COVID was and is an infodemic as much as it is an epidemic. So I think one of the things that started early on was to how to create the right informational systems that can then impact public at scale. And that work led to more with the Delhi government in terms of bringing the COVID, helping build the COVID Delhi Corona app, which was the Delhi government's official app for the people of Delhi. But also while doing that, also bringing and building the data systems in place. And a lot of this was not just with the Delhi government. We also worked with, for example, the Principal Scientific Advisor's Office to work with how to put the data interoperability in place so that researchers and hospitals start exchanging COVID data in frameworks that are NDHM compliant. Today we heard about the NDHM. So we built a platform which allows NDHM compliant exchange of data, how to build models that can then also be shared across people. There's about 400 models that were built for COVID, but how do we create a sort of a zoo for COVID-19 models and leverage on top of that? And we built our own models also for scenarios such as how do we predict the surge that might be coming up using genomic data sets. So essentially looking at the book of the COVID virus genome and reading the changes in the genome using language models, same kind of models that are used by Google, for example, to predict which word is likely to be typed next. So building those kind of models and looking at trends to predict surges, and then triangulating information from other sources. So essentially what we have been doing is that we know that there wasn't enough data and agile data available to a lot of researchers. So how do we triangulate a lot of information from genomics to social media to data that we can get from feedback on apps, and create better pandemic preparedness solutions.
So just one follow-up on that, do you think there was like a fundamental change in the way the government was largely open to predictive modeling or advanced analytics techniques? Do you think COVID has driven that perceptional/behavior change as well?
Absolutely, yes. I think it brought us all together. It brought together government and research organizations. It brought together research organizations and clinical organizations. So clusters were formed. One of our efforts was actually a cluster effort, where the Delhi cluster was seeded as to tackle the issue of COVID-19. So I think, and that was an initiative seeded by the Principal Scientific Advisor's Office, where we realize that there's a lot of potential in and around Delhi in terms of research as well as technology and clinical expertise. So how do we come together and then engage with the government hand in hand? And not just with government. In our cluster initiative, it pushes us to actually engage with industry as well, so that some of the solutions that come out as a dovetailed effort between different organizations actually get translated in the hands of industry partners as well. And this happened via the openness and a push from the government sector as well. So I think absolutely there was very proactive engagement from the government, and government was open to, I see a lot of initiatives where data sets were opened to researchers and are also being open as more proposals are being invited. So certainly, yes, this has led to a very different space, which is starkly different from pre-COVID times in terms of government's openness to building models and looking at models and opening up data sets.
No, great. Thanks, Tav. I'll bring in Sigal now. So just carrying on that thread, as we spoke, like you handle data from patients from across the world. How do you, from your standpoint, like how has COVID transformed the ease of handling the data, or has it become more difficult because there's just so much more data? How do you think about this, Sigal, from your perspective, and like what are some of the questions that your teams come to you with in terms of data handling? You're on mute, Sigal, sorry.
So I think that something tremendous has happened, and although the price has been terrible from an economical and human life, the toll has been really terrible, but something fantastic in a living history. We're living history, actually. And it's not just data that has suddenly arisen and everyone is accepting data. Everyone has changed. And the collaboration between the different stakeholders has been tremendous, whether it's within country, within a nation, or across the world. So we see all different stakeholders, from government, who has been, as Brandon said, suddenly opening up and saying, just take care of my people, because they suddenly understood they cannot deal with it alone. And all countries unprepared, budget-wise, hospital-wise, infrastructure-wise, data-wise, digital-wise. So they said, we need help. Payers, private or non-private, all had to step in and say, what are we doing? How are we covering? How are we providing services? The different providers, as I said, and the patients. The patients suddenly said, we need to understand our situation. What is our risk? Am I healthy? Am I not healthy? I need to control my clinical pathway, because I cannot just say and lay back, if I get sick, my insurance or my HMO or my government will pay, I will go and see a doctor. That didn't work anymore. Everything was shuffled and changed. And suddenly you have customers, patients, people who say, I want to own my data. I want my data to be organized. I am willing to share my data, and I want my decision making to be influenced by accessibility, affordability, and data sets and points that are going to help me get the best possible medical care in a situation of need, but on demand and from the comfort and the safety of my home. So all stakeholders have waken up one morning and said, okay, there's a very big drama happening. We need to change. The mindset has changed, and we need to collaborate and work together to survive, simply. Now, I think we're not post-COVID, but we're post the survival mode. And everyone is looking left and right and saying, okay, how are we continuing to collaborate, and how are we going to get stronger out of this situation? And on the data side, it's not enough to have data, and it is very important to use data to predict and to analyze, but data has to clearly become an input for managing any kind of health crisis, not just to predict, as I said, or alert as to what is coming, but actually to use it in the process. And I'll give an example. And we first, to be honest, did it in India. When the big wave hit and India was really having so many deaths and people couldn't access hospital beds and ventilators, we were thinking, okay, it is not enough anymore to provide primary care telemedicine, because you don't have enough doctors. You need to prioritize your patients. All the doctors were busy. Hotels and elderly homes turned into COVID hospitals for medium severity patients. We don't have what we need to even manage this. So what we did, and medics came up with, is we developed an algorithm that would ask in live, through the app or link for people who don't use smartphones, etc., a questionnaire. What is your temperature? How many breaths per minute? If you have an oxygen measurement, pulse oximeter, you can. A lot of people had that in India. Give us when were you diagnosed with the first symptoms? Because we know, for example, based on data, and TAV will support that you get worse and then you get better, and on the 5th day there's a turning point. Either you're going to go south or north, right? And so people would, at home, without talking to a nurse or a doctor, just fill that live digital questionnaire in, push submit, and that would reach our telemedicine primary care COVID-19 doctor center, nurse and doctor center. And these patients, by an algorithm, by using simple computing, which is not complicated, and I urge everyone out there that is listening, all the young people, to say AI data can work for you, and it is not so complicated. It is for very smart people like Tav, but also for simple, passionate people about healthcare. And the system triaged and said, based on emergency and urgency and the severity of the situation of a person, based on comorbidities, based on medical history, based on symptoms, that person would be directed in the line. So he could jump everyone else and get to a doctor or to a nurse or to a medical coordinator who has very clear guidelines based on the Indian guidelines, and would be decided whether he can wait 5 minutes, or because the lines are pretty packed, or he has to jump everyone in the line. So data is important, but it has to become practical, and it has to be put to work for the patient. And we see the patients wanting that. We see the providers understanding that it's efficient and cost efficient to provide these services. India definitely has the brains, the computing systems, now the databases, and the people who really want that. And it cannot stop with primary care. It has to continue. So digital health has and is continuing, not just with primary care, to specialist care, to disease management, chronic disease management, rehabilitation. I'm very proud to see Brandon nods and agrees, because his speech was very inspiring. And I'm like, okay, Dr. Sharma said everything I wanted to say. And then Brandon topped that up and he said everything I wanted to say. And I'm like, I don't have anything to say anymore. But he nods, so this is a compliment, right? And it has to go all the way through rehabilitation, and it has to touch every person's life. We have to understand that people need to be more involved in the decision-making process. They need to choose how they're going to consume and be provided their healthcare services, and it needs to be quality-driven, affordable, and more accessible. And we're living just that. So really, I think the relationship of the doctor-patient relationship, I'm sorry, Brandon, it just comes a lot of providers don't always like that. It's over, finished. We see the birth of a new patient-doctor-hospital relationship, and we will see virtual hospitals beyond the brick.
I think Shigal, that's amazing. You know, like you put the entire healthcare continuum on a virtual platform, right? And made it seem like it's indeed possible with a layer of, you know, AI, machine learning, you know, algorithms on top. I'll just bring in Yan, you know, just in a bit, and then we come back to you for sure, Sigal. Like, and you know, we could all talk about this. uh, so, Jan, you mentioned information infrastructure, right? And you mentioned that that's like your passion. That's and Elsevier, I think it's about 150 years old now as an organization, and you are the, in a way, harbingers of information, or you know. And with this whole data coming in, how does a 150-year-old organization, how does COVID affect its digital transformation? I know you know, and we talked about this last time as well, like, you know, digitization is now at your core, and not just, you know, digitization of data, but also digitization of education, right? So would love to hear from you, you know, what Elsevier is up to, right? And how you guys are thinking about this, and then downstream, how does what Elsevier does translate to the medical education side of things, and thereby the patients that these, you know, future doctors are going to be treating?
Thank you, Vidor. Yeah, when I look at, so as you mentioned, we have an amazing legacy of providing the most trustful content, medical content, to the world, to the communities, to the healthcare communities, including Lancet, Grey's Anatomy, Netta. All of these are examples for this strong legacy. Now, and it also shows again, you know, the importance of trusted evidence-based content, as Dr. Sharma mentioned before. Also, the digital space is, of course, becoming more and more important. Now, when I look at the digital, you know, when we look at digital health, it's of course a continuum from education of the doctors, of the professionals, to the clinical space, to the patients. And I look at our transformation over the years. The first step was really in relation to, you know, just digitizing the content that we have, the basic solutions that we had for the students, for the doctors, for the nurses, to provide them information. But that this transformation, in fact, has been mostly completed even before COVID. So we had already more than 80% of our business in digital form. Now, what has changed during COVID in different areas is really this next level of transformation. And I can give you a few examples of that, and also how, especially how we have applied it in India. We have been in India now for more than 20 years and have a lot of you know, capabilities in the country on that. So when I look at through the lens of COVID, we already at the very beginning of the pandemic provided digital resource centers to the community, to the researchers, to the healthcare workers, but then also very quickly launched also complete local versions for India specifically, with India specific guidelines, etc., to provide here the support. Then we moved in education. We provided not just very basic, you know, digital content, but more and more tools that really engage the students and improve the learning outcomes. So think about anatomy. You know, learning anatomy from a textbook is of course is important. Every doctor has done it for many years. But the combination of this content with, for example, 3D augmented reality kind of delivery modes, that's something what we saw, especially during COVID, really on the rise, because you want, as a lecturer, as a faculty member, you want to create the most engaging environment under these constraints. And we see these kind of solutions across the globe in India and other countries really skyrocketing everywhere, because it is the combination that makes it so so powerful. Similar with simulations, I think we talked before about how to show, for example, how to learn empathy, how to learn the empathy with the patient, even if you can't see the patients now during the pandemic. And here, having simulations that can train our healthcare workers in this are really, really critical. And again, we saw here a lot of uptake, and this is on the education
Could you
side
tell us
quite.
more about that, Jan? Personally, that's amazing to hear. That how does one learn empathy in a digital world, especially from a doctor-patient relationship? Like, if you could share more on that, that would be awesome.
Yeah, so what we did, and in fact, that was one of the so we acquired a company based in Florida called Shadow Health. In fact, during the pandemic, which was a very special context, of course, from working with the startup company and working with the teams. But since we were all anyway digital and all virtually online, it was very very straightforward. Now, what this company has created is simulations and a conversation engine where you can speak to these avatars, different patients. You can speak to them, you can type to them, and they provide you then clues. They provide you then information about their status. But it's not just only that. It's also about, it's so critical what questions you ask as a healthcare provider to get the right answers, but also to show empathy. And this is all measured in these simulations, in these digital simulations, and then fed back to the student, to the learner, to make them ready for practice much faster than before. In fact, we ran a survey, and in fact, the results are very similar in both India and also in the US, where we just did it very recently. That in fact, more than 50% of first-year nurses don't really feel that they are completely ready for practice. It's a lot of stress, especially as you can imagine now with COVID. So these type of solutions can help that to augment, obviously the normal learning capabilities. So that's one of these examples. When we talk about data, so overall, as I think there are two parts to it. So one is I'm really honored that we had that we got yesterday the FICCI Excellence for Digital Innovation Award for our solution around primary care pathways, where we digitally codified specific guidelines, created an AI engine that supports on a mobile handheld ASHA workers in frontline healthcare workers in their daily work. And that's one of the examples where we link the evidence-based content with the technology, but also create it in a way that is highly engaging to both the healthcare workers and the patients. Because that's the other thing, when you create these platforms or these information infrastructures, one is about the standardization you need to do. You need to remove the conflicts from the different parties, so that like the startup companies can indeed flourish on top and create those. But the other one is about designing then, and you need to get the data, but then it's about designing these products in a way that they are highly engaging for both the healthcare workers and the patients, because otherwise you don't create the uptake. And that's an example of how we are doing that in India. So
Well, that is great. Those are very, very insightful. I didn't imagine that even this was happening, and especially with Shadow Health, conversational engines teaching doctors how to communicate with patients virtually. Brandon, I'll bring you in at this point. We've got a question from an attendee, Mr. Asim Mathur. It's and also to the audience, please feel free to ask us questions. We are more than happy to answer any kind of question that you may have. nicer if it's on digital health, but otherwise, difficult to get this group in a room so you can ask them anything. So this is a question we grapple with all the time. With all this data coming on, and data not being siloed, being shared across organizations, all of that, how will the privacy of patients be affected? I think the question was originally from a national digital health mission perspective, but maybe all of you could give brief thoughts on this, because I think it's an important enough issue. But Brandon, starting with you, how do you think privacy? Do you think it is an issue, or we have mechanisms in place to address that today?
Yeah, so of course privacy is an issue, but the nice thing is we do have mechanisms in place to address that. That's one of the key things when we talk about digital health. In general, I think every nation that I'm aware of has some pretty stringent rules around that, and certainly all provider networks out there can get blown out of the water if you have any of those kinds of breaches. I will say that also with great IT leaders, technologists, and partners, they're coming up with new solutions to make that even better and easier without even having to go down the privacy realm. We probably don't have time to get into all of those things now, but things such as federated learning and other techniques and ways to actually mine that data, get out of it what we need to without ever broaching who that data comes from is really darn exciting.
Yeah, Sigal, please. You're on mute, sorry.
I apparently do not learn my lessons. So this is a topic that is very close to my heart. And usually the answer is we need to implement tools and we need to do this and we need to absolutely. And the world is doing that, and the world has been doing that for so many years. I mean, a person would not care that the whole world or a cloud would know at every minute of time where he is, okay, and what he's doing. So just by having your phone with you, the cloud or someone knows exactly where you are, what you're doing. When you drive, Waze or Google Maps or whatever you're using knows exactly where you're going. That is not just a little data about I have an ear infection that is relevant for a week in my life. That is every day of my life. We're all banking and managing all our investments online. We're paying our taxes online. All the information, everything today is online. We express our love, our feelings, our passion on Twitter, on Google, our political ambitions or opinions. Everything is out there. So it is outdated to state and to say that there is an issue with privacy or with managing your medical health in a digital way. The world has the right tools to protect data. Countries know what the infrastructure is, how to protect data. There are guidelines in every single nation, and there are global guidelines from GDPR to HIPAA to the different ISO. So this is a non-issue. And I feel
so Sigal, if I was to just if I was to dig a little bit deeper on that, Sigal, so as you operate, you mentioned you have presence in 13 countries, so and patients across 90 countries. Like, does all of their data come into like a central location, or do you have like every country you've got like a different data center, or how do you guys handle that?
So I trust that in a few years from now, it would be even more simple and all the data could be aggregated in one center. But actually today, it's really dependent on the country where you operate. And every country has its own regulations. And we at Medics are compliant at a local level with the local regulations. And we store the data where the country allows us to store it. So for example, across Asia, or if it's Singapore, or if it's Hong Kong or Europe or the UK, are you allowed or not allowed to export, and for what reasons? But then there is anonymized and non-anonymized data. So we manage millions of EMRs and millions and tens of millions of medical interactions. But you can store that data on a local level on the cloud. So it's not on servers. Today, we're all cloud-based, but it is stored in the country based on the regulation where you're allowed to store that data. And we also can upload it to a database on an anonymized level. And then you can actually draw data analytics. And data analytics is exactly what is going has saved us how did we in such a very short period of time develop a vaccine against a new pandemic? How do we know to analyze the side effects, right? So we have countries who have put their national database in an anonymized way at the service of developing the vaccine. Take Israel, for example. It has been the first world country to be a national clinical trial for COVID-19. So data can be anonymized and analyzed. It can be managed at state or federal or national level in a non-anonymized way and protected. We have all the technology, the infrastructure, and the regulation to protect data. And I feel that this topic is people want to share their data. Most people around the world are keen to drive and to get better healthcare, more affordable, accessible, and quality driven based on decisions that are driven from personalized data. You know, I will say one last sentence and then I'm done. I talk a lot, I know, I'm very passionate about this. Today, it is not anymore.
No, it's a pleasure to listen to you as well. So
thank you. It's not about one great solution fits all, because that doesn't work anymore. And people understand that. People want personalized healthcare. They want it, what is right for me, for my genomic, for my genetic makeup, for my, for me as a person with my family history, with my medical history, with my current situation. I don't care about what works for other people that are not like me. Without having personalized data and access to data, we cannot provide what today's medical world can provide to people. The cure, the treatment, and the diagnostics needs to be personalized, and for that we need data. People understand that, and privacy should not be a topic, should be implemented and managed in a responsible and secure way, but that is it.
no, I think obviously completely agree with both, yourself and Brandon. And I myself use that example whenever I can, right? You never talk about privacy of your bank account, right? Nobody talks about privacy of money anymore because, but it's all on the cloud. It's all in data centers. It's like, I don't have like a hard disk that has my credit card on it or something like that, right? So why are we, still having that conversation of moving from cloud and on-prem and all that?
Does someone not buy something on Amazon because Amazon knows exactly when I breathe, what I eat, what vitamins I take, and what books I read, and what
Correct.
movies I watch?
Absolutely. Now that as well. Hey, yeah, Brandon, please.
Can I turn the tables on you a minute?
Sure.
Great. And a question for everybody there. So have we moved finally beyond just the digitizing of the old and moving into the new business models, right? Isn't that digital 101 is just, okay, it's an old record, we put it in the back, now we put it on an EMR, we go from there. Hey, I walk into the doctor's office, now I don't have to walk into the doctor's, I can see him or her, et cetera, have that. And now we're actually seeing real new business models created digital first, right, that are moving there. What are you seeing? Because that's where we're going, and that's what we're seeing. So Segal, when you kind of took the shot at me earlier and said, sorry, Brandon, this is happening, I actually embraced that. I think that's perfectly fine. I think that's a great thing, and we as providers have to adapt to that. But what are you guys seeing as far as the new digital business models that maybe weren't just a replica of the offline world before?
I can take a shot at that. I think the fundamental way business models are being considered across the digital and the physical realm are different, right? The success metrics for a startup that is, like so-called digital health, telemedicine, e-pharmacy, e-commerce, platform, aggregator kind of startup, the success metric for that and the success metric for a chain of 500-bed hospitals across the country are fundamentally different, right? Like, these guys are optimizing for growth, they're optimizing for reach, they're optimizing for number of interactions. Their metrics might just be in gigabytes or terabytes, right? Their metric might not even have revenue or cost or EBITDA and PAT and all those things. Whereas when you're setting up a hospital, I'm sure Brandon has a fun time explaining this to people all the time, but when you're setting up a hospital, it's more about, okay, I'm going to invest, like $200 million of this, and then, I'm going to get a IRR of, like 12%, and, and that's my business model. Whereas on this side, these guys are using what we are building here, and so the valuation metrics are different. So that's what at least I'm seeing across the board in India, that there are traditional organizations that are trying to move into the truly digital realm, right? Not digitization, but being truly digital, but they're facing this problem where you just don't have the mindset for it, right? I can't spend $100 million and then never make a profit, right? So I think that's the conundrum we see ourselves in. If anybody else wants to add, we're getting some questions in as well. But Brandon, do you have that thought as well, like the difference of business model, or are you guys able to figure
I
it out?
do. I mean, and we're seeing that, and we're actually pushing some of that as well. And internally, I can't give away anything of our digital roadmap per se, but Sagal actually touched on a number of those points. That if I was to open up the roadmap, is like, yep, we're going there too. Some of it is, it's the traditional story, right? We're disrupting ourselves before we get disrupted in some of those areas, just because we think it's the smart thing to do. And by the way, it gets accessible, affordable healthcare farther, faster than a brick and mortar, heavy capex, et cetera, can do for us. And that's, at the end of the day, that's what we care about. And we'll just believe that now is finally the time to make that happen with great kind of digital first partners. And oh, by the way, some big other partners as well, and governments helping to lead the way, et cetera, et cetera.
On business model, I'm happy to add to Brandon and to what you just said. When you're a provider and you own hospitals and you run hospitals, clearly during the pandemic, you had to do beyond your bricks and mortars and your clinics and your pharmacies. But think of the income a hospital can generate by linking up and partnering with digital health providers like us or any other ones that Brandon would choose, and say, before a person, so people don't like going to hospitals. People would prefer to get care from their homes, but they need a virtual hospital capability. And they need people to come and knock at their doors with a urine test or other diagnostic tests that you can do very simply and easily today at home. They would like to have support tools before they have to go to the actual hospital. That is an income that a provider does not see today, but he could reach out and have his arm's length go all the way into the home and say, I'm not just the hospital where you come if you have no choice and through the emergency care. And it needs quite a bit of an effort to be very profitable, because you have very high expenses and non-variable expenses to keep a hospital together. On the radiology side, you certainly know you have a number of radiologists that can work day and night. It's very expensive to keep them at night, and you would want to service the whole Indian nation and cross board, but you need people for that. So why not add an AI model that actually triages and says, I don't need to have people at night as many as, or maybe demand coming in. I can use an AI triage system. I can collaborate with digital health solutions providers across the world, web-based PAC solutions, so radiologists can work from home, and your income as a business model would be exponentially growing because you reach out beyond the walls of your clinic, etc. And these are the models that we see coming in. And those
Great. Sigal, I'm so sorry, we've got like 5 minutes, and I would love to take on this conversation. But we've got a couple of questions that have come in. Maybe we could take them really, really fast. One says that information has become a powerful tool and a necessity post-COVID across the healthcare continuum. How does one close the loop from providing verified information? I think this is for Jan. How does one close the loop from providing information to a medical student all the way to a doctor? at the bedside. So Jan, a quick answer for that, and then we're getting another. Yeah, now people are asking questions. Sure. Please, Jan.
Yeah, so I think linked to this one, I would like to connect it a little bit more to the data story that we talked about. So one interesting thing is with all the data that we have, that we collect and that we use, that we enrich, it's still not actionable, right? You need to combine it with something to make it actionable. And that's when we look at now our experiments that we do of how we link our the evidence-based content that we have curated over so many years, decades, centuries. It's about adjusting this content in a way that it can be linked to this data. So for example, when you have a specific data trigger, could be through various different systems, that it is compatible with a care plan, for example, with the care plan information, with micro content that can then be played back in this particular context to the provider, or also to the patient as well. So that's one of the things that we are doing to connect the whole story to when you think really in a more advanced way what we are doing.
Nice. There's one question here, and I think that's a cool closer. I would love from all four of you guys. What is your one top recommendation for young aspirants keen to start a career in digital health? We could go around the room, and I think that would be a great closer. Maybe Jan, you could go first.
Well, I think so. First, sky is the limit here, and it's a perfect timing to work on these topics. It's incredibly purposeful. But you want to do something that you feel constantly that you can relate to and that you can drive, and this is clearly one of those. It's perfect timing. It's about building these digital skills that we talked about. They are not that difficult, yeah. Or you can actually surround yourself with people who know these, and then leverage them. It's much easier than any time before to link up with a team of like-minded people with the different skill sets to actually drive that mission.
I think that's a great
environment.
point. So point number one, right, from Jan, is surround yourself with people who know about this stuff. Tav, what do you say? The one thing I could do, I'm a 22-year-old girl or boy wanting to do digital health. What should I do besides join your lab?
Sure. Yeah. So acquiring digital skills, lifelong learning, and immersing yourself in a health setting. I think that's very important to understand what the challenges are.
So go to a hospital. That's what I'll take away. Brandon, I'm again 22-year-old, want to do digital health. What should I do?
Very easy. Come work for me. I'm building teams in India and around the world. Look us up on LinkedIn. No, only partially kidding about that, but really come and immerse yourself in the world here. Understand that when you get as old as some of us panelists on the panel here, you'll want to look back on that and tell your kids, etc., that you were involved in something that mattered this much, right? That's why you want to do it. There's a lot of other places you can do cool stuff, but come here and make a difference.
Nice. And Sigal, same question. I'm 22, want to do digital health. What should I do?
So first of all, everything is possible, as Jan said. Dream big, really stick to it, never give up, and it will work because the world today is really ready for it. Bring your passion. You need to be passionate about exactly what you're going to do in that digital health space. And then my last thing is I'm all about shared value. Look for what you're doing has to have a shared value aspect. And that means that you can quantifiably impact that world, our world. And while doing that, your profitability will increase. So find this project, this technology, this solution that has a never-ending demand and need, and is not something that is right now relevant or answering a pain point. It really has to make a difference and provide value. So impact healthcare, social, economic growth, and the more impact you have there, the more profitable you would be. If you find
Awesome.
a balance, a strike between those two,
Great.
you're a unicorn.
No, so thank you so much, everyone. Brandon, Tav, Sigal, Jan. It was an absolute pleasure. Thank you to the FICCI team. Thank you for those who tuned in and who are listening to us. So closer, 4 things you should do if you're a youngster wanting to do digital health. First is surround yourselves with people who know about that stuff. Second is go work at a hospital, visit a hospital. You can't build healthcare solutions outside of healthcare settings. Third is work with Brandon, and fourth is dream big, work on a project that has infinite impact. So thank you so much, guys. It's an honor and a pleasure. Thank you so much.
Thank
Over
you,
to you,
Dr.
Shilpa.
Vijay, and a big thank you to all the panelists. Of course, great deliberations, great insights. We hope people like the session. We would now move on to our next session in 15 minutes at 5:30. We'll start with the session on politics at COVID healthcare, the experience so far, which will be moderated by Dr. Harsh Mahajan. And we would have panelists like Mr. Nalin Kohli, Mr. Manish Tiwari, Mr. Shekhar Gupta, and Ms. Navika Kumar. Thank you, everyone. Thank you for joining us, and a very good evening to you.
Thanks. Thank you, guys. Take care. Bye.
We should keep in touch.
Let's connect on LinkedIn first and then find a way to do that. Okay.
Great.
Sounds good.
Thanks.
Take care.
Thanks.
See ya.
Have a good one. Bye-bye.
Thank you.
Yeah, please go ahead, sir.
So good evening, everyone. After the full day of conference, we yet again come to a very exciting session, Politics at COVID Healthcare, the experience so far. I have with me the stalwarts and of course, convener and moderator, Dr. Mahajan, who's the co-chair for FICCI Health Services Committee and the founder and chief radiologist, Mahajan Imaging. Dr. Mahajan is an eminent radiologist and a pioneer in the field of magnetic resonance imaging. He's been honorary radiologist to the President of India since 1998. In 1992, he set up India's first privately run MRIs. He's the former president of the Indian Radiology and Imaging Association, and also the consultant to the International Atomic Energy Association. Mr. Mahajan was awarded Padma Shri in 2002 for his contribution to the field of radiology and imaging. With this, I would like to hand it over to Mr. Mahajan. Dr. Mahajan, over to you, sir.
Thank you very much, Praveen, and it's a pleasure to be on the FICCI Heal platform. This is a conference which is very well received every year across the globe. Last year, having more than 10,000 people attend it. And today, it's my singular pleasure to welcome a very, very powerful and erudite panel of 4 eminent citizens of the country. And let me start by introducing them. Ladies first, Ms. Navika Kumar, who is the group editor of Times Network and editor-in-chief of Times Now Nav Bharat. She is a well-known face in the country, and she works very closely with the business and leadership teams of the network to drive the channel's growth strategy and towards building Times Now Nav Bharat to become the leader in the Hindi news category. A versatile and transformative news personality with outstanding journalistic credentials, Kumar is credited for investigating and breaking some of the most high-impact stories in the last 2 decades, including the Office of Profit. We have the CWG scam and the Aircel Maxis deal, amongst others. She has also been at the forefront of reporting and analyzing the COVID pandemic through her programs, and I'm sure she will be able to shed a lot of light on COVID, the politics of COVID, and how things can be better. Next, we have Mr. Shekhar Gupta, who's the founder and the current editor-in-chief of The Print. He's also a columnist for Business Standard, where he pens a weekly column. He was elected president of the Editors Guild of India in 2018, and he started his career, as we all know, as a journalist working in the Indian Express, for which I think all of us remember him. Under his leadership, the Indian Express won the Vienna-based International Press Institute's award for outstanding journalism in the public interest 3 times. The first time for uncovering the Bihar flood relief scam in 2009, and the third time for its sustained investigation into the Malegaon blasts. He also has been with NDTV for 15 years, doing a very popular show, Walk the Talk with Shekhar Gupta. Welcome, Shekhar. And on to Mr. Manish Tiwari, a member of parliament from Lok Sabha representing Anandpur Sahib. He was also elected as member of parliament in the previous 15th Lok Sabha from the Ludhiana constituency in the year 2014. He has been Union Minister of State with independent charge of information and broadcasting and contributes regularly numerous articles on topical issues such as energy security, national and international security, nuclear disarmament, etc., to name a few. He's been a member of various consultative committees such as the Ministry of Defense, Ministry of Law and Justice, member of Standing Committee on Finance. Welcome, Manish, and thank you so much. Last but not the least, my good friend, Mr. Nalin Kohli, who is very balanced in his approach, in his speech, very erudite. He is the Additional Advocate General for the Government of Assam, representing them in matters in the Supreme Court of India. He was formerly also the Additional Advocate General for the state of Rajasthan. Nalin has been the nominee of the Ministry of Corporate Institute of Company Secretaries of India and also a member of the high-level committee set up by the Ministry of Corporate Affairs to suggest improvements in the disciplinary mechanism of the institutes pertaining to chartered accountants. He is the vice chairman of the anti-doping disciplinary panel of the National Anti-Doping Agency. Both Mr. Tiwari and Mr. Kohli are also national spokespersons of the BJP, of the Congress and the BJP respectively. Thank you all very much for joining, and as was agreed amongst us, you have 3 or 4 minutes to really put into perspective what you thought about the COVID response in this country, of how it panned out, the politics of it, or lack of politics, as you may deem fit. We will start with you, Navika, on to Shekhar, Manish, and then Nalin. Navika, please.
Thank you, Dr. Harsh Mahajan. Thank you for having me, and stalwarts. Always very difficult to speak in front of Shekhar, who's been my boss. I've learned journalism under him. So pardon me, Shekhar. You can rap me on the knuckles anytime you want. Um, I'd just like to say that India hai to politics hai. We don't talk without it. So, it moves in that direction, and everything these days, and I'm talking about these days because the last few years, everything is about politics, and the COVID, the pandemic situation was no different. Of course, concerns, tempers were running high, and it was a great platform for politics simply because there was so much to say. And it was unexpected, and any government that would have been in power at that time would have looked ill prepared, because actually the bolt came out of the blue in a manner of speaking, and we were not prepared. And there's no point hiding that fact. But I think the response systems have been very good. The lockdown, when it came, was probably amongst the first few countries where this kind of a lockdown came in. And, anticipation, definitely India didn't anticipate or plan well. And we are a large population. We are 135 crores. And anything of the scale of the pandemic called COVID-19, if when it hit, it was bound to have repercussions and impact across the country, and the visual, and I come from television, so the visual impact was there to see. Nobody could hide it. Nobody could do anything about it, even in the first wave. Forget the second, which was a nightmare in any case. So I think it started off, and on both sides, the fact was the opposition had a point. We weren't prepared. Of course, the opposition never has to answer the question on what it would have done if it would have been in power. That frankly is a luxury that the government of the day never has. And in this case too, the government initially did look a little bit on the back foot. There was first the pandemic and then the migrants issue that really set the tone of politics. And what could have been done in a more collaborative manner never happened. And of course, you can blame us. We get blamed all the time that wherever there are a few cameras, there will be larger than life events that will happen, which is that the magnitude of the migrants was multiplied, because there was a lot of political support that came in, for the migrants, and everybody sort of fought for their space on the cameras as well on television channels. And there was a raging debate. It didn't really help, because the BJP, also the government of the day, also looked at this in some sort of an event management style, which it wasn't. So initially, some of those issues, were picked up, played up, criticized, joked about, and it was all playing out, if not on television's cameras, then 24/7 on social media. Having said that, I still think that in this country we don't appreciate, because these days everybody watches over their shoulder on what they're going to be trolled about, what they say and how the world is going to react. But I would like to say two things about the government. In the first wave, I thought, even if people criticized the Diya Jalao or the Thali Bajao, people criticized it a lot. But I'm just putting the intellectual uh, media on the side that Shekhar is going to be talking about. But I'm talking from a reporter's point of view and from a camera and visual point of view, that there was that whole country there that was participating. And whether you called it silly, you called it stupid, the fact was that people were participating. There was a sense of disbelief amongst the common people. They needed something to hang on to. And they hung on to the Prime Minister's word. As a leader, I would say full marks to him, because he got people's attention and got them involved. And there weren't any answers to give. So, this kept things going for
May
a
I
while.
just interject, Navika? I can tell you from the doctors and the healthcare workers standpoint, that's many of us felt very good about it. So, the thali bajawing, for whatever it was worth, for that moment, the country coming together. Later, we may have been vilified and we may have felt that it was all for nothing. But in that moment, it did matter. Can I go on now to Shekhar? And, just the beginning, because we have a lot of people have already sent in questions. And so we would like an interactive session.
I haven't even come to the second wave yet. Just 30 seconds,
Sure,
Shekhar, if
Navika.
you'll allow me.
Please,
30
please.
seconds.
Please.
I know how difficult it is for the panelists like Nalin and Manish Tiwari every night. But just one thing that I wanted to add is that is how the people, we saw people reacting to it. So in that sense, I thought it did what it needed to do. And in the second wave, we were very badly off. We didn't anticipate the extent of the impact that it would have. We didn't plan, we didn't anticipate, despite having gone through a first phase. Yet, I think managing it in 2.5 to 3 weeks to manageable levels was also, I think, a decent, a pretty decent job that the government did. Um Opposition's questions cannot be taken away, should not be taken away, and should not be ridiculed. They were there. But I just feel that people should have come together a little more than they did on both sides of the aisle in Parliament. Shekhar, over to you.
Shekhar, please.
You're on mute, Shekhar.
Is it okay now?
Yeah.
Yeah. So thank you, Dr. Mahajan, and thank you, Navika. I know that when you say that you learn from me, you're telling people how much younger you are, which is a fact. So we can all speak the truth. Second, now that you have established the Guru-Chela relationship, I can also tell you that there are many cases where chelas leave the gurus far behind. राइट तो उसके लिए हिंदी में कहते हैं गुरु गुड़ ही रहे चेला चीनी हो गया तो ये चेला तो चीनी हो गया हम गुड़ के गुड़े हैं अभी ये तो अभी स्टार बन गई है
बहुत गुड़ हो गया
बहुत गुड़ हो गया और उसका दूसरा बात वो भी है जो असरानी ने बोला शोले में हमारे आदमी चारों तरफ फैले हुए हैं तो हमारे जो फैले हुए हैं उनमें एक नविका भी है सो नविका थैंक यू फॉर बीइंग देयर थैंक यू फॉर काइंड वर्ड्स नो नविका सेड समथिंग फ्रॉम व्हिच आई टेक द क्यू शी सेड इंडिया है तो पॉलिटिक्स है इसको मैं उल्टा करूंगा पॉलिटिक्स है तो इंडिया है क्योंकि इंडिया तो वॉलंटरी फेडरेशन है ऑफ स्टेट्स इंडिया वाज कॉन्स्टिट्यूटेड एज ए रिपब्लिक The republic is based on a constitution which is based on democracy. Without politics, there can be no democracy. So India stays together because India is a democracy and a federal democracy. And democracy stays there because there is politics. So you can say it any which way. India है तो politics है, politics है तो India है. You can always say एनी अदर कंट्री है तो क्रिकेट है फॉर एग्जांपल. इंडिया को क्रिकेट भी कहते हैं, क्रिकेट और पॉलिटिक्स. उसके लिए डेमोक्रेसी नहीं चाहिए. उसके लिए तो प्राइम मिनिस्टर ऑफ द कंट्री कैन अपॉइंट द क्रिकेट बोर्ड चेयरमैन. प्राइम मिनिस्टर ऑफ द country can also select the team. Then if the team doesn't do well, prime minister of the country also decides who to blame. You know which country I'm talking about, next door. So India में politics है. Politics is very important for us. It's so important for us कि मैं थोड़ा plug भी कर लूँ the print. और ये मुझे पता नहीं था, much as नाविका betrayed the fact कि हमारे बीच में कुछ insider trading भी हो सकती है, पर ये कोई insider trading नहीं है. इसने मुझे पहले पेपर लीक नहीं किया था कि मैं ये कप लेके बैठा हूँ. ये हमारा तो प्रिंट कम आ गया और इसके पीछे लिखा है because politics matters. Right? So we take politics very seriously. चाहे किसी की भी हो, politics matters. Because politics, a lot of people like to make fun of politics. One of my biggest intellectual arguments with the Anna movement was, मेरा नेता चोर है, voting बकवास है, politics बकवास है. So our question used to be, politics नहीं है तो क्या है? How can you have democracy without politics? And this whole idea कि आप मैग्साइसे अवार्ड ले आओ, आप नोबेल प्राइज विनर्स ले आओ और वो इस देश को चलाएंगे, तो ये एक इसमें इंटेलेक्चुअल आर्ग्यूमेंट था. सो इंडिया नीड्स पॉलिटिक्स. नाउ देयर हैज बीन पॉलिटिक्स. Politics has played out fully during the pandemic. When I say during the pandemic, I take you back to March of last year until now. So that's about 1 year and 7 months. Politics has played out fully. And it's not just opposition versus ruling party politics. It's a question also of political management. Now, we saw many challenges emerge. For example, we saw initially in terms of political management, what was good was that government was responding very quickly. And we can say that the government, we can now say the government maybe overestimated the first wave, but overestimation is better than underestimation. Because second was underestimated and we know what the consequences were. But for quite some time early on, there was lack of transparency. For example, the evening briefings at PIB by the Ministry of Health and other people were very sketchy. Questions were not answered or answers were dismissive. And that led to a lot of confusion. Now I understand that there wasn't that much to say at that point because everybody was blank. Look at ICMR's own recommendations. They said hydroxychloroquine, they withdraw it, right? They said azithromycin, they withdrew it. So various people, सब तुक्केबाजी हो रही थी. So in terms of politics, I would have liked to see more states sort of excel in their own ways. In the first wave, Kerala did it very well, but other states also, the competition among the states did not come out as well as it should have. Similarly, if the opposition was saying that Modi government was getting it all wrong, then it was for the opposition states to show that they could do a lot better. We know that there were no vaccines, etc. at that point, but this ruling party states के मुकाबले opposition states could have done a lot better. One of the poorest performing states right through has been Punjab, for example, which is not a BJP state. It's a state where BJP is unlikely to win by itself anytime soon. But yet, even today, on most features, Punjab is among the poorest in the country. So that competitive spirit did not come out. So name calling is all right. आपने थाली बजवा दी, आपने दिए जलवा दिए. That was the criticism was that this was gimmickry. That because you had no answers, but the fact is there were no answers. If a big political mistake was made with the first wave, it was the totality of the lockdown. And totality of the lockdown, it was too draconian and too total, and that crippled the economy. Now, for a lot of us, it may not matter so much, but for people who are daily wagers, people who have non-contract jobs, people whose next week's income is not guaranteed. This was devastating. I think this was a bit of a panic reaction, and on that, India needs to reflect, because next time something like this happens, will you again do this? The second wave was obviously a case of declaring victory too early, and that's what happened. So two things happened with the second wave, and I thought the opposition could have taken this up better, but they didn't. So in fact, instead of there being too much politics with the pandemic, there was too little politics with the pandemic. So the second wave, the fact is that the Prime Minister himself, in his speech at the Davos Forum, remotely spoken, had basically declared victory against the pandemic. That was third week or last week of January, and that's when it was picking up. Initially, a lot of the vaccines were exported, and with great fanfare, the India was giving it all to the world on the presumption that we had fought it off. And there were many bad theories floating in the market. All of us are guilty of having discussed those. Maybe it's the BCG injection that was protecting us. Maybe it is because this was a CSIR peer-reviewed paper that Indians already are exposed to many infections, so they will not be, you can't ignore a peer-reviewed CSIR paper. But the opposition lost its opportunity in terms of politics. I think they were all scared. Normally, any opposition, because politics is a tough business, you have to be very ambitious. Any opposition, especially in this case, the Congress, the top leaders should have been in the countryside. With the second wave, they should have been going through the villages of UP, Bihar. See what Gandhi would have done. See what Narendra Modi would have done if he was out of power. Politicians need to expose themselves to danger and do things so that people think, oh, वो मेरे साथ नहीं है, लेकिन ये मेरे साथ है. You may not be able to bring any medicine. So I would say that politics did not play out adequately in the second wave. Because if politics had played out adequately in the second wave, maybe we would have had better responses, and maybe we would have woken up to the second wave at least 2 weeks earlier than we did, because even 2 weeks earlier would have saved a lot of lives. And the same vaccine drive, which is then picked up in a big way after the second wave, I think it was quite possible to have put in another 10 to 15 crore vaccines before that as well, if this complacency was not there. So I think our politics did not adequately play out. And even when politics played out the wrong way, it wasn't sufficiently questioned. For example, the government delayed emergency use authorization for Covishield for too long, much after the countries where it originated had approved it. And everybody got the impression that that is because government was hoping that the other vaccine, Bharat Biotech, which is a homemade vaccine, that will come in first. So it was just a loss of time. Even now, if you see 100 crore vaccines given, I suspect, I'm just waiting for the data, but I suspect about 92% is Covishield. Because anybody would have known, any scientist would have told the government, or should have told. If they didn't, then they were not doing their jobs. They should have told the government that basically you cannot scale up a whole virion vaccine production so quickly, because it's the same thing as making a car on an assembly line and making a bullock cart. Because for car on the assembly line, somebody can manufacture engines, somebody can manufacture doors, so you can put them all together. In a whole virion vaccine, I'm giving a very basic example. It's like producing a bullock cart. It's effective. It will take you from place A to B, but you first have to produce the bullocks, and then they have to grow. So in this case, you have to produce the virus. It has to multiply. Then you have to kill the wretched fellow. Then you have to attenuate it. It's a laborious thing. So there was no way you were going to be able to scale it up to these levels. Even now, we are looking at Bharat Biotech scaling it up, and it's a big improvement, about 8 crore a month, whereas Serum can now do maybe 35 crores a month. So time was lost, and I think opposition was less than vigilant. Our politics was less than vigilant. Our parliamentary committees were less than vigilant. And frankly, the media just gets divided. And when they get divided, half of them sound like they support everything the government does. The other half sound like they oppose everything the government does. I'm not exactly half and half, कुछ हमारे जैसे भी हैं बीच में who get caught in the crossfire in the middle between the two rows of bunkers. But the right questions were not raised. So I would say that more than the first wave, the second wave was a case of the failure of Indian politics and democracy. While essentially the blame must always lie with the government of the day, but India's democratic processes failed itself in the second wave.
Thank you very much, Shekhar, for putting it all into context and for your feeling that probably the opposition didn't do as much and didn't play as much politics as probably could have been done, especially in the second wave. But maybe it's because everyone was stunned by the ferocity of the second wave, which really, including healthcare professionals. So now on to Manish Tiwari, and how do you feel the whole thing played out, right from the initial lockdown to the migrants problem to, again, the response of the government in the beginning, setting up the hospitals, the diagnostics taking off, and then leading to the lull before the second wave? How do you feel, and where could probably things have been better, where they were good, and what is your take on the whole last 18 months?
Thank you very much, Dr. Mahajan, for having me for this extremely important discussion. I think there are far larger issues which unfortunately have not been addressed adequately or properly in the past 18 months. Let's rewind back to the November of 2019 when reports started circulating of a pneumonia-like illness in the Wuhan province of China in the city of Huabi. Obviously, it's quite possible that the Chinese also may have been caught by surprise. But by the time they reported the outbreak of what looked like a SARS kind of an illness on the 31st of December 2019, much time had been lost. Unfortunately, the World Health Organization, for reasons best known to it, its initial advisories on the 5th and the 7th and the 9th of January 2020 were completely bizarre, to put it mildly. In fact, the warnings, the advisories said that travel is all right and there's no need to panic and everything would be all right. And in the meantime, what you actually saw in the month of December and January, that China had started shutting down its own cities. If you look at the TomTom traffic index for Shanghai, for Beijing, for some of the provinces around Huabi, you would see almost 80 to 90% drop in traffic density, which obviously meant that they had imposed some kind of lockdowns in order to contain the spread of the virus. But the Chinese were unfortunately more than economical with the truth. So while they shut down internally, they kept air travel to the world open, which allowed the virus to really socialize around the world. And the worst hit initially were those parts of in and around Milan, where a lot of the high fashion leather industry is situated. Concurrently, because China was the chair of the United Nations Security Council, throughout the month of March, when almost 3/5 of humanity had gone into some sort of a lockdown or the other, did not even allow the COVID-19 pandemic to be discussed at the United Nations Security Council. And Incidentally, it was only in the month of April when the chair of the United Nations Security Council went to the Dominican Republic that for the first time there was a structured discussion as to how the global response with regard to COVID-19 should really be coordinated. So the big takeaway from what happened between the January and the April of the December of 2019 and the April of 2020 was that there was a complete failure of the institutions of global governance, whether it was the World Health Organization, whether it was the United Nations Security Council, or any other institutions of global governance that we had created. They had absolutely failed to deliver to their remit. Next, what we saw playing itself around the world were not even national responses. They were actually subnational and local responses where people or communities were really taking it upon themselves as to how best they could insulate themselves from the virus. Why I chose to relate or refer back to that particular period was because that was vital time which was lost for India. And though the World Health Organization had started giving out certain advisories, but they officially notified it as a pandemic, if I recall from the top of my head, on the 10th of March 2020. So vital time was lost whereby preparations could have been done. Then, if you were to fast forward to the 24th of March 2020, at a 4-hour notice, a nationwide lockdown was imposed at a point in time when India had 381 cases and 7 deaths. So, therefore, whether a lockdown of that nature was really required or micro containment, which was or which became the norm later, should have been the preferred option, is something which has not really been debated or even dissected at great length. The second thing which started happening, unfortunately, was that in the initial days of the pandemic, epidemiologists became economists and economists became epidemiologists. While the former could not contain the disease, the latter flattened the economy. You had a strange case of hubris playing itself out, whereby in PIB briefings, it was said that the number of cases would come down to zero by the 15th of April by some eminence in the Niti Aayog, which gives you a sense, coupled with what Mr. Gupta was saying, that the manner in which the ICMR and the various medical protocols which were prescribed, which were completely found off the mark, that the people who were handling the COVID-19 response, either from an administrative standpoint or from a medical point of view, were completely and absolutely clueless. I mean, the latest that we have seen is that ivermectin has been deprescribed now. So ivermectin for a very long time was the medicine which was being administered in addition to azithromycin in order to contain or mitigate the impact of COVID-19. And so therefore, we kind of stumbled through the first wave. And the reason why we were able to stumble through the first wave fairly unscathed was primarily because large parts of rural India remained open. I recall that when the lockdown was lifted on the 15th of May, and I traveled back to my constituency, when I would, go around the villages, and we have 1,800 odd villages in my parliamentary constituency, which goes across 4 districts of Punjab. The usual refrain I would see people were not wearing masks, and the usual refrain that I would hear is, "Ji zukam hai, theek ho jaayega." So therefore, in large parts of rural India, there was actually a kind of a disconnect, or if not a disconnect, a disbelief about the seriousness of the problem, notwithstanding, the migrant crisis and the manner in which it played out from the last days of March till about the 15th of April. But I guess where the fundamental mistake got made And that is where lessons learned from similar epidemics, especially the Spanish flu of 1918, were probably not well studied, and neither was it internalized. Was that the second wave is always more lethal than the first wave, and we allowed ourselves to be overtaken by that hubris, thinking that we had scored a big victory over the virus when the second wave hit us, and boom, we did not know what happened. I mean, in a place like Delhi, where people come from treatment all across the country, you had people dying in the parking lots of hospitals for lack of oxygen. And these were not people uh, who came from that strata of society where they were not connected, or they were not able to access services through jugaad. So, in many senses of the word, the second wave was like the 26/11 moment for the middle class of India, when terror really came to their watering holes. And therefore, if you were to kind of rewind back and look at the past 18 or 20 months in a certain context, I think we have really kind of stumbled along from one flashpoint to another, trying to mitigate situations without really having a game plan in mind. And I don't blame the government for that, because like everybody else, they were grappling with the unknown, not knowing as to what the next moment would really bring. Well, on the vaccination, I think beyond the initial flip-flops, whereby an attempt was made to possibly see, as Mr. Gupta was saying, that a particular vaccine succeeds or precedes the other vaccine. In the initial days, the vaccine hesitancy was very much a reality. And though we have really crossed the billion mark today, and which is applaudable by all standards, what really needs to be seen when the data is crunched, that how many people have really been fully vaccinated, which actually brings us to the next problem, because all over the world, you have people going in for booster doses now. So therefore, you do not even know as to whether fully vaccinated means whether you are fully protected, because in many instances you are seeing breakthrough infections which are proving to be fatal. Recently, all of us read that General Colin Powell, who was the US Secretary of State and their national security advisor, despite being fully vaccinated, succumbed to COVID-19. There are various other instances also which are available in the public domain. So to conclude, I would say that we are not really out of the woods. I think we are as much in uncharted waters as we were in the March of 2020, because this race between variants and how we evolve and adapt in order to surmount those variants is a continuing battle. Until now, whatever projections we have seen coming out of the World Health Organization, trying to predict the trajectory of the pandemic, have been completely and absolutely off the mark. So therefore, let's all hope and pray that the second wave was actually the worst, and the worst is behind us, and we are able to, not only as a country but as a world, get back on our feet and try and get back to normal life.
Thank you, Manish, and thank you for bringing in the global perspective as well, because as this pandemic has shown, the world is one, and it's a small place, and so what happens in one part of the world affects the other instantly, and also, yes, Shekhar, yes, you're muted, Shekhar.
Okay, just to take forward what Manish said just now about Colin Powell, the fact is Colin Powell was 84 and he was under treatment for complications of multiple myeloma.
So he was immunocompromised.
No, but he was under treatment for multiple myeloma. in a very late stage. So even medically, his death has been described as death by multiple myeloma. So, if people get scared, in any case, there is some anti-vaxxer sentiment. So this was misused. And after that, in fact, a lot of people, Eric Topol, who's one of the best informed handles on COVID research across the world. In fact, he put out a tweet that said he died of COVID. He said, corrected for you, died of complications from multiple myeloma. So
absolutely, absolutely. I was going to add that as well. And to answer your question, Manish.
Well, I stand corrected on that, but the fact is that breakthrough infections are a reality.
Yes.
Which
they are a reality. There's no doubt. But if you look at the mortality rates, Manish, those are rather small. So the vaccines work. Most of people in the US who are in hospitals are the unvaccinated. And hence, and to answer your question, about 74% of the adult population of India today has had one vaccine, and about 31% have had two. In the US, it is 66% of the population that has had one vaccine. So I won't go into reasons, but India is not doing so badly. But then in the US, they also are including some of the youngsters, 12 years plus, in the count. Now, over to Nalin for his thoughts. And I must say that without...
Can I
Yes,
ask a
yes,
question?
please, Navika, please.
Of
Nalin,
Manish.
sorry.
Manish made a very important point, and he actually spoke about the fact that epidemiologists and doctors and ICMR were pretty clueless in the beginning in March last year. I just want to leave you with a thought, Manish. I mean, given the fact that that was the case, and we all know deep inside that that was the case, nobody knew क्या हो रहा है, क्या assessment है. In such a situation, had there been a different government, would it have changed the story too much? Because the experts, by and large, remain the same.
Navika, I don't want to get into the mundane cut and thrust politics of, he said, she said. All I'm trying to say is that we have had situations in the past, not as serious, but you've had the SARS pandemic, you've had the MERS pandemic, you've had the Hong Kong flu. So you've had various situations, and going back all the way to the Spanish flu, where there are lessons learned which have been internalized by the medical community over a period of time. And therefore, unfortunately, those lessons did not play out as they would have. For example, if the lessons of the Spanish flu would have been internalized, I think we would have been far more vigilant with regard to the second wave. And I've also, because of paucity of time, not spoken about the fact that we never had a legal architecture to deal with a pandemic of this kind. What you had was an Epidemic Act of 1893, which is a one-page, four-section act, and you managed this entire pandemic through the consequential provisions of the National Disaster Management Act 8.2 and one other, which are really consequential and incidental provisions. In fact, the Disaster Management Act does not even define the term pandemic. And we still have not got to the stage of really being able to craft a law in order to deal with such a situation in the future. But if you look around democracies around the world, each of them has actually put a specific law on the statute post COVID-19 in order to deal with these eventualities, but we'll leave it for another day.
Thank you. Nalin, the floor is yours for the next 10 minutes, and then we'll have time left, I think, only for one question. Please go ahead.
I'll make it short. I must thank all my previous panelists because each one's brought a perspective. And I think, Manish has given a very nice overview of the entire situation. Shekhar and Navika have brought in relevant issues. So I think let's sum it up. There are two parts to it, the vaccination of today and also the situation. It was, is, and continues to be an unprecedented situation. I don't think anyone amongst all of us has ever witnessed anything, and there is no collective learning As Manish keeps referring to the Spanish flu, that was 1918. And anyone in governance today is not from that era. I mean, everyone is actually post-independence, and that's true globally. Even younger people are there. So yes, that is one thing at a global level. The second is the nature of the virus. I don't think the jury is still out there in terms of how unpredictable it is, how it is evolving. Is it man-made or is it lab-grown? Is there something in evolution that answers it? We have no clear answers even today as we try to battle it. So that brings us to the government of the day in this case. And Manish, in fairness, has kept it bipartisan. So I think if we divide it between 2020 and 2021, the two phases, I think 20 was really ramping up and trying to do something in terms of preparation. And we have to bear in mind, we didn't produce PPE kits in this country. I mean, as good as negligible in 2020. And that PPE kits today, we are doing about 10 million a day, 10 million a month, 1 crore a month, or take N95 masks. I mean, N95 masks, we are doing almost 2.5 crores a month. And we used to barely manufacture it. I remember the debate at that time in the first one was how many ICU beds we have. If I recall, the figure was 16,000 or 17,000. Today, we at least have 64, 65,000 ICU beds and almost a dedicated 1.5 lakh beds. Some of it today is being used for dengue or dengue as it's pronounced. I don't know which is the correct one, but nevertheless, I mean, there was a ramping up of preparation and infrastructure. Yes, the second wave did hit us very badly. There's no doubt about it. And it's been a tragic story for many people at a personal level. But then again, if we look what we expect from a government, and I think that's what I'd like to bring up here, is the response that was brought in. So let me deal with each one of it. Remdesivir, which was, and I'm not a doctor to answer, Harsh, but yes, but Remdesivir needed to be ramped up. It's gone up from about 4 million doses to 12 million doses in 4-5 months. Multiple licenses have been given out there. So there has been an approach to somehow meet it. Oxygen was a supply. Industrial oxygen was transferred. Private firms stepped in. About 133 plants have been put into it. Many have been commissioned. So that there is a sort of a self-sufficiency. It was unprecedented, the scale. I think, yes, one has to accept no one ever could have probably anticipated it. My take on it is simple, and it was beyond everyone's comprehension that something like that could happen. But to me, it's reassuring at the end of the day that there is a vaccination policy, which is, as Manish used the term, and I think it's fair to say, applaudable. 100 crore vaccines in 275 days. That's from 1st of January when this vaccination policy comes in. Today, to where we've achieved it, is no mean achievement. It is something to be happy about that, yes, this is what we believe is giving us protection. There may be questions about vaccination. There has been a phase of enormous vaccine hesitancy, not just in India, but across the world. But then at least we do believe that doctors seem to say that that you are better protected in terms of morbidity with even a single dose and certainly with a double dose. And you pointed out those figures. The task of the vaccination itself is huge. And we are a country which has, the numbers are daunting, to put it mildly. So, I mean, look at the kind of people involved in the vaccination policy or in terms of its implementation. I mean, today you have 3 lakh vaccination centers functional across the country. You have almost 1 crore vaccination sessions. 95 or 96 lakhs is the last count that I checked. Done. You have almost 7.5 lakh professionals, that's trained healthcare workers and their assistants, 7.5 lakh who are involved in administering the vaccines. Almost 1.5 lakh, 1,50,000 ice boxes that take it to the villages. And news channels have reported some remote places carrying it on their shoulders, even where there are no roads per se. You have 16 lakh vehicles taking it, 1 lakh refrigerators and deep freezers to manage it. So it's a huge thing. And I think the world today also acknowledges it globally. The WHO has also come out. Others have come out to acknowledge that India, where there is 1/7 of the global population living, has managed to get 70% of its people single dose and a 31-32% of them double dose. And we are talking of a vaccination policy that from June is free for everyone 18 and above. There's the talk about what happens below 18, but that's down the line. And I think the government of Modi has to be complimented in terms of putting in the efforts to meet the situation. Yes, There will be criticism. There should be a discourse in democracy, no question about it. But can we take away also what has been managed in terms of ramping up production of medicines, putting in place trained compartments were used as emergency hospitals in the first phase. So a lot of things have done. And today, to me at least, it's a matter of satisfaction that 100 crore vaccines is a milestone, and we are going at a pace which is very, very encouraging. The first 10 crore vaccines happened in 85 days. From 10 crores to 20 crores, it happened in an additional 45 days. Then it has come down. The lowest we did was 11 days to do 10 crore vaccinations. But from 50 crores to this 100 crore mark, it has been broadly under 20 days, 19 days, 14 days, 11 days. And therefore, we are maintaining it. So I think at this pace, the vaccination is certainly going to happen for the whole population. And I can't say whether there is a need for a booster dose or not. But to answer Shekhar's one query, yes, Covishield is the vast majority of it. If my figure is correct, which I was checking while Shekhar answered that question, I think over 100 crore is Covishield and about 31, 32 crores is Covaxin. That's the figure that I checked on the net, but it's subject to being further checked. So I thought I'll just sum it up.
Nalin, it's about 91% or 89% is Covishield, and 11%, 11 point some percent is Covaxin. That's the
financial
percentage.
figures. Actually, Harsh, the figures I've checked is about the total expenditure, which will finally be about 35, 40,000 crores. Currently, it's about 20,000 crores.
Yeah, that's
But
because
from the financial
Covaxin is
figures,
double.
yes. So therefore, Covishield and Covaxin are almost on a 2.5, 3 to 1 in terms of the payments that have gone up. So I can speak in terms
Covaxin is double the price of Covishield. So it's about 89 to 11. 89% percent is Covishield and 11. Oh, yeah.
So I just thought I'll bring in this perspective, and I think as Indians we should be in a sense satisfied at least that finally the vaccination drive has been an enormous success in terms of reaching out to 100 crore people, which is no joke. This is the largest that it's ever happened. It beats any kind of vaccination drive. And I think it's encouraging for other countries to also pick up a clue from here. If we could manage it with our challenges, and there are better equipped countries, better democracies, better systems in other places, perhaps they can certainly learn the lessons learned in reaching out to the most remote areas. So I thought I'll just make these initial comments and make it a little more brief to maybe enable a few more questions.
Thank you. Thank you very much to all of you. And I must say there have been many positives that have come out in the last 18 months, most of which have already been enumerated. We've all lost a close friend or a relative, especially in the second wave, which was devastating. And I'm sure there are lessons we've learned from that as well. And there is one, question asked by a very senior member of FICCI, and this is something which has been talked about often. And maybe in the context of COVID, it may come to the forefront because we've seen that the response was state specific and it may have been non-uniform across the country. And so the question is, and maybe again we start with you, Navika. What if health was to be brought under the concurrent list so that the central government, instead of sending advisories which were followed or not followed, it would send directives so that there would be uniformity across all states. And we saw as diagnostic players or in hospitals, even at every district level, there was non-uniformity. And, the boss of the district was making decisions and, it could have been very different. Whereas had it been in the concurrent list, one directive going from the center where, the gurus were sitting, trying to make the best, not that we knew everything. This is, after all, a novel virus. It keeps mutating, changing. So do you think bringing health into the concurrent list, something which even the 15th Finance Commission has recommended, would be useful going forward?
Dr. Mahajan, normally finance commission reports or any commission reports, what happens to them? They lie, in a bookshelf, gathered dust. Not many advices given in that are taken up. I think this is more in the realm of parliamentarians. The day we have a mature democracy where, as we've seen today, where we talk about these things in a bipartisan manner, I don't see a solution to this kind of a problem. Definitely, uniformity at a national level would really help in terms of health workers, doctors, protocols, especially in the learning of a pandemic situation. Having education and health on concurrent lists will bring in some amount of uniformity, which I think is the need of the hour. The question is whether political parties across the aisle can sit and actually get to a consensus situation on that, because this will require changes in law, and most of the debates are more confrontational in nature, and it is seen as center stepping on the toes of the rights and realms of what falls in the purview of the state. Um so frankly, it's a utopian situation. We should of course look forward to it, pray for it that it happens, and in any mature democracy these issues as learnings from a pandemic situation would take place. Whether it really happens in India actually depends on the way things proceed in parliament on both sides. The government of the day will also have to be magnanimous to accommodate concerns of states, and states also have to be in a mood for a dialogue and cooperation.
Thank you. So you support it. And Shekhar, what do you feel? And then I come to the two who are in politics.
Well, we are
Well,
also lawyers. Don't forget that. Manish and I both have practiced law, so that will be, they might.
well, the flavor of the day's politics is devolution of powers, not centralization of powers. Any country that's over centralized, even on pandemic response, has suffered gravely. A very good example is Russia. Russia is today the worst example in the world of pandemic management. Putin, his word is law. He can get you in jail and nobody will know your address for a very long time, right? Uh, do you know how many Russians have had one shot at this point as of today? At least one shot. India has had now 75% today, but how many Russians? Russia is a country much richer than India, much better health infrastructure. Only 34% Russians have had at least one shot. What percentage of Russians have both shots? 31% Russians have had both the shots. If you look at the graphs, in another week, the number of people who've taken one shot and two shots will be the same. What that tells you is that no more than 34% of Russians are willing to take any COVID shot. Why? Because they don't trust Putin's vaccine, right? They don't see Sputnik as a scientific vaccine. They see it as Putin's vaccine. They see Putin as a dictator. In fact, today, the speaker of Russian parliament, who is from Putin's party and Putin's supporter, he himself has made a statement that people don't trust the government, so they don't trust the vaccine. So India is a diverse country, federal country. India has to trust the states. And track record tells you that putting this, centralizing this is no answer, because some of the most laggard states on vaccinations are actually states run by the ruling party at the center. So what is the possibility that Yogi Adityanath's government in UP or any state like that would listen to a Manmohan Singh government of the UPA more seriously if health was on a concurrent list than now when Mr. Modi is the Prime Minister of India? So states have their capacities and states have to build capacities. And state leaders, India's politics is in the states. Real power in India is in the states. The most powerful man in India, most powerful leader is the chief minister of a state. Uh, so if they mess up on their health, they will pay the price for it. So I don't think that you need to tweak this. I don't think directives from the center work. Even if you send directives, no center in India will be so big that they can then make sure that their directives are being carried out. Today, you have a time when even the Supreme Court is struggling that we give bail orders and state governments take 5 days implementing them, right? So now they are putting bail orders on internet, etc., etc. So over centralization is exactly the opposite of what India needs. India needs much more devolution of powers.
Thank you. Thank you for bringing in that perspective.
Otherwise,
Manish,
otherwise the states will just blame the center.
yeah. Manish, your take and your perspective on this. We are running over time. We'll take 4 minutes more.
Well, I think including health in the concurrent list is a good idea, for the simple reason that I did a back of the envelope calculation, and I had written a piece about it. If you want to overhaul India's primary health infrastructure, you require 6 lakh crores. I can, at some point in time, share that piece with you. So, therefore, the states do not have the money to ramp up the primary health centers, the community health centers, which come at the second stage, and number 3, even the district hospitals. They are woefully deficient, both in infrastructure and, of course, doctors is a completely another story altogether. There are no doctors in rural India for the simple reason the cost of medical education in India is so high. And after you've gone through that capitation fee process, even though it is officially abolished, if you have to go and work in some rural hospital, you will never be able to repay your education debts. So therefore, this is a hugely complex problem with regard to the state of our medical infrastructure across the substantive bulk of our country. And so therefore, if the center is able to or is willing to foot the bill, I think you can move it to the concurrent list, because God forbid if you have another pandemic like this, we are woefully ill-equipped in terms of infrastructure to be able to surmount that. Number 2, you see, what Mr. Gupta said is absolutely correct. The response to handling the pandemic has to be as decentralized as possible. Trying to handle it through consequential provisions of the National Disaster Management Act was nothing short of a disaster, and I'll give you 2 examples. A part of my parliamentary constituency is 200 meters from where the Chief Minister of both Punjab and Haryana stay, which is a small little place called Neagaon. So most of the people who work in and around Chandigarh actually have made that their home and habitat. Most of the labor lives out there. There are actually 16 people who are living in one room and who are sleeping in shifts. So therefore, you suddenly impose this lockdown and you lock those 16 people up into a room and you deploy the police outside that will beat the crap out of you if you step out of your room. Are you mitigating the virus or are you spreading the virus? The same was the situation in my erstwhile parliamentary constituency of Ludhiana, where in Jamalpur, the migrant labor, if you actually look at the way they stay, it'll bring tears to your eyes. But a sensitive deputy commissioner would have known how to handle this in the best possible manner, or even better, an SDM would have known how to handle it. But since you had these draconian instructions coming top down, which had to be implemented, you had a very curious situation on your hands whereby you were facilitating the spread of the pandemic rather than trying to contain it. Similarly, now the pandemic in Punjab originated from one of the villages in my parliamentary constituency called Patlawa in the subdivision of Banga, where the first death of this preacher who had come back from Canada or somewhere occurred. Now, shutting Patlawa down made sense You could actually put a micro containment zone in place and shut it down. The next village from Patlava is 5 kilometers away. It maybe made sense shutting that down, but shutting the whole district down, which was completely virus free at that point in time, what sense did that make? So therefore, in fact, these should be the lessons learned, that in a vast country like ours, you should actually leave it to the administrators on the ground who will be best able to deal with it. For example, you started announcing that curfew will start at 7 o'clock in the evening. Now, in summers, 7 o'clock in the evening, the sun is right out. I mean, getting people back into their homes at 7 o'clock meant that the whole district police had to be deployed with their lathis to beat them up to get them back into their homes. So, I mean, it was bizarre. And I'm just giving you anecdotal incidents of how this centralized management and even the centralized health management, frankly, Dr. Mahajan, with great respect to the doctors, and I have grown up on the campus of PGI Chandigarh, the ICMR did not cover itself with any glory in the manner in which it has been handled. In fact, the role of some of these organizations need to be seriously examined by parliamentary committees.
Thank you, Manish. And now the final word to you, Nalin. What is your response to this question?
It certainly requires more study because as a principle and as an advocate, I feel that to shift away what's on one list, which is the state list, to the concurrent list, is definitely going to lead to an argument of centralization, and it's going to lead also to encroaching in terms of the power of the state to some extent, because it's not a complete thing. The concurrent list only where there's a redundancy or there's a conflict, which means something that the center proposes and the center will prevail. So it requires more discussion. But in a pandemic, maybe a way out is that in situations like this, which are unprecedented and of a completely global or a complete national character, maybe a legal architecture can achieve some kind of provisions that helps the center step in to bring a uniformity of approach. Otherwise, at the moment, it's pretty divided. For example, health is purely in the state subject, the state list, it's entry 6, but health education comes into the concurrent list, but setting the standards for higher education, which includes medical standards education, is in the central list. So therefore, I think this is a good topic for further discussion, and more work is needed.
Thank you very much. We've overshot.
Dr. Mahajan,
yes,
I'll just leave you with
Manish, please.
just leave you with a thought. You see, why a legal architecture is important is for the simple reason: how is the principle of triage to be employed? Are there any SOPs that in a situation where a hospital is overwhelmed, what are the guiding principles for applying the doctrine of triage? There are none. So therefore, I think the pandemic has provided us with an opportunity, rather than belabor under hubris once again, because we've achieved a particular vaccine number, to really think through some of these serious issues and come up with an architecture, both administrative, legal, as well as medical, in order to mitigate such contingencies in the future.
Thank you very much. I must say we've had a very, very exciting and useful debate. Most of you were on the same page. There is no doubt that we have learned a lot. And to your point about micro-containment zones, that's the way that containment is being done now. When we started, probably we didn't know better, and we've learned from it. I'm sure as we analyze the last 18 months, which is very, very important, look at the data, there would be many more learnings for the future. And I'm sure most of all 4 of you would be part of these deliberations and help in formulating policy and the way action is to be done in the future. I thank FICCI for giving me this opportunity. And I thank all four of you, stalwarts. Yes,
Can I
Shekhar, have the last word.
just add to what Manish said? The states don't have the money for all this. Center should give the money. States will have the money if they stop giving free power, including your state, where the new chief minister was just seen making a bonfire of electricity bills. So unless that pandemic stops in India, center can't keep printing money and helicoptering it to the states. States have to become more responsible.
That's true. I mean, fiscal prudence is something, which needs to be equally applied by state and central governments. And so therefore, I mean, I don't think there is any quibble with that.
And just to the Shekhar's point, when he said, the Putin example, I just want to make a point. We were talking about bringing it to the concurrent list, not the central list, and thankfully in India, we have a robust democratic system. So any prime minister, the next after that, hopefully will not be in the mold of Putin. So I don't know if the Putin example comparison really works.
Thank you all very much. And let's hope that health gets the focus it deserves and also the money it deserves. Because without that, we will be left holding the can just as we did. Manish, you wanted to say something.
No, I was only saying, I mean, we can go on and on, so therefore we might as well close it. It's, a concurrent example to Putin is how badly Brazil and Bolsonaro, if I pronounce the name correctly, has handled the pandemic in Brazil. So therefore, if you look at authoritarian leaders around the world, you would find that the more authoritarian they are on a scale of 1:10, the more disastrous has been their handling of the pandemic.
Thank you. I think finally we close. Over to you, Praveen.
Thank you so much.
For your final comments.
Thank you so much, Dr. Mahajan. It was actually, the most visited, I would say, session and most heard session. So thank you so much for making it so very interesting. Stay safe, stay healthy, and thank you so much once again for joining us.
Thank you.
Thank you all. Thank you.